take the dais. Dr. Amit Gupta is with us. He's a renowned diabetologist from Noida. Please, sir, join the stage. Without further ado, we'll be starting the paper session. For first presenter, I would request Dr. Jayakrishnan to come over the stage and start his presentation. Your slides are there. We'll be very quick. We'll be giving 5 minutes for the presentations, 2 minutes for the question and answer session. And we request you to be precise because the marks would be carrying for the time of the presentation also. Thank you. Please.
Good morning. I'm just presenting a publication, a cross-sectional study on satisfaction with teleconsultation in people with diabetes during the COVID-19 pandemic in semi-urban and village parts of Kerala. The coronavirus pandemic had pushed both doctors and patients to adapt to teleconsultation for routine consultation in management of type 2 diabetes. And telemedicine can overcome the distance and location barrier and further enable high-quality healthcare services, thus benefiting the patient located to remote areas of the country with limited accessing to doctors. The patient satisfaction with telemedicine is an important research focus because it is a critical aspect of quality of care and health outcomes and assessing the acceptability of the services. The study aims to assess the patient satisfaction with diabetes management through teleconsultation in these semi-urban and village parts of Kerala. And it is a cross-sectional study with a duration of 6 months conducted at Self-Care Clinic in Thiru, Kerala. Sample size was 163 people with type 2 diabetes, aged more than 18 years who availed teleconsultation services were included in this online survey, and patients who are not willing to sign a digital informed consent were excluded. And this online survey was based on a 12-item questionnaire developed by the author and adopted from the telehealth usability questionnaire. And statistical analysis was done using the SPSS tool, and patient identity was always kept confidential. And the age distribution, majority of the teleconsultation occurred in the 41 to 60-year age group, and the quality of discussion was poor for 2, good for 55, and excellent for 90 patients. And personal comfort using a teleconsultation was poor for 2, excellent for 63, and excellent for 85, and good for 63. And the patient satisfaction and duration, the explanation provided, audio, video, and overall experience was poor for 1.22%, fair for 4.9%, good for 49.69%, and excellent for 44.1%. And the patient preference for teleconsultation, 158 people were preference for teleconsultation again, that was 96.93, and 95.09% was recommended teleconsultation to friends and family, and 60.12% preference for teleconsultation once the COVID-19 pandemic goes back to normal, and 7.97 patient was not happy with the maintenance of confidentiality. They had some doubt, but 92.02% was happy with the maintenance of confidentiality. And the summary of advantages and pitfalls in teleconsultation: easy accessibility to diabetes care, early detection and treatment of diabetes and complications, provides individualized health information, enhances decision-making to clinical management, increases awareness of diabetes through education, facilitates remote monitoring and information delivery, availability of diabetes care facility at doorstep. And the pitfalls are poor internet connectivity, and villages, most of them does not having smartphone, And elderly patients have a degree of deafness and poor sight, resulting in challenges with understanding. 2 patients were more than 8 years old in the study, and disturbances, background noise, or disturbance resulting in poor communication, interference issues and technical issues, security and privacy issues while assessing patient data over the internet. And the majority of the patients are satisfied with the teleconsultation that have become the norm during the pandemic. The quality of conversation, the explanation of their condition, and the time provided are rated as excellent by most of the patients, which is gratifying in those tough times for humankind. And policymakers and healthcare providers should be mindful to accept the advantages of delivering care through virtual mode in this digitalized world, and should encourage the development of policies and guidelines on the subject in an urgent mode to support the update of telemedicine in an excellent manner. Thank you.
So how did you do it? It was a survey you conducted. How did you do it? What was the methodology?
During pandemic period, I was already doing teleconsultation.
How did you do it? What
Follow.
methods you used?
One is using my website. The second one was using with this WhatsApp media.
Right.
Yeah.
So you collected the data, whatever data you must have collected, you collected from
No, we have sent a questionnaire through Google Form.
questionnaire. So your methodology
through
included
Google Form
a questionnaire.
To the patients who have already attended, I have mailed to 500 people. Out of that, we have selected 168 according to the inclusion criteria. So more than 18 years is the time to die.
So what are the, what for finally you would like to say at the end of your questionnaire, that what is the benefits, or do you recommend or you do not recommend? What are the final conclusions?
Pardon?
What would you suggest then? Do you recommend that teleconsultation be given as a methodology as per your study?
Yes, actually it should not be away from the physical examination and direct. It is not a substitute. But for follow-up, definitely it is excellent manner, because most of the people, they don't have to cut short, or they don't have to take a leave, or the children don't have to take leave to take their parents to the doctor, and connectivity is easy. Anytime they can contact the doctor.
But the pandemic was a special situation.
Yeah. Yes.
In non-pandemic situation, is it valid? Because what is the current scenario of teleconsultation presently? Are we allowed to have teleconsultation as per the Government of India guidelines?
They have some restrictions in Kerala. Those who are within 60-kilometer radius, and those who had a direct consultation during the past 60 days, they can come for teleconsultation for follow-up. That was the norm. The Kerala is followed.
So they can only come if they have given in written a consent that
Yes.
I want to take a teleconsultation as per the government guidelines. Okay.
Thank you, Dr. Jagrishan. You can move to your second presentation. Yes.
Thank you.
Second presentation, please. Second.
He is the second presenter, so please put on his slides. So we'll start, once the slides are on, we'll start the second session.
Dr. Jagrishan, I would like to ask one more thing. Do you find any difference between video consultations and only the audio consultations?
Video consultation is better, because we can see the patient's expressions, how they feel what we are talking about, and we can take back, and accordingly we can. Because diabetes is the second one I am coming. Good morning. Shall I start? Yes, a cross-sectional study on prevalence of diabetic distress in people with type 2 diabetes and its clinical determinants in semi-urban and village populations in Kerala. The diabetic distress is the emotional distress resulting from patient concerns about disease management, support, emotional burden, and access to care. Diabetes distress is closely linked with diabetes-specific biological and behavioral variables, and reflects distress resulting from the burden of illness and treatment. The diabetic distress can be measured across 4 domains, which include physical related distress, emotional burden, interpersonal distress, and regime distress. The study aims to determine the prevalence of diabetic distress and its clinical determinants in people with type 2 diabetes in semi-urban and village populations in Kerala. It's a cross-sectional study conducted at Safecare Clinic in Tirur. Duration of study was 6 months. Sample size was 260 people with type 2 diabetes who are more than 80 years of attending outpatient department are included, and patients with type 1 diabetes, pregnant women, alcohol or drug dependence, chronic medical or surgical illness other than diabetes were excluded. Diabetic distress screening scale was used for screening purposes, and patients with an average score of more than 3 or a sum of the tool more than 6 were screened positive for diabetic distress and subject to DDS-17 questionnaire to determine the type of diabetic distress. And among 260 patients included in the study, 62.3% were female and 37.6% were males. And the mean age of the study population was 56.8 years, and most of the cases were in the 41 to 60 years of age group, and the average duration of diabetes was 9.25 years. A total of 65.7% had diabetic distress. Among them, 57.5% had severe distress, and 9.5% had moderate distress, and the emotional burden dimension had the highest score, that is 85.3%, followed by interpersonal distress of 73.6%. And the results, there was a correlation between the level of education, duration of diabetes, HbA1c level, and diabetic distress, and were the main predictors of DD in our study. And it is a head-up diabetic distress is real, and we have to continue diabetic education. And the conclusion is a serious problem that affects people with type 2 diabetes. It is necessary to address diabetic distress in patients for better glycemic outcomes. And focusing the attention on clinical predictors of diabetes distress and screening patients with diabetes is an effective method for HCPs and patients to improve their disease management. Thank you.
Yeah, very well presented. Just wanted to ask how you analyze the diabetes distress, which scale did you use, and how it would be from the depression DSM-5 criteria? Or how many actual population came out to have depression with diabetes?
I have used a DDS 2 score as well as DDS-17 score. It is having 4 subgroups, and with the help of my staff.
This is the questionnaire which you filled, and
Yes.
what was the analyzing criteria? So, a 5
Yes. Yes. Will score more than 3
Yeah.
for DDS-2, and more than 6, the sum of more than 6.
because there's a huge number coming out for a diabetic distress. More than 50% of the diabetic patient came up. Anything, you also tried using the standard criteria of depression also. Any data regarding that?
This score I have not used.
Okay.
So what do we exactly, when we say diabetes distress, how do we define it? We need some proper definition, no, when we are doing a study like this is the diabetes distress which I am going to look into. It may be anxiety, it may be depression, it may be something else. So is there any such definition, or it's a, is this terminology used previously? Is it a standard terminology, diabetes distress, or is it depression in diabetes?
No, this study analyzed only the distress, not depression. That's why I have not used this score.
So that's what I'm saying.
Yes.
So what do we understand by the word diabetes distress, if you have it in
Actually,
your
even though the
exact
study came out like this,
definition of the, because you will have to study that.
Actually, the underground motto of the study was, yes, I wanted to know, even though this was presented in this way, I wanted to know whether the people were happy with my
So the tool that you have used is?
DDS-2 and DDS-17.
Yeah. So that is for scoring of what disorder?
Distress of the patient, distress because of the regime, distress because of the
Okay.
caregiver, the doctor. Actually, I want to analyze myself, but
Right.
even does this study.
So what will be the final utility of outcome of our study? What?
Diabetic distress is real, and we have to overcome by giving more education to the patient, their relatives, and the society as a whole.
Fine. Thank you.
I think distress is a very, very important point, and often it is missed in patients. And distress is often missed in patients. Diabetes distress, patients, we often miss that. And it is the burden of the diabetes that itself brings to the patient.
Yes.
It may be related to anything.
Caregiver is looking special attention to that, most of the time we will miss. And that might be
Yes.
one of the reasons that they are not adhering with the treatment. Because the regime what we are putting might be.
Thank you. Thank you so
Thank you
much.
very much. Thank you.
Do we have the next presenter? Vishnu Shivam. Mr. Vishnu Shivam. Dr. Ankita Mandal. Yes, Dr. Ankita, please. Do we have Dr. Him Shikhar Khatneyar? Sorry. The next presenter, Dr. Him Shikhar Khatneyar. He is not there. Dr. Kashish Malhotra. Dr. Kotha. Dr. Divendu Bhushan. Dr. Kotha is there, right?
You be ready. Be ready. We'll be, if there is something to do next.
Good morning, Vishakhapatnam, and good morning, judges. I'm Dr. Ankita Mandal, ex-senior resident from Department of King John Medical University, and Department of Residence. So this was my paper published recently in May 2022, a cross-sectional study to determine the psychological distress among pulmonary tuberculosis patients during the COVID-19 pandemic. It has been already published in Monaldi Archives of Chest Disease. So we all know COVID-19 pandemic has outstretched the anxiety and concern in the overall society from each and every aspect. Coming to the tuberculosis program, we know we have planned to end the tuberculosis program in 2025. This is a picture taken from the Delhi TB Summit 2013, where we have, the WHO head, Modi ji is there, and he is planning to end the tuberculosis by 2025. But in between, what we got is COVID-19 pandemic, which has caused a hazard. It has dropped the notification rate in overall all the nodal centers in India. And while going through the study, I will come across the notification data in our center also. So mental health issues are the other major health concern that we have faced during the COVID-19 pandemic. And especially in cases of tuberculosis, where the patient is already taking certain drugs like glycosidine, and all the drugs which are predisposing for psychological distress. This is one stand that we have to take. We have to create awareness for those patients so that that can be addressed properly. Now this picture, which is given alongside, this shows that initially when COVID pandemic came, the baseline notification was dropped. The blue negative trigger shows there's a drop in notification. But what analysis the Global TB Report 2020-22 has done, that ultimately it's going to get rise when we get to find out the data afterwards. So these are the data which we can see in the latter year it's going to rise. Because most of the people, they didn't visit their centers, they didn't take their medication, they didn't came for the DRTB centers for their initiation of regimen. So this is what is going to happen afterwards. Coming to the aim, this was a study done to assess the psychological distress among pulmonary tuberculosis patients during the COVID-19 pandemic. I have 4 main objectives. Number 1 is to determine the anxiety related to COVID-19 among pulmonary tuberculosis patients. Number 2, to estimate the level of depression during COVID-19 pandemic among pulmonary tuberculosis patients. Number 3 is to determine the fear of COVID-19 pandemic among pulmonary TB patients. And the 4th one is to estimate the number of new case registrations of pulmonary tuberculosis in COVID-19 pandemic as compared to the previous year when there was a non-pandemic phase. This is a single-centered cross-sectional observational study performed in King George Medical University with collaboration with Department of Respiratory Medicine and Department of Psychiatry. What we did, a questionnaire-based interview and a retrospective analysis of the record of the previous year, non-pandemic year, was undertaken, along with the verbal and the written consent of the patient involved in the study. Alongside is the flowchart, how the study was done. This one, so all we have taken is 361 patients for the analysis, because what we have assessed, among the 382 patients, 21 patients has already expired while taking their ATTs. So they have we have considered the inclusion and the exclusion criteria, and we have subjected the patient to the questionnaire. So what were the questionnaire that we used for their study? Number 1 was to assess the anxiety related to COVID-19. It was designed by D. Roy et al. So this is an Indian questionnaire which was used during the COVID-19 pandemic for the patients in the Indian population. Now another one was patient health questionnaire. This was to assess the depression of the patients. And the third one, it is taken from Mark D. Griffith et al. The fear of COVID-19 or FCB-19S questionnaire, specially designed for the COVID-19 pandemic. I'm not going through the details of the questionnaire. These are just the picks. 5-point Likert scoring was used to assess the anxiety of the patient. This is the patient health questionnaire along with the fear of COVID-19 pandemic questionnaire. Coming to the data. Now, what I got in my result was most of the male patients were drug susceptible. Coming to the demographic data, most of the male patients had drug susceptible tuberculosis, while that female patient have...
Dr. Ankita, sum up the study, because the time of presentation is finished.
Ma'am, the main thing was like female patients were more predisposed to drug-resistant tuberculosis than male patients. The age group of 18 to 13 years have more predisposition of tuberculosis, that too drug-resistant rather than drug-susceptible tuberculosis. Drug-resistant persons had delayed in initiation of treatment rather than drug-susceptible tuberculosis. Coming to the anxiety or psychological distress, fear was one of the prominent factors. Now, about 23% with a significant p-value had fear. And out of that, most of the patients who had history of COVID-19 pandemic, they had highest amount of anxiety, and the patient who didn't have any history of COVID-19 infection or history of COVID-19 infection among their acquaintance, they had a higher amount of distress. Now this is the data taken from our center. In the initiation in April 2019, when COVID-19 was not there, the notification was 600 cases in our center. But at the mid of 2021, that is March 2021, when there is an starting of...
Thank you, Dr. Ankita. Any question, ma'am?
So there was a fear of COVID-19 pandemic in this. So what is the utility? Like what will be the outcome? What steps would you like to think would help to overcome this?
Ma'am, most
Because we do some
importantly-
study to have some use. Otherwise, of
Yes,
course,
ma'am.
fear was there in all the people,
In
whether
all
they
the
were
patients.
diabetics, they were tubercular
Ma'am,
being pulmonary.
Yes, drug
More so?
resistant, most probably, mostly drug-resistant tuberculosis patients, they are already taking drugs which are predisposing fears and anxiety disorders like cytosine and other drugs. So we need to counsel the patient that this is because of the COVID-19, not because of the drug. So you can continue your drug. We have to analyze that whether it is because of the drugs or after withdrawing the drug, whether the fear was persistent during the COVID-19 pandemic or not. We have to see that, and we have to address that and ask the patient to take their drug and continue their treatment.
Was there any fear of not getting the drugs because of the COVID-19
Yes,
pandemic?
ma'am, that is.
That was,
there
I
was
did
a
not
fear
see that in that, because not getting drugs for a tubercular patient becomes very important,
That was a
especially in the
fear.
pandemic. So that fear
a
was there?
Yes, ma'am. There was a delay in initiation in drug-resistant tuberculosis. Most of the patients who were unable to get their drug or initiate their regimen at the proper time, about 66% of the total subjects had delay in initiation. So they had significant amount of anxiety too, relating the starting of their regimen.
So was that included?
Yes, ma'am, it's included.
It was included. Fine. Okay.
Thank you. Next. Dr. Kotha Wabishi, Dr. Himshikar. Dr. Himshikar is not there. Dr. Kashish Balotra.
A request to all the presenters, please stick on time. There will be 5 minutes for your presentation and 2 minutes for the discussion. You get marks for being on time.
Good morning, everyone. I am Kashish, and today I am here to present our research on global and gender equity in reproductive health research. With increasing recognition of the lack of research capacity as a primary determinant of poverty in middle and low-income countries, where over 80% of the world population lives, there is a need for equitable and supportive research partnerships worldwide to aid resource-limited settings. However, to date, there are no studies which have quantified the difference in global research about reproductive health across resource-rich and poor countries. So we, for the first time, aim to quantify the total number of publications, citations, and mean citation per publication per researcher for several reproductive health conditions. We also aim to evaluate the geographic and gender diversity in male and female reproductive health research. We used a broad search query to extract all the publications related to reproductive health using Dimensions API, which is a scholarly search database indexing PubMed, Google Scholar, directory of open access journals without any language or time period restrictions. We also subdivided our study into female reproductive health conditions and male reproductive health conditions. The female conditions included were endometriosis, pregnancy, female sexual tract infections, polycystic ovary syndrome, female infertility, breast cancer, ovarian cancer, and endometrial cancer. Similarly, male reproductive health conditions included were benign prostatic hyperplasia, male sexual tract infections, male infertility, testicular cancer, and prostate cancer. Additionally, we also identified the top 1,000 most published researchers of reproductive health, women health, and male reproductive health research. We classified the researchers according to their country of practice into high income, middle income, and low income countries according to the World Bank report. Network analysis was done to contextualize the research, and density visualization helped us to identify the most impactful keywords. To study trends over time, overlay visualization of the extracted studies was also done. To study collaborations, link strength co-authorship analysis was done. Gender of the researchers were established with 95% probability using NAMESOR API, which is a machine learning algorithm and has been previously used and studied in the scientific literature. Coming to the results, we noticed that there is very limited geographic participation from the African and the Central American countries across all the conditions, which highlights the global inequity. However, when we studied the overall trends from 2000 to 2020, we noted that there has been increasing involvement of researchers from low and middle income countries, including Botswana, Lebanon, and India, which is the positive side. Overall, LMIC researchers, that is low and middle income researchers, had lower number of total publications, total citations, and mean citation per publication per researcher as compared to HIC researchers. Interestingly, on individual specific analysis of similar male and female specific conditions, publications related to female reproductive health were less in number than male reproductive health conditions. For example, HIC researchers of female infertility had lower total publications and total citations than HIC male infertility researchers. Similar trend was also seen in endometrial cancer versus prostate cancer. Also, we noted that low and middle income country researchers faced difficulties or had lower collaboration opportunities. For example, HICs had statistically higher link strength for female reproductive health research, male reproductive health research, and overall reproductive health research when compared to the low and middle income country researchers, and it was statistically significant. Though overall extensive inter-researcher collaboration was seen in the publications, as we can see in the cluster of researchers and the density visualization, but as studied previously, this inter-researcher collaboration did not transcend the geographical borders and extensive global disparities were noted. We also found that female researchers faced difficulties or had lower collaboration opportunities. Only 26.1% of the reproductive health researchers were female, and male researchers had statistically higher total publications, citations, and total link strength than female researchers, which means that male researchers either had higher collaboration opportunities or more ease with which they can collaborate. On the bibliometric analysis, we found the top keywords, which were contraception, fertility, population, pregnancy, and the developing countries. And whereas when we did the bibliometric analysis with the log modularity, we found the emerging keywords to be machine learning, birth defects, developing countries, animal research, assisted reproduction, and health policy. To conclude, our study found that there are huge global and gender disparities in reproductive health research. Female researchers and LMIC researchers face difficulties in collaboration with other researchers or had lower collaboration opportunities. Though in the recent years, progress has been made to ensure global diversity, which can be seen by actively involving researchers from several low and middle income countries, including India. In the end, I would like to state that forming academic institutes and strengthening the existing universities by partnership with HICs need to be prioritized to increase the quality and impact of research done in middle and low income countries. Thank you.
Very good. Just wanted to ask what inference you want or a message you want to convey.
From this study, we want to give the message that females, especially if they are from low and middle income countries, they are at a disadvantage of collaborating with other researchers as compared to their male counterparts. Also, low and middle income country researchers are also at a disadvantage in collaboration when compared to other high income country researchers. Beyond that, we also identified the key upcoming keywords via the bibliometric analysis using lean log modularity of normalization, where we found that the emerging trends were artificial intelligence, obesity and infertility, and so on.
You are a student of internal medicine or community medicine?
I am student intern at Diabetic Medical College, Punjab.
Right. So you had a very important point that the research done regarding male-related reproductive health issues is more than female. So what was the possible reason for that? You must have looked into that.
Ma'am, for endometrial versus prostate cancer, we noted that prostate cancer had a higher, somewhat higher prevalence and higher mortality as compared to endometrial cancer. So for that, it could be explained. But for female infertility conditions, when female infertility research was less than male infertility, we noted that they had similar prevalence, like 50-50%. So that was a surprising result, and it needs to be looked further and needs to be quantitatively assessed to promote global equity.
Okay. Thank you.
Thank you.
Could you find any reason for this disparity and anything which can be addressed to address this gender inequality?
Sir, the lack of collaboration is certainly one point because, as we noted, that female researchers are at a disadvantage in collaboration, and the same can be said for low and middle income countries. I think it is one of the main point. Though extensive inter-researcher collaboration was seen, as we have seen, there was in the clusters. There were more than 71 clusters here. So though inter-researcher collaboration is very high, it is clearly shown that it doesn't transcend the geographic borders, and it hasn't spread to the middle and low-income countries in that aspect.
These were just individual small research, or they were research funded by some, the variety of research? What was the criteria of looking at? The research was including all funded research also, like the ICMR and all those things, the funding globally?
We included all those public.
Or these were mainly because that also needs to be looked into, how much funding by a particular nation goes into a male reproductive research and a female reproductive research issues. So did you look into that?
Yes, ma'am. It is part of our research. For this one, we included all the journal publications. This one is work in progress about the funding. And we also noted that, like in India, we have done analysis of funding, where we noted that only ICMR was the leading funder of AIMS. And in fact, even for PGI.
ICM is the lead, it's the lead funder for most of the disorders, but was there a disparity in the ICMR funding? Or I would not name any particular agency. Anywhere globally, was there a disparity noted?
Ma'am, it is still a work in progress, but from my experience, not from my experience, but from my previous research, there we noted that there was high-income countries were inherently at an advantage when compared to funding as compared to lower and middle-income countries.
Okay, thank you.
Thank you, ma'am. Thank you.
Next presenter, Dr. Kotha. Vamshi Krishna Patel.
Good morning, everyone. Today we are going to see an interesting case report of a case of secondary FARS syndrome mimicking meningoencephalitis with neuropsychiatric manifestations in a patient. And myself, Vamshi Krishna Patel, PG resident from AIMS Patna, and my moderator being Dr. Divendu Bhushan, Associate Professor, AIMS Patna. And coming to the case, basically FARS syndrome is basically idiopathic basal ganglia calcification. In our case, the patient presented with features suggestive of meningoencephalitis with neuropsychiatric manifestation, and we are going to describe it in the next following slide. Coming to the background, hypoparathyroidism refers to a defect in either secretion or the effect of the parathyroid hormone leading to neuromuscular hyperexcitability, and FARS syndrome is characterized by bilateral basal ganglia calcification. And hypoparathyroidism is one of the most common cause of FARS syndrome, that is bilateral basal ganglia calcification associated with hypocalcemia in the patient, and the most common association being hypoparathyroidism. When hypoparathyroidism is coupled with basal ganglia calcification, secondary FARS syndrome is established, and the primary FARS syndrome being the familial variety. Coming to our case, basically the history being a middle-aged woman with generalized abnormal body movements for last 2 months, and poor oral intake, generalized weakness and fecal incontinence for past 1 week, and altered sensorium and fever for the last 5 days. And she is a known case of seizure disorder for last 20 years, and a known case of DCMP with an EF of 35%. She was taking levetiracetam, valproate and digoxin for her seizure disorder and DCMP respectively. Coming to her examination, CVS examination was unremarkable despite her DCMP status previously, and neurological examination revealed neck rigidity and restricted side-to-side neck movements, along with normal tone and global hyporeflexia in the patient. She had abnormal body movements involving the entire body, mimicking seizures mostly on initiation of activity without any loss of consciousness. Meningoencephalitis was our initial DD, and it was suspected, and before proceeding to a CSF study, we had gone for NCCT brain, and it revealed bilateral symmetrical basal ganglia calcification suggestive of FARS syndrome. And her serum calcium was low, and hyperphosphatemia and normal vitamin D levels were noted, and her corrected calcium for albumin, and her blood gases were within normal limits. And her CT findings in the background of neuropsychiatric symptoms along with hypocalcemia, hyperphosphatemia and low PTH consistent with hypoparathyroidism. A provisional diagnosis of FAR syndrome was established in the patient. Coming to the unique features of the case, her neck rigidity was due to the abnormal spinal ligament calcification secondary to FAR syndrome due to hypoparathyroidism in the patient. And movement disorders can be misdiagnosed as seizure disorders in such patients because hypoparathyroidism causes hypocalcemia that may contribute to the neuronal hyperexcitability which may mimic the seizure episode in the patient. And hypocalcemia correction plays an important role in seizure termination rather than any anti-epileptic in the patient. Her DCMB status was also found to be a fallacy as her 2D echo review revealed normal findings that might explain the fact that hypocalcemia led to global hypokinesia previously, which got markedly improved after calcium correction in the patient. Coming to the NCCT head findings in the patient, it reveals bilateral basal ganglia calcification in the patient. And the most important take-home message from my case report being FAR syndrome secondary to hypoparathyroidism, a rare disorder resulting in bilateral basal ganglia calcification, and hypocalcemia leading to movement disorder in the patient. This can be treated without any anti-epileptic in the patient. In our case of apparent epilepsy and DCMP were treated without anti-epileptics nor any heart failure medications, but with basic elemental calcium, and that's how we would like to welcome everyone back to basics. Thank you.
Yes, this is a very common thing which is seen that many a times status epilepticus is considered to be their patient is taking some 3-4 anti-epileptics and the serum calcium has never been done. Because if you do the serum calcium, it comes in the range of 3, 4, 5, of total primary hypoparathyroidism leading to severe hypocalcemia, and once calcium is corrected. So what did you do in this? What did you proceed? How did you proceed?
We managed the case using calcium gluconate. We used to give like 3 to 5 ampules of calcium gluconate in D5 over 2 hours for, in a TDS dose manner for initial 2 to 3 days, followed by around 3 ampules, and we have gradually tapered over next 5 days.
So now, afterwards, what do you have to do?
Active desupplementation we can proceed, ma'am, in this case.
We can proceed, or you have to give a calcium supplement?
We have to give active.
How much?
Usually, in our case, we have managed it using 0.5 microgram per day.
0.5 microgram calcium.
Active D3, ma'am.
Okay.
Active.
And, okay.
Calcium.
Do you not have any video of that patient, the presentation you did not add? This is a paper, this presentation, you could have added a video. That would have been very useful.
Basically, I thought like we have to present only slide and.
Okay, fine.
It was consistent with hypoparathyroidism, like low PTH. Hyperphosphatemia.
You just mentioned you only corrected the calcium. But maintenance, because you are saying it is a primary hypoparathyroidism patient presenting as power, so you need to supplement the D2 levels also.
Supplement?
Alpha calcidol also along with this to maintain the calcium levels. So that
in our case, we have managed using calcium supplementation, 1000 milligram TDS dose, and active D3, 0.5
Yeah, that's what I was saying. You have to supplement the, and how long?
Lifetime supplementation, obviously.
We have with us Maheshwari sir. Sir, we would like your input on the topic.
P.K. Maheshwari sir is has keen interest in neurology, renowned neurologist. So we can have questions from the floor also because we want to keep it interactive. So if you have any question regarding the presentation, you can ask. Please place a mic in the audience also.
And whether it's a generalized or in one limb only?
It is generalized, sir.
Generalized. Okay. When you have infused that calcium What was the response?
Tetany will usually disappear.
Disappear. In
Even-
your case, when it responded,
Basically, after giving the infusion, even after the first dose, we have noticed improvement in the patient. So we have proceeded with TDS infusions.
okay. Subsequently, you have done the EEG or also or not?
Sir, EEG was done in the patient and it showed periodic burst potentials in the patient.
Periodic pulse potential. Then followed up.
Sir, एक साल के बाद after
Well, it's
one.
quite common in the FAR syndrome.
Sir, pardon?
In the FAR syndrome, it's quite common.
It is not that common, sir.
Not common.
FAR syndrome is not. Idiopathic basal ganglia calcification might be common, but FAR syndrome is not.
Because we find out the idiopathic calcification in quite commonly.
We can find in certain, around 5 to 10% of the CTs, we can find bilateral
But
basal.
that does not correlate with a tetany.
That doesn't correlate with any biochemical abnormality in the patient. But if at all it is combined with hypoparathyroidism, then FAR syndrome, secondary FAR syndrome is identified.
Okay.
Judicious. We must calculate the proper dosing of the calcium.
Basically, there is very limited data regarding the management of FAR syndrome with status epilepticus in the patient. Because in our case, she was already previously labeled as a case of epilepsy and was on multiple seizure medications, and no proper control was achieved. And as the patient had fever, altered sensorium along with neck rigidity, and these things in the background of hypoparathyroidism leading to FAR syndrome, leading to the calcification in the nuchal ligament, we were also in a diagnostic dilemma initially, and we wanted to proceed for a CSF study. in the patient.
My question is very simple. When you came to know that he is a case of hypocalcemia, how you calculated a dose of the calcium? How to infuse? How much to infuse?
Usually the replacement levels will be around 3 to 5 gram. Orally we can't be supplementing the dose which is required to replenish the CSF ionized calcium levels in the patient. So obviously we have to go for intravenous calcium loading, but as the half-life of calcium gluconate intravenously is very low, the better sustainability is achieved with continuous infusion rather than a stat bolus doses in the patient.
Thank you. Thank you very much, Dr. Kota. I think the message is very clear. Thank you.
Thank you.
Do we have Dr. Divendu Bhushan?
A very good morning to everyone and respected chairperson. My topic of presentation is we did a audit of admission and discharge processes in the medical intensive care unit. So this is very important in our scenario because ICU care is needed to most of the patients, and we have too much of backlog. We generally refuses admissions for around 3 to 4 patients daily from a tertiary care center, that we don't have any beds in the intensive care unit. So there is a huge gap between the demand and supply. So American College of Critical Medicine has developed a priority setup of the admissions in the intensive care unit. ICU are planned for critically ill patients, and there is a huge gap. And various societies has made the guidelines for admissions but how these are implementing, and on the actual forum, how they are implementing in the institute, this is not done anywhere. And this is very important. So these are the categories: priority 1, 2, 3, 4, 5, and these are the criteria: criticality. Do we have any pointer? Do you have pointer? So we can see that there is five divisions: criticality, stability of the condition, intense monitoring, intensive therapy, and reversibility. So in the priority 1, it is the classical indication of admitting the patient in a ICU. ICU equipped with all the things, especially the ventilators. So there are various categories of the ICU also, ICU, HDU, and so in priority 1 there is a critically ill patient who was unstable. He required intensive monitoring and intensive therapy, and reversibility. This reversibility is required. That can be reversed. So these are the priority 1, like ARDS, DKA, acute liver failure, thyroid storm. In category 2, the patient is generally quite sick, but the intensive 3 may be required. Those are not that sick patients, like GI bleed, drug overdose, or seizures. In category 3, priority 3, the patient is critically ill, the condition is unstable, he requires intensive therapy, but the reversibility is not to be said, like those patients who have COPD and had exacerbations, or cardiac tamponade patients who are underlying malignancies. Category 4, those are seriously ill patients. They are stable enough, and the condition of the reversibility is there. So like stable decay, type 1 diabetic with recurrent admissions of diabetic ketoacidosis. And category 5, those are terminally ill patient, and the reversibility of the condition is not there. So like extensive stroke, brain dead patients, these are the category 5. So objective of our study is to determine the current effectiveness in our admissions and discharge policies with standard ACCM guidelines. So methodology, we take the retrospective, it is a descriptive, retrospective, record-based study. We did it for the 6 months. We take out the record of 6 months, and we took out about 355 patients' records. So how was the result? You can see here that in the gender distribution, males are more, as the admissions of the males are relatively more. Average age is around 54. Average length of stay in the ICU is about 6.11. Now you can see the admissions in the ICU is more from the ward, not from the emergency. This is the huge difference. So we admit sick patients in the ward because we don't have beds in the ICU, and when they become more sick, then we shift them to the ICU. Now you can see that most of the patients, of all the admission patients, priority level 1 patients were the most. Still they are 40% only. And rest are the 60% are priority 2, 3, 4, and 5. This is the diagram. Now, in the association of the length of ICU stay across the priority level of the patient, you can see that the priority level 1 has lower length of stay because they stabilize, their condition is reversible, so they stabilize more early, and then they can be discharged or they can be shifted back to the ward. So there is the p-value is less than 0.01, so this is quite significant. And association between the priority level of the planning of discharge is unplanned and planned. In a planned way discharge, in an unplanned way discharge, we included the deaths also. So unplanned discharges, you can see that in the priority level 1, it is quite high. It is quite high. Despite that, there is only 20 mortality. We unplannedly discharge them because unplanned means they are still on the vasopressor support, or some type of oxygen supplementation is going on. Now, outcome of the patient in priority level 1, 85% of them are transfer out, and in the category priority level 5, you can see that most of them, about 75% went lama and death. This is a bar diagram, and now the result in the discharges and lama, you can see that
you will have to sum up. Your time is over. Please kindly sum up.
This is the 2 minute.
No. For 5 minutes already done, so sum up in a few
So
seconds.
can I put my discussion slide, but this is a 2 slides more, sir. So the uniqueness in this study, that what we want to say, that if when we are planning to start an ICU or intensive care unit, if we are starting 10 bed of ICU, then we should have a 20 bedded HDU or the something like called palliative treatment ward. This is very mandatory, because if only ICU will not supplement, and we will get overburdened with the patients in the ICU. So this is the crux of the study. Thank you.
So thank you very much. I think that was a very important topic that you took up, triaging being very important and priority level being fixed out. So what do you suggest? Because this is a problem faced by all big hospitals, that the beds are already occupied by patients who are probably not going to come out. Chronic COPDs who are not going to be weaned off, and malignancy patients, stroke patients probably on the downhill but still occupying the bed. And the patients who require the beds, who may probably survive if given treatment on the correct time, they are then not getting the facilities at that time, and they succumb many times in the ward. So what do you suggest? What would be your points of suggestion?
The suggestion is, when we are planning to set up an ICU, what I have worked many places in the government setup also, even in the AIMS Delhi also, they have 10, 12 bedded ICU, but they don't have HDU. So if you take somebody from the CVA patient there in the ICU, that bed got blocked for around 1 week, 2 weeks time. So in my short life, professional life, I can see, I have seen the beautiful ICU of the Holy Family Hospital in New Delhi. They have 20 bedded ICU and they have 45 bedded HDU. There are 45 bedded. That doubles the strength of HDU, and that is very, very, very much needed. It should be replicated in the government hospitals also. They should give priority that we have a step down HDU or that palliative treatment ward also.
Dr. Devendu, I would like to know the outcome, from the outcome point of view. Those patients who were shifted after admitting to the ward to the ICU, and those who were directly admitted to the ICU, outcome was better in which group? Those who got the direct admission to the ICU, or those who were shifted from the ward?
Actually, sir, this is a retrospective data calculation, so I cannot make out that difference.
One small suggestion, because it's a retrospective, I would suggest, it's a very beautiful study. You should further see how much time they have spent in the ward, how soon they got the ICU.
Yes,
because
yes.
I don't think we get direct admissions to ICU. They usually go via the ward only.
Go via the ward.
But then you have to see those who got within a few hours, those who got on the next day, and those who got after 4 days. What is the difference in their outcome? That would make another very good study for that.
So ICU person is always under pressure. They work under pressure कि एक patient ward में और खराब हो रहा है, तो you have to shift the better patient from the ICU and then the more sicker patient from the ward. That is a very difficult thing.
Thank you very much. That was an important message. Thank you, Dr. Devendu. Now we have do we have the next speaker, Dr. Kiran Vadapalli?
Thank you.
Yeah, we can, we should applaud for the speakers also. They have done a good work.
I will request the audio team to put the timer, please, at 5 minutes, because we are not getting the timers. No beeps.
Their PPTs, please do that in the preview room so that we do not waste time here while searching. All the participants, please get it loaded in the preview. Please proceed.
Good morning, dignitaries and my dear colleagues and senior faculty. I'm Dr. Kiran. I'm working as an assistant professor of medicine at Rangaraya Medical College, Kakinada. I'm here to present a study done during my residency, a point-of-care ultrasound as an agent for physicians to predict the right time to wean the patient from mechanical ventilation. As physicians, we find difficulty in deciding the right time to wean. Early weaning may require reintubation, and with reintubation there is increased chance of mortality. And late weaning will lead to patients getting ventilator-associated pneumonia and may also increase the cost of care. So the right time to wean the patient from mechanical ventilation will come a long way in making the patient better and also decreasing the chance of other reinfections. So point-of-care lung ultrasound and diaphragmatic ultrasound can be used as a weaning index. We have been using different weaning indices like rapid shallow breathing index, integrative weaning index, etc. But these indices are not so much specific in predicting the right time to wean. Now with the increasing use of ultrasound at the point of care in ICUs and in the wards, we can use the lung ultrasound and diaphragmatic ultrasound to predict the right time to wean the patient from mechanical ventilation. There was no study done from India using both lung and diaphragmatic ultrasound as weaning indices at the time of the start of the study. So the aim of the study is to use the lung and diaphragmatic ultrasound as weaning predictors in critically ill mechanically ventilated patients. As my previous speaker has spoken, critically ill patients are the patients who require mechanical ventilation, and in latest COVID pandemic when I have done this study, many patients had ARDS and other pneumonia secondary to aspiration, etc. And there were quite a number of surgical patients also. So my objective of the study is to correlate the lung ultrasound score and diaphragmatic thickening fraction and excursion with the weaning outcome. So this is a prospective observation study done in the Department of Critical Care Medicine at Bharati Vidyapet Medical College, Deemed University, Pune, over a period of 9 months from July 2020 to March 2021, and it was approved by IAC. Now we calculated the sample size by predicting that 69% of the patients who are mechanically ventilated will have a simple weaning. This is by International Consensus Conference statement, and we calculated the sample size, it came to around 89 patients. We defined simple weaning as the weaning of the patients who are weaned at the first spontaneous breathing trial, and failed weaning as patients who are difficult to wean, that is took more than 3 attempts to wean, and prolonged weaning is more than a week of first attempt of weaning. And patients who have failed extubation are also categorized as failed weaning. So we included all the patients who are mechanically ventilated for more than 24 hours, both medical and surgical patients, and who are fit to be weaned in this study. So the baseline characteristics at admission, the severity score, Apache and SOFAT presentation were all taken at the initial assessment, and at the time of first spontaneous breathing trial, we put the patient on the standard mode of pressure support, and with a pressure support of 8, positive and expected pressure of 5, and FiO2 of 40%. If the patient is able to tolerate the spontaneous breathing trial, we have done a lung and diaphragmatic ultrasound at that point. And lung ultrasound score is a standardized score which is done in 12 areas, 6 on each side, 2 anteriorly, 2 laterally, and 2 posteriorly. And we see the aeration of the lung. 0 meaning that lung is good aerated, A is few B lines, which is minimal amount of problem with aeration. B lines, significant B lines, which is pulmonary edema, and the 3 goes for consolidation. If you see there, the consolidation and their dynamic air bronchograms. This is the classical picture we see in a lung ultrasound. And we saw the diaphragmatic movement. And when the patient is taking a deep breath during SPT, the amount of movement of the diaphragm and the amount of thickness of the diaphragm when the patient is taking a breath. Lung aeration and the diaphragmatic movement will indicate the aeration of the lung, which is the major organ, and the strength and endurance of the diaphragm, which are both of them which are essential for the weaning of the patient from mechanical ventilation. So we had 89 patients who have undergone the spontaneous breathing trial, and out of them 62 passed the spontaneous breathing trial and went on to extubation, and 47 patients were successfully extubated, but out of them 15 failed extubation and required reintubation, and 1 required NIV support, and 5 died even after reintubation. And there are 27 patients who failed SPT in the first attempt only, and all these put together, the failed weaning group constituted around 42 patients. Coming to the baseline characteristics, At the presentation age, sex, the medical or surgical illness with which the patient is admitted into the hospital, the severity scores of Apache and SOFA, and the illness duration of days didn't change much. But outcome scores, the ventilator days.
Your time is over. Please sum up in a few seconds.
Out of the 89 patients, 47 patients had simple weaning and 42 had failed weaning, madam. Both have simple, comparable baseline characteristics and illness severity scores. Cutoffs were lung ultrasound score of less than 12 and thickness fraction of more than 22 and excretion of more than 1 had good weaning outcome. And these scores are almost comparable to scores which were applied from Europe and US. And so point of care lung ultrasound is good for weaning the patient for mechanical ventilation. Thank you.
Thank you very much. So what do you infer at the end of this, that the ultrasound is useful for which group of patients? Either you go in for a simple weaning test initially and the patients who have failed, or you propose to do this ultrasound for all the patients whom we are planning to wean off.
We can do it for all the patients because it's radiation free, madam. It's very portable and doesn't cost much. We can use it for all the patients and we can predict whether the patient.
So has the cost effectivity been established somewhere? Would it be cost effective enough as compared to the simple weaning procedures which are already going on? The patient is initially put on the total ventilatory support, then pressure support, and then weaned off gradually. So is it cost effective to do for all patients while weaning off, or only for the patients who have failed weaning off?
Madam, cost effectiveness was not directly assessed in this study.
You must have seen, since we do some study to find the outcome, we must have seen in the literature.
Yeah, madam, but in the literature there was no cost effectiveness was worked out because point of care lung ultrasound is now being used in every ICU. Ultrasound machine is the only income which we put forward. Otherwise, like we regularly do.
We would need a sonologist for all the patients, mind you. So the ICU cost, the cost definitely increases. You do a small change, you make a small change, the cost increases.
This as a resident, madam, we are supposed to do lung ultrasound and diaphragmatic ultrasound daily for all the patients. Actually.
So because we had to go very fast in your result slide, we could not see. So what was the result? Was it significantly beneficial by using POCUS?
Yes, madam, it was significantly I didn't assess the use of POCUS, madam. Like we assessed the scores of lung and diaphragmatic ultrasound score, and all the patients had who had successfully weaned had better scores compared to the patients who have failed weaning. And patients who have, and we could predict that the lung ultrasound score in this, we can, I'm not able to show the graph, but in lung ultrasound score with score less than 12, we are able to predict the successful weaning in around 97% of the patients, 97% sensitivity and around 85% specificity, madam. We did AUC curves for them and we could predict that lung ultrasound score is much better.
So this is a prognostic, basically you want to say, not a, not in an, this would help us knowing whether this patient may be weaned off or not.
Yes, madam, it will help us.
How it is going to benefit me if I am going to do this? How it will help me?
Madam, because if we can predict the right time to wean, we can reduce the chance of reintubation or extubation. And because we are directly seeing the lung, which is the major organ which we are ventilating, and we are seeing the diaphragm directly with our eyes through our ultrasound, we can definitely gauge the ability of the patient to tolerate the weaning attempt. Rather than other scores which calculate the, if we put the patient on weaning mode, the patient becomes tachypneic. We calculate the RSBA index, and if the patient becomes tachypneic, we feel that the patient is going to worsen. So with these scores, probably if the scores are less and diaphragm movement is good, we can predict that, okay, this patient is going to tolerate weaning attempt and he can be weaned successfully.
Dr. Kiran, excellent presentation. I would like to know three things in this. How frequently you should do it? What should be the time of initiating this POCUS? So you may be having a facility where you are able to do it regularly, but in many of the setups, this may not be available as a routine. So when it should be started, how frequently it should be done, and when you have successfully weaned off the patient from ventilator, do you need a follow-up with the POCUS also? So can you prevent reintubation in some of the patients by doing POCUS?
Thank you, sir. Thank you for the question. Like as per the study protocol, if the patient had weaning failure, we used to again go back and do the lung and diaphragmatic ultrasound to find what was the problem with, why was our assessment has failed. But I didn't put this in our study, like in Falsis we have put it. Second thing, sir, with every ICU, and now I am working in a type 3 city now. Even there, even government setup, we have an ultrasound in our hospital. So that is easily used by all the, even my MD residents are using ultrasound routinely because of training. So we can regularly use it in a day-to-day care. But for patients who are mechanically ventilated, weaning, at the time of weaning, we used to do patients who are ventilated. And these scores were, when I was doing the score, we didn't know the score, but we used to know the aeration of the lung. And we had many COVID patients. I did this study in COVID pandemic. We are able to see that, okay, this lung is very much consolidated. It's not good to wean the patient. No, that judgment definitely we are able to get. But with proper application, probably it can be used regularly in practice. And we had made a protocol in our unit that we had to do this every day. So I cannot extrapolate it to every ICU possible.
So just because we are short of time, just one more question. Can it replace the regular chest X-ray which we do in the ICU patients?
Pardon?
Can it replace the regular chest X-rays which we do in our patients almost on the daily basis?
Sir, ultrasound has now gone away from X-ray. X-ray is a two-dimensional image of a three-dimensional structure, but an ultrasound will give us a complete image. And by seeing the diaphragm, because that is a major muscle which is helping us to wean the patient from mechanical ventilation. If you can see that diaphragm is thickening well and it is moving well, that means diaphragm function is good. So he will be able to tolerate the weaning attempt, and we can go ahead with weaning.
So thank you very much, Dr. Kiran. That was an important addition to the routine for the physicians.
In our unit, madam, we are regularly doing.
Yes, it is. And weaning is a difficult problem. Thank you so much.
Thank you.
Now we move on to the next speaker, Dr. Anjan Yadav. Dr. Anjan Yadav is in the audience. Please. So is it is to be just reiterated that you have to finish, you get 5 minutes only, and we would like to spend as less time on the changing of the slides also.
And you get more marks if you finish in time, because this is a paper presentation. So.
We have equal distribution for the relevance of the study, for the time management, for the your communication and presentation skills, along with the question answers. So as Dr. Amit was saying, being on time is very important. So please, before the buzzer. Thank you. You can start.
Good morning, everybody. My name is Dr. Anjan. I'm a postgraduate in Department of Medicine in Kempegowda Institute of Medical Science, Bangalore. So my moderator is Dr. Tirthankar Mukherjee, sir. So I would like to present to you a very rare case of sudden onset paraplegia, which we saw in an elderly female patient who came to our OPD. So firstly, let us go to the case details. This is an elderly female who was a known hypertensive on treatment. She came to us with complaints of low backache, which is a chronic low backache, bilateral lower limb progressive paresthesias, weakness, and she had buckling with history of multiple falls, but no bladder involvement initially. All these symptoms were persisting since 2 to 3 months. So coming to the clinical examination of the patient, when we saw her in the OPD, her higher mental functions were normal. There were no cranial nerve examination was normal, and the power in the bilateral lower limbs were 4/5, with very patchy lower limb sensory loss, with no neurological deficits in the upper limb. So with this scenario, with OPD setup, we got an MRI brain imaging for this patient done with whole spine study with a contrast. So that showed us an hyperintensity in the lower dorsal cord with conus medullaris with cord swelling involving the D10 segment to L1 levels. So all these features were suggesting us that this patient could be a case of transverse myelitis. So this was what the cord was showing us. Now coming to the spine study showed there was diffuse annular bulges involving D12 to L5 with significant narrowing of bilateral neural foraminas. So with this, we admitted the patient. We did a CSF study in this patient. So that turned out to be negative. It was negative for oligoclonal bands, and even albumin was negative in this patient. So with this perspective, and with age of the patient being 73 years, we administered steroids for this patient. So what exactly happened after steroids is very much remarkable in this thing. We admitted the patient today in our second day of our hospital stay. We gave her steroids, and this happened on day 2. Following day 2 and physiotherapy, patient weakness worsened. How bad it was? The power which was 4/5 went to 2/5, and now she initially did not have bowel bladder involvement. Now she had bladder and bowel involvement with 3 to 5 episodes of vomiting. So now what do? Now we asked for an MRI LS spine. Mind you, last time what we done was a whole spine contrast study, and now we asked for LS spine in particular. So when we asked for LS spine in particular, what came out in the report was quite very significant. It showed us there was a dorsal cord edema with ischemia with flow voids noted in T2 segments. And this, what we thought was secondary to spinal dural AV malformations, or that is spinal AV dural fistulas, starting from D9 level. So let's go to the MRI imaging of this patient. This is the MRI imaging of the patient showing the dorsal cord edema with flow voids in the T2 hyperintensity levels. So coming back to this, now how do we manage this case? Now with the background history of spinal dural AV fistulas, we subjected this patient to a spinal DSA. So when we subjected this patient to a spinal DSA, the spinal DSA now revealed that it was a dural AV fistula with the feeder vessel from the radicular branch of left T11 intercostal arteries with right renal artery aneurysm. So this is a spinal DSA image what we did. It is showing whatever we show here in the white arrow. Sorry, this is a white arrow. This is actually the intercostal artery, and we can see a very black arrow in the single black arrow. That is the radicular branch which is connecting to the radicular branch. This is a radicular branch of the spinal cord. So this is a spinal dural case of spinal dural AV fistula, which was very significantly seen, which is very remarkable and very rare. So next, what did we do for managing this patient? So she now came to us on day 2 of OPD, day 2 of her admission, her weakness has worsened. And now we subjected her for embolization. We did an embolization with 25% n-butyryl cyanoacrylate. And after embolization, we were able to obliterate the fistula very successfully. And post-intervention, the patient's symptoms improved gradually by day 10, and with the power in the lower limb being 4+/5. And bladder and bowel incontinence improved, and patient was ambulatory. So this is the spinal DSA. Now coming to the image pictures, like this was what the embolization we did. We went through a femoral axis. We used a 5F SIM1 gastric catheter. The white color, what we see is the 5F catheter. We have a magic catheter over there. Okay, not able to see. There's a magic catheter over there, which is going. It is indwelling into the fistula, indwelling into the radicular artery, which is fistula matus. And now we have injected the dye. And the dye here is n-butyl cyanoacrylate. It acts as a glue. There will be no wash off of this dye. It acts as a glue there. So it acts as a glue, and you can see that after post-contrast, there is no filling of the fistula, and we were able to obliterate the fistula very well. So this, ladies and gentlemen, is a case of spinal dural AV fistula. And coming to the discussion of this forms 70% of AV malformations with an annual incidence of 5 to 10% per million. And
kindly summarize.
Yes, ma'am. The summarization of this is going to be, this is a case, why exactly there will be weakness in this is because of arterial hypertension. It is transmitted to the veins, and this will be arterialization of the veins causing venous congestion and cord ischemia. And this is the only myelitis, mind you, the only myelitis which worsens on steroids and exercise. And high degree of clinical suspicion is required to diagnose this entity. And once diagnosed, this requires a multi-system approach for treating this. Thank you.
So, okay, fine. So, this was an interesting case, and you are
I'm a postgraduate medicine.
In medicine, right. So, do you have, how easy it is to go in for a DSA in the...
No, ma'am, it is quite...
So, that is the main problem
yes,
with the neurological this?
Yes, ma'am. This requires a multidisciplinary approach. It's not a very, it can't be tackled in every single community health center. So this requires a very high setup and requires very high clinical suspicion. And we got a first MRI done, and it was done in 1.5 Tesla. That was the drawback of that was radiological drawback indeed. A 1.5 Tesla machine did not, it only demonstrated there was a cord edema. It did not pick up flow voids in T2. So when we subjected the patient to a 3 Tesla machine with MRI LS spine per se, then it picked up a flow void. So this is not a case that can be managed at a very lower
So
setup.
the
This
flow
requires-
void was probably which directed
ma'am.
you to go in
Yes,
for
ma'am,
further
yes.
evaluation, because
Yes, ma'am.
the first was showing a myelitis,
Myelitis
transverse
picture.
myelitis.
Yes, ma'am. The second MRI showed a flow void. That is when we had a very high clinical suspicion this could be a spinal dura AV fistula, and immediately we got a DSA done and dramatically patient improvement. That
So
was
what
like,
would be your take-home message?
ma'am, take-home message is any patient who comes to you with with signs and symptoms of compressive myelopathy, any signs of compressive myelopathy, when you are ordering for an MRI, so, and one more thing, what was the catch in this case was, usually this is seen in 5th to 6th decade of life, but this patient, and it is morely in males, this was a female patient. So what would I suggest for a take-home message is proper clinical examination to rule out whether it is compressive myelopathy or not. If it is compressive myelopathy, order for an MRI, please ask for flow voids. Please ask for flow voids. If flow voids are there, then don't give steroid, don't admit, because every myelitis we give steroids, and every myelitis improves on physiotherapy. But this is one such myelitis which worsens on physiotherapy, worsens on activity, and also worsens on steroids. So ask for a flow void. If there's comment there is no flow voids, go ahead giving steroids, go ahead giving physiotherapy.
So vascular etiology has to be
Has
kept
to be
in
ruled.
mind, not only in spinal cord, in all the
Okay.
contexts. Many times pain abdomen also comes with, it turns out to be a vascular etiology, being treated for pancreatitis and APD and everything, but turns out to be a vascular
ma'am, yes.
ischemic pain. So that's an
This
important
case
message.
actually got a worldwide recognition in 2002. It was first described in Neurology Update 2002 as Singer's paraplegia. It was done by our own Indian Mr. Vinu Khurana did it actually. It was published in the Neurology Update 2002 as Singer's paraplegia. He was actually opera singer. The main complaint was 10 to 12 years, he used to go on the stage, he used to sing. The moment he sings, the legs used to give away. That is because of the increased pressure. There could be venous congestion and cord edema leading to his transient paralysis.
Thank you very much, Dr. Anjani Yadav. Do we have Dr. Soumya Roy? Soumya Ray?
So, good morning to esteemed panel, faculty members, my fellow delegates. Today, I'll be presenting my paper on survey of medication error awareness amongst physicians and nurses in tertiary care hospital settings. I am Soumya Ray from Department of Pharmacology, IPGMR, Kolkata. So, medication error is defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer. So citing some reports from US FDA, there have been 1 lakh reports of medication errors since the year 2000. 7,000 to 9,000 people have died each year. The total cost of looking after patients with medication error associated errors is $40 billion each year, which is really staggering and which leads to decreased patient satisfaction. So my primary objective was to assess and compare awareness, attitude and practice towards medication errors among physicians and nurses in tertiary care hospital setting. And my secondary objective was to assess and compare awareness, attitude and practice among physicians and nurses segregated by public sector and private sector. So coming on to the methodology, my study design was a cross-sectional observational study. It was set at IPGMR Kolkata, which is a government institution, and PLS Hospital, which is a private institution. My sample size was 100 physicians and 100 nurses from IPGMR Kolkata, and 30 physicians and 30 nurses from PLS Hospital. My study tools was medication error awareness form and medication error documentation form, and it was completed within 18 months from the day of inception. So coming on to the inclusion criteria, there were physicians from both the IPGMR and PLS Hospital Kolkata, along with staff nurses from IPGMR and PLS Hospital. My exclusion criteria was less than 6 months of work experience in the concerned hospital and not consenting to fill in the questionnaire either face-to-face interview or within a reasonable 2-day time period. Now my work plan was questionnaires were distributed among physicians and nurses. They were asked physicians and nurses, they were asked to fill the form and return within 48 hours of receiving. The data was filled in Excel sheet and the analysis was done by Statistica version 8 software. So coming on to the results, there were 125 doctors and 146 nurses. Here we can see that the respondent nurses had a greater median work experience. Now I had a 60 questions on my questionnaire. Question number 1 to 20 were on awareness. Question number 21 to 35 were on attitude. And now the table 2, it compares the attitudinal elements between doctors and nurses. Here 91% of nurses double checked the dose calculation, while it was only 74% amongst doctors. Also 95% and 94% of nurses, they made sure to write a legible prescription and entering details carefully in medication record sheets. Also, when it came to report a medication error, it was 80% amongst sisters and only 50% amongst doctors. Now question number 36 to 58, they were on the practice elements. So this table compares the practice elements between doctors and nurses. Here the 54% of nurses, they refer to package inserts whenever they were unsure. Also, what's noteworthy here is, even here also the sisters, that is 71% of nurses as compared to 41% of doctors, they reported a medication error when it happened. Now this table, it compares the risk factors which can lead to medication error, and this is between government doctors and private doctors. Government doctors, they ascribe to heavy workload as the most important criteria, followed by fatigue. Also illegible prescription, deliberately look-alike packaging, poor quality labeling were other factors. Now this is the table for risk factors which can lead to medication error between government nurses and private nurses. Now here amongst government nurses, it was 84% of government nurses ascribed to heavy workload, but in private setting it was 74% who told that illegible prescription was a major criteria for causing medication error. Coming on to the conclusion, awareness and practice among both doctors and nurses are encouraging. A major lacunae, it lies in the documentation of medication error experience. Fear of negative consequences and subsequent legal action can be a determinant, can be a major inhibiting factor why doctors don't come forward to report a medication error. Not a single respondent from both the hospitals produced a filled-in medication error documentation form, and medication error reporting is the need of the hour. Thank you everyone.
Very good study done at your center.
Thank you.
So what one line message you want to convey?
Ma'am, I would like every doctors and nurses to come forward and report a medication error, because as we have seen from the reports of US FDA, there is a staggering cost which happens due to looking after the patients who are associated with medication error associated problems. So I would like every doctors and nurses to come forward, ma'am.
Yeah, we could have more EMR recording of the prescription,
right.
Even the medication, so the medication errors reduces.
Yes, ma'am.
Even the dispensing errors need to be
Right.
seen.
Ma'am, I would like to say one thing. Our IPGMR Kolkata, it is the eastern Zonal Center for Pharmacovigilance Program, PVPI India. So we obviously, I am a senior resident, so even senior resident PGTs, in my PGT life, we used to go to the OPD settings, and in every OPD setting, and we used to make sure that the nurses and the doctors are writing everything in the generic name and not in the brand name.
Pharmacovigilance is important. It's there in most of the medical colleges these days in the departments of pharmacology. But then what do you think is the more important cause? It's many a times, is it the fear of reporting, or many a times it's just a lethargy, you know, that what is the use of reporting?
Ma'am, I would like to say that as talked with the doctors and nurses, fear is a big criteria. They wanted to be anonymous, and my study was already told that you can be anonymous. Also, doctors, I used to give my questionnaire, but I never got to sit in front of them and take a face-to-face interview, because the major problem was that they had a very heavy workload and they couldn't produce me. Ma'am, these are IPD based. Ma'am, my questionnaire was all to the residents, faculty members and all.
Of the outdoor setting or indoor?
Ma'am, both.
I think one thing is clear from your study is that nurses are more open to accepting the errors. They are more open to reaching out to their colleagues when it comes to whenever there is a confusion regarding the dosage, and they are also more accepting of their errors than the doctors. So I think this is something which is needs some change. Thank you for your presentation. Thank you.
Thank you, everyone.
So next presenter is Dr. Swaraj Vadanakeri.
Good morning, everybody. At the outset, I'd like to thank the organizers for giving me the opportunity to present my presentation. I am Dr. Swaraj Vadanakeri from Kalyana, Karnataka, North Karnataka. I am working as an associate professor in the Department of Medicine. My topic is gender discrepancy and correlation between C-peptide and metabolic syndrome in people with type 2 diabetes. We all know metabolic syndrome is a widely prevalent and multifactorial disorder. Who defines it as a pathological condition characterized by abdominal obesity, insulin resistance, hypertension, and hyperlipidemia. Diabetes characterized by insulin secretion impairment and insulin resistance. Pancreatic beta cells fail to compensate this resistance, leading to hyperglycemia. So this measurement of C-peptide, which is secreted along with the insulin, provides a better index of exogenous insulin production and beta cell activity. So we have seen the evolution of metabolic syndrome according to various different criteria. We have the AHA, NHL, PI 2009, IDF 2005. We use the IDF 2005. So 104 male and 96 female patients were enrolled in the study. Simple linear regression analysis was done between fasting C-peptide, waist circumference, lipid profile, and metabolic syndrome for males and females. Inclusion were people who are type 2 diabetes, either on medication or on diet, and who are more than 18 years of age and or of either gender. Then we had patients who excluded, who were either admitted or who were having other types of diabetes, like type 1 diabetes or type 3C diabetes, or known case of type 1 diabetes, or acute illnesses like pancreatitis, myocardial infarction, stroke, or acute hepatitis. So all those conditions and patients with CKD were ruled out. This is the IDF criteria that we have used. Sorry, sir. IDF criteria which we use to define the metabolic syndrome. So we all know that we as Indians are predisposed for metabolic syndrome. We have the genetic factor. Now with this Western diet and decrease in physical activity, there is increased visceral adiposity leading to increased reactive oxygen species, that leads to chronic inflammation, hormonal activation, insulin resistance, developing metabolic syndrome, and then type 2 diabetes along with increased risk of cardiovascular disease. So our mean age of the male patients was around 47.6, mean age of females was around 49. So mean C-peptide in the males was 2.5 and in the females was 2.79. So if I have to come to one particular slide in my discussion which I have to talk about, I think this would be this. So it is all cases, if I have to see the duration, as and when the duration of diabetes progressed, the C-peptide fell down. So that was that was accepted. But the difference, what I would like to tell you, it falls significantly in females than compared to that of males. Also, if I have to talk about all cases with respect to BMI, there was a positive correlation. As and when the BMI increased, the C-peptide increased, and that was not different in terms of males and females. So other variables, systolic blood pressure was significant, HDL was on the lower side, triglycerides was on the higher side, which was p-value was quite significant. When it comes to LDL, the mean LDL of males was around 106, whereas it was 130. So this tells that the females are probably more likely to have a cardiovascular disease, especially if they are having longer duration of diabetes. So coming to discussion, so the core feature of metabolic syndrome is insulin resistance. We are all very aware about this. To compensate for this, the hyperinsulinemia occurs. So the mean C-peptide in our study was higher in type 2 diabetes with metabolic syndrome than if I had to compare in people without metabolic syndrome. So there was a inverse association between C-peptide and duration of type 2 diabetes. How do I explain this? It can be explained by the chronic glucose and lipid toxicity, which causes gradual and irreversible damage to the cellular components of the insulin production and also to the insulin content as well as its secretion. So dyslipidemia showed an increasing association of lowered HDL cholesterol, which is inverted commas the good cholesterol, and increased triglycerides to a higher levels. So as the C-peptide levels went higher, the HDL fell down, or rather the HDL decreased and the TG increased. So fasting blood sugar was elevated. Fasting blood sugars were elevated. Fasting was elevated despite elevated C-peptide levels in obese patients, proving the role of insulin resistance. Significant correlation between C-peptide and triglycerides and HDL cholesterol, which are all the constants of metabolic syndrome. In people with type 2 diabetes, people with metabolic syndrome had a higher C-peptide. So metabolic syndrome is equal to higher C-peptide levels. So BMI was an independent positive correlation with fasting C-peptide levels, emphasizing that obese patients have comparatively higher insulin resistance, thus paving the way probably for using C-peptide as a marker of metabolic syndrome. Thank you.
Dr. Swaraj, I have 2-3 queries, and I think many of them will be having, since you are talking about the metabolic syndrome. So metabolic syndrome is impaired fasting glucose, something like that, right? All your patients already had diabetes. And in patients with diabetes, C-peptide levels can highly be variable, because you did not mention anything about their control. Because if somebody is having hyperglycemia, C-peptide level may be falsely low also.
Sorry sir,
yes.
The definition of metabolic syndrome doesn't include type 2 diabetes. So it says that 3 out of 4 criteria of which diabetes can be excluded. So that is the reason we included those people who are having diabetes, but they were not having any other risk factors. So that is in such subset of patients, if C-peptide is elevated, that can be a marker of metabolic syndrome. So that is what the probably 204 patients is a small number of patients to prove that, but I think this could be way ahead.
So you were targeting that a higher C-peptide, so higher hyperinsulinemia, so higher insulin resistance. So would it not have been better to look in for a HOMA beta and HOMA IR in this, using the modified homeostatic model?
Yes, ma'am. Cost factors as well as availability of...
Nothing else was required, only fasting glucose is required. You have the C-peptide, you have the fasting glucose, you can calculate.
That can be done, but we have not done that.
That would have been. Yes. Okay, fine. Thank you, Dr. Swaraj.
Thank you, ma'am.
We have Dr. Ankita Mandal to come for her next presentation.
Is on assessment of knowledge, attitude and practices among respiratory patients on inhalational therapy in a tertiary care center. So this study was also done in King George Medical University in Department of Respiratory Medicine. So in this picture we can see the normal diameter of the normal bronchus. But when a patient acquires an obstructive airway disease, the total diameter and the lumen get reduced to a lot, leading to expiratory airflow limitations. So smoking cessation, medical therapy, pulmonary rehabilitation, all these things has come into active. But we have to consider whether the patient is adhered to the therapy, whether the patient is compliant to their therapy, or whether the technique is proper or not. That is an important thing which is done in this study. These are the types of inhaler. Various inhalers has come like BAI and standardized PMDI, but the main issues that we face is the cost. Despite breath actuated pressurized metered-dose inhaler being a very nice therapy, but its cost is very much which cannot be afforded by the normal patient of the Indian society. Now the aims of this study, we aim to evaluate the inhaler techniques in patients of obstructive airway disease. We assess the compliance of patient toward the correct use of the inhaler devices. Basic preliminary knowledge about the knowledge and attitude and practices towards inhaler devices were assessed by this study. This is a prospective observational questionnaire-based face-to-face study done in KGMC in Department of Respiratory Medicine OPD. Out of 152 patients, we got 64 patients were male and 36% of the patients were female, among which 78.95% have adequate knowledge about their treatment elements and their ailments, and out of the total patient, 75.49% have optimistic attitude towards their treatment. Now, in various studies we have seen which is done abroad or also in South India, most of the used inhaler therapy was PMDI or BI. Especially in abroad, the patient used BI because they didn't have the issues of economical status. Even in South India, I have seen various studies where the leading inhaler therapy was MDI. But when I have held this study in North India, the inhaler therapy that was much more taken by the patient was DPI. So while coming to the practices, most of the practices were in moderate range, but the only thing, like 35% of the total patients who were taking MDI, they had one problem. They were pressing the MDI twice in one dosing. And in DPI, they had 35.9% of the patient have the problem in holding the breath for 8 to 10 seconds after taking the inhaler. So these factors were seen in this study. Now, these are the normal study variables that I have already discussed. Now, coming to the conclusion, as seen in this below picture, we have to ask our patient to get adhered to their therapy and get adhered to the compliance of their therapy. So once the patient is taking their therapy, it's very easy for the patient to come back to their normal life. But if they get deferred from their therapy, they lived an adverse life that's seen in this picture. So the most commonly inhaler therapy used by us or in North India is DPI because economy is one of the issues that we faced in our Indian population. And we are trying to solve this, and DPI is also simple and easy to use. It is portable, though there are certain drawbacks of the DPI, but that could be outdrawn by proper compliance, by proper counseling of the patient. I would like to acknowledge my mentors and the other authors who have helped me to get this study done. Thank you.
Thank you, Dr. Ankita. Since this was assessment of the knowledge, attitude and practices regarding the use of devices used in the respiratory disorders, COPD and bronchial asthma, did you look into, and I did not see, as to who had explained the utilization of the device to the patient?
The doctors have
whether it was a doctor, whether it was a pharmacist, whether it was a nursing staff?
No, it was the doctor. It was the OPD visiting doctor who were giving the patient inhaler therapy. Because what we used to do in KGMU is like, we don't rely on the other person. We prefer that the doctor themselves teach the patient how they are taking the treatment, whether there is any drawback, whether we need to facilitate that, whether we need to correct that drawbacks for the patient. So doctor has done the whole thing. Yeah. Yes, ma'am. For inhaler therapy, if the patient is educated enough, we can ask the patient to go through YouTube and
Or
see
should
these
we
things.
have, like we have separate diabetes educators for insulin and all, similarly, should we have
Ma'am, it
trained
would-
pharmacists who would probably tell
it would
further
be
and then
better.
aided by doctors?
Ma'am, it would be better in future aspects we can train the pharmacist and the nurses so that they can train properly to all the patients. But
What
right
is,
now,
okay, good. As per your this, what is novel in your presentation? What is new?
ma'am, the patient who are taking MDI, they have to be trained, like when they are asked for 2 puffs, they have to repeat the same procedure twice. They need not take the 2 puffs twice at the same setting. And in DPI, they have to hold the breath for 8 to 10 seconds after taking the medication. Most of the patient, what they do is they just take the breath and they just release the DPI and they release out the breath. That's not the thing. The inhaler therapy won't reach the required places. So
Thank you very much, Dr. Ankita.
thank you, ma'am.
Thank you. Do we have the next speaker, Dr. Vishwa B. Unatkat? Dr. Vishwa Unatkat is not there. Dr. Manasa Elika.
Good morning, everyone. I am Dr. Manasa, postgraduate resident of Department of Internal Medicine in IMS and Some Hospital. My study was clinical and biochemical profile of NAFLD in type 2 diabetes mellitus patient under the guidance of the Dr. Samir Saho sir. As NAFLD is currently the most common liver disease with a prevalence of 25%, and patients with type 2 diabetes mellitus are found to have NAFLD in 65 to 87% of the cases. So my aims and objectives are to study the clinical and biochemical predictors of NAFLD disease in type 2 diabetes mellitus, and also to compare the clinical and biochemical parameters of the patient in type 2 diabetes mellitus with non-alcoholic fatty liver disease, and also to detect and quantify the amount of fat in liver by using ultrasound and also elastography in NAFLD patient. So the materials and methods were, I took 100 individuals were chosen depending on the inclusion and exclusion criteria and over 18 months. And methods were based on ultrasonography. They were divided into 2 groups, patients with fatty liver and also without fatty liver. Anthropometry measurements like weight, height and waist circumference and hip circumference were measured, and blood parameters like LFT, CRP and serum uric acid and FBS, PPBS, serum insulin, HbA1c and lipid profile were taken. The variables were compared between type 2 diabetes mellitus patients with NAFLD and without NAFLD. So the inclusion criteria were in and out patients with type 2 diabetes mellitus, and the exclusion criteria include the already known case of chronic liver disease, alcoholic patients, hepatitis patients and malignancies, and ingestion of drugs known to produce hepatic steatosis, and also pregnant females. The results were, out of the 100 patients with type 2 diabetes mellitus, ultrasound revealed 69% having NAFLD and also 31% having no NAFLD. There was significant difference in levels of insulin resistance and serum ferritin and serum uric acid and CRP between the NAFLD and without NAFLD groups. So this was depicted in the table and the bar charts. So as clinically NAFLD patients tend to have components of metabolic syndrome such as obesity, type 2 diabetes mellitus and hyperlipidemia and hypertension as risk factors. In these comorbidities, type 2 diabetes mellitus seem to be the most important risk factor, causing NAFLD and also NASH, and the most important clinical predictor of adverse clinical outcomes such as cirrhosis and mortality. So the limitations in my study was, as a gold standard for identification and classification of NAFLD is liver biopsy, and as it is an invasive procedure frequently associated with distress and discomfort. So ultrasound is the suggested first line examination. However, there are other different imaging techniques used for non-invasive assessment of NAFLD. These include hepatorenal ratio, acoustic structure quantification, and also control attenuation parameter and MRI and CT scan. So these techniques are more accurate and conventional than ultrasound, but less commonly used in clinical and population-based research settings. And there are also some drawbacks of ultrasonography use, comprising the observer reliance and subjective assessment, and also low ability to measure the extent of fatty infiltration. So, concluding my study, patients with non-alcoholic fatty liver disease with type 2 diabetes mellitus should be investigated early to prevent the further complications. Elevated uric acid, CRP and ferritin may serve as a biochemical predictors for early detection of NAFLD in type 2 diabetes mellitus. Thank you.
Thank you, Dr. Mansa. Your topic mentioned here was unusual presentation of a usual fungal infection. Has it been mentioned wrongly or?
It was my poster presentation, sir. In poster presentation,
Okay.
I got the paper.
Okay, so, right, okay, that's fine. So I think,
This was selected as a podium presentation, or that was this because for podium presentation your topic selected was unusual presentation of a usual fungal infection.
That was a poster, ma'am, I sent, but they mistakenly they kept in paper, and this is my paper where they kept in poster in that schedule.
thank you very much. So we have the next speaker, please.
Just one question I would like to ask is, Dr. Mansa, that yes, NAFLD is a very important problem with type 2 diabetes. So what is new in your study?
So actually,
It is known since quite a long time and it is being paid stress upon that liver is an important organ which has to be looked into in patients with type 2 diabetes. So what is new? What have you found out new
so
here?
if a patient is having type 2 diabetes mellitus, and if you are suspecting NAFLD, ma'am, so before we detect it, we can actually see the risk factors, and also we can assess the serum uric acid and ferritin and CRP levels, which will be elevated in the patients who are having the risk of developing NAFLD. So that, or else we are not doing the ultrasound, or routinely the patient is not assessed for NAFLD, and just patient is diabetic. If at all we are not checking these parameters, if we check these parameters, we can prevent the complications of NAFLD like into cirrhosis or further any fibrosis, all this.
So how will you check them? CRP and ferritin levels, how will you reduce them?
Like it is already.
They are, what do they suggest?
Inflammatory response.
Inflammatory markers, which are very important in all non-communicable disease complications developing these days. So, okay, and you have not mentioned in a conclusion slide the anthropometric, I think, which are very important, the high waist hip ratio.
It didn't come as a significant.
It did not come as significant in NFLD.
In
That
this
is
study, it didn't come.
quite strange.
It was
Okay,
equal, there is no
fine, Dr. Mansa. Thank you. Thank you very much.
Thank you.
Next speaker, please, Dr.
Good morning, respected delegates. This is Dr. Jonalagada Vihari, final year postgraduate, Department of General Medicine, IMS and Some Hospital, Bhubaneswar. Today, my study was association of carotid intima media thickness and estimated glomerular filtration rate in different grades of chronic kidney disease. My guides are Professor Dr. Chandan Das sir and Professor Dr. Besaranjan Mohanty sir, and my head of the department is Professor Dr. Samir Sahu. As you already know that people with CKD have an increased chance of developing cardiovascular disease, and as a renal function declines, the risk of mortality from cardiovascular event rises. In the later stages of CKD, a slight decrease in glomerular filtration rate causes double to triple increase of cardiovascular disease. Cardiovascular events are strongly predicted by ultrasound assessments of the intima media thickness in the carotid vessels, both in healthy and sick individuals. And we already know that in both healthy and sick individuals, the glomerular filtration rate is primarily considered as the best holistic marker of renal function. My aim of the study is to study the association of carotid intima media thickness and EGFR in different grades of CKD. Objectives are to find out the grade of CKD using EGFR and to measure the CIMT and to study its association with EGFR in different grades of CKD. The main rationale of doing this study is, nevertheless, the relationship between the stage of CKD and CIMT has had to receive much attention in our nation. It is anticipated that CIMT will be strongly linked with cardiovascular disease risk factors, with the outcomes predicting both cardiovascular events and advancement to end-stage renal disease. This possibly will be a valuable tool for prognostication, early intervention in CKD individuals, preventing the additional illness and death. Materials and methods. The study was done in the Department of General Medicine, Nephrology, Shiksha Anusandhan, Deemed University, Bhubaneswar. The individuals with CKD who were hospitalized at IMS and some hospital over the time frame made up the study group. 136 individuals were chosen depending upon the inclusion and exclusion criteria. And this is a cross-sectional study. The study period was done from November 2022 to June 2022. Methods. The MDRT formula was used to determine the EGFR, and using a high-resolution B-mode ultrasonography duplex analysis of carotid vessels, the CIMT was measured. Eligibility criteria. The individuals with CKD getting treated at Department of Nephrology and General Medicine were included in the study, and exclusion criteria: individuals with nephrotic syndrome, those on statins and antiplatelet drugs, those with acute and chronic kidney disease, and those with the background of cardiovascular events are excluded from my study. These are the results. This is the bar diagram showing the age and gender distribution of the study participant. Among 136 study individuals, 57 were in the age group of 25 to 45, and 68 individuals were in 46 to 65 age group, and 11 were more than 65 age group. The mean age of the individuals was 45 plus or minus 1.15 years, and 93 patients were male and 43 were female. This is the table showing the association of the mean CMT with different factors, and we can see that EGFR in different grades of CKD was there is a p-value less than 0.05 was considered significant in this study, and we can see that our study showed a statistically significant association between CIMT and EGFR in different grades of CKD with a p-value of less than 0.05, that is 0.03. And identical findings were seen in studies done by Tees and Kaumatal in both men and women with p-value less than 0.001. And however, there are certain studies where Sazard and Hinderlal where CIMT did not correlate with EGFR directly. And there are some other studies like Despian and Castan et al. Where there is a positive associations between carotid atherosclerosis by intima medial thickness and CKD has been noticed. My main limitations of my study are most of the individuals in this study that are from poor socioeconomic and educational background and hence do not accurately reflect the overall community. The etiological diagnosis was not considered. Inter-observer variance is a problem with B-mode ultrasonography. And since this is a cross-section study on which the patients cannot be followed up on, an extensive multi-centric investigation is also needed to corroborate these findings. My final conclusion of the study is there was statistically significant associations found between EGFR and different grades of CKD with mean CIMT. Therefore, a physician should urge CKD patients to have the CIMT serially measured so that the possibility of cardiovascular complications may be estimated as early as possible. Thank you.
Thank you very much, Dr. Vihari. So that is interesting to note. I want to ask, why did you exclude nephrotic syndrome? We did not exclude diabetic kidney disease. We did not exclude hypertensive kidney disease. So these are all, they all have an independent impact on the carotid endomedia thickness, whether it's a diabetic patient or it's a hypertensive patient. So why was only nephrotic syndrome included? And did we have all the patients of diabetes and hypertension included in this study?
We include all hypertension.
They have their independently, they impact on the carotid intermediate thickness. So probably it would be difficult to extrapolate that. Is it the GFR correlation, or is it a CKD which is there, or it is an overall entire vascular disorder which is going on, which goes on in a patient of diabetes and hypertension?
Actually, that is also one of the limitations, ma'am, since we didn't excluded hypertension, since we didn't excluded diabetes, since they might also cause for the increased CIMT. But the thing is, CKD and the hypertension both cannot be separated in
That
most of the
cannot be
instances, since hypertension is both the cause and the complication of the...
You're absolutely right. And there's no need to exclude because we need to know how it adversely affects. So it's good that we come to know about it by doing the IMT. But then why did you exclude nephrotic syndrome? As such, there must be some thought line process behind that.
Nephrotic syndrome, why we excluded means...
Okay, no problem. Okay.
One simple clinical query, that how does the addition of CIMT measurement, what clinical value it brings to the patient? Does it adds anything to the management?
Sir, future cardiovascular event can be anticipated as early as possible.
See, if somebody is already having diabetes, or already having CKD, so you assume it is believed that this patient is already at a very high risk of CVD, cardiovascular disease. So adding one more test and measuring the carotid media thickness, intima media thickness in this case.
One another benefit is target organ damage also can be best assessed by this CMT, sir. That is a hidden rationale.
So if you are checking it in a group where in the early stages of the CKD, or you can say even when the EGFR is normal and you have a higher carotid intima media thickness, then probably it is the time you are not suspecting the CKD also, but the patient is at a high risk of CVD. But already established CKD and type 2 diabetes, I don't think clinical value. Anything from the floor can also be taken. Thank you.
Yes, sir. Thank you.
Next speaker, Dr. Sonal Samal, please.
Good morning everyone, my respected judges and delegates. Myself Dr. Sonam Samal, postgraduate, Department of General Medicine, IMS and Some Hospital, Bhubaneswar. And today I am going to present a paper on the topic study of pulmonary functions in the patients with cirrhosis of liver and its correlation with the child-pug scoring. Introduction. Development of pulmonary manifestations of cirrhosis has several clinical implications with regard to the management since they carry a poor prognosis. The pulmonary disease manifestations include pleural effusion, obstructive lung disease, restrictive lung disease, impairment of pulmonary gas exchange, etc. These pulmonary manifestations are in general less recognized by the attending clinicians and are usually not given due importance in routine management of patients of cirrhosis of liver. Aim and objective. The main aim of my study is evaluation of the patients with cirrhosis of liver for the presence of pulmonary manifestations with reference to arterial blood gas analysis and spirometry. In materials and methods, the site of study was IMS and Some Hospital, Bhubaneswar. Study population was all the cirrhotic patients in the OPD and IPD. Study design was simple random sampling. My sample size was 100. Time of the study was, duration was November 2022 to October 2022. And method was the data was collected in the pre-test pro forma meeting the objective of the study in the 100 cases presented to the hospital with the signs and symptoms of cirrhosis. Eligibility criteria, my inclusion criteria, proven cases of cirrhosis of liver to be included in the study, age above 18 years including males and females. Exclusion criteria, patients with life-threatening complications of cirrhosis like active upper GI hemorrhage, hepatic encephalopathy, patients of age below 18 years, patients with previously diagnosed case of COPD, bronchial asthma, interstitial lung disease, etc., smokers, gross ascites with severe respiratory distress, patients who had recent MI within the last 1 month and recent upper abdominal surgery. In my results, summarizing, the mean age group of the patients was between 31 to 40 years, and the study was more dominated in the male patients. And most of the patients they presented with the following signs and symptoms, but among them, the most common was the patient presented with the splenomegaly. 98% of the patient presented with splenomegaly, 95% presented with ascites, and 75% presented with abdominal distension out of 100 patients. And if we arrange or find the child-pug scoring of the distributed patient, the total 100 patient, in my study, 41 patients belong to the child-pug scoring B, 32% in the class C, and 27% in the class A. In arterial blood gas examination, it was abnormal only in 8% of the patient. And pulmonary function examination showed obstructive pathology in 2% of the patient and 25% showed restrictive pulmonary function. The relation between the pulmonary function and child-pug scoring, all the patients with obstructive pulmonary functions were in child-pug scoring class C, while approximately 70% of the patient with restrictive pulmonary function were in class C. We observed that the severity of the liver disease was significantly associated with the pulmonary function. And by comparing the arterial blood gas examination based on the arterial blood gas examination based on the Child-Pugh scoring, our study observed that the arterial blood gas examination was independent of the severity of the liver disease, that the p-value was more than 0.05. In discussion, the study population consisted of 100 patients diagnosed to have cirrhosis of liver and evaluation of above participant for presence of pulmonary manifestation and identify etiology of hypoxemia. The most common age group was between 31 to 40 years. The study was most common dominated in the male patients. Common presenting complaint was abdominal distension among 75% of the patient. Clinical finding, the most common was splenomegaly, and hypoxemia was seen in only 8% of the patient. All the patients with obstructive pulmonary function were in Child-Pugh scoring class C, while approximately 70% of the restrictive pulmonary function was in class C with a significant p-value. And arterial blood gas examination was independent of severity of the liver disease. Conclusion, cirrhosis was most common in the 4th decade, and abdominal distension was the commonest presenting complaint, and restriction was the most common abnormality pulmonary function test in the majority of the patient. Thank you.
Thank you very much, Dr. Sonam. So, what were you looking into in your study basically? I could not make out. Were you looking into the characteristic feature of the cirrhosis of liver? What is the clinical presentation in the wards, or you were looking into the pulmonary function tests? And what is the significance? I have a few questions. So, why do we need to go in for pulmonary function tests? Is there any relevance of looking into the pulmonary function tests in these patients, because they are already in the very difficult extra and intracellular fluid imbalance in all these patients of cirrhosis of liver with the RAS activation and all?
Normally, maybe it is not that specifically I have studied that that cirrhotic patients will come. I will do the pulmonary function test in those patients.
Why will you do it?
Ma'am,
what is the relevance behind it? That is my question.
Ma'am, cirrhotic patients, some pulmonary complications those patients can present with. So with this, if we correlate severity of the liver disease, we are seeing in the Child-Pugh scoring classification, and we can see the restrictive and obstructive pathology if we correlate by seeing the Child-Pugh scoring classification, that this class C is having restrictive pathology or class B is having obstructive pathology. So by that, future any respiratory complications we can find out in the cirrhotic patients.
How will it help us? See, the patient has come to us in a Child-Pugh score C. He is a severely ill patient. Now, if he has a obstructive or a restrictive pulmonary pattern, how will it help? How it's going to help you in your management of the patient of cirrhosis of liver? Any idea? That is where the relevance goes in, no?
Ma'am, my main aim was
okay, fine, absolutely. Fine, Dr. Somanam. Thank you so much. Thank you. Now we would like to invite on stage Dr. Archana Samal.
Good morning, everyone. Myself, Dr. Archana Samal. I'm third year PG resident from IMS and Sam Hospital. My paper presentation is study of reticulocyte hemoglobin content in diagnosis and differentiation of various type of anemia in CKD patient. It is a cross-sectional study. The prevalence of anemia in India among the patient of CKD is around 87%, where the prevalence has increased from the stage 1 to stage 5 of CKD. Anemia also affects the morbidity and mortality of the CKD patient by accelerating the disease progression and reducing the survival rate. Anemia of chronic disease is easily confused with the iron deficiency anemia because both type having low iron level in the blood. It is very difficult to differentiate between the anemia of chronic disease and the iron deficiency anemia, and those having both the condition of iron deficiency and anemia of chronic disease. Bone marrow aspiration and stained with Prussian blue considered the most accurate method, but it is an invasive method. Measurement of the soluble transferrin receptor protein is a good indicator to know the functional iron status in the body, but not interfere with any systemic or chronic long-term illness. Measurement of the soluble transferrin receptor divided to the log of ferritin also useful indicator to differentiate between the iron deficiency and anemia of chronic disease, but it is very expensive and not available in all the centers. Reticulocyte hemoglobin content, which is a reliable marker for cellular hemoglobin and directly estimate the functional availability of the iron in the erythrocyte. The value below the range indicate the decreased amount of iron in the RBC or iron deficiency. Reduction in the fraction of indicate iron deficient erythropoiesis even in the condition in which traditional biomarkers such as ferritin, transferrin are inadequate. Example, in case of inflammation or anemia of chronic disease. The good thing is the reticulocyte hemoglobin content is not affected by the acute phase reactant. It is very cheap, easily available and not invasive method for the diagnosis. My objective of this case is to assess the role of reticulocyte hemoglobin in differentiating the various types of anemia in chronic kidney disease patient. The study design is cross-sectional study that is done in the medicine department of IMS Sam Hospital, Bhubaneswar, and the study duration is 15 December 2021 to 16 June 2022. The sample size we have taken total 202 CKD patients, and the sample technique is universal sampling technique method. Inclusion criteria, all the CKD patients were admitted in the medicine ward. Exclusion criteria, those in patient who is having malignancy and medical treatment affecting the hematopoietic stem cell, hematopoietic systemic disorder, and below the 18 year of age, hematological disease, and those who are receiving blood transfusion in last 4 months, thalassemia trait and sideroblastic anemia also excluded. Study tool, we are taking CBC with RBC indices and ESR, CRP, iron, serum iron, ferritin, and reticulocyte hemoglobin. Then the result, we are taking the hematological and biochemical parameter of all the patients. In all three groups, iron deficiency anemia and anemia of chronic disease, and both anemia of chronic disease with iron deficiency anemia patient, we are taking the red hemoglobin, which was negatively correlate with the serum transferrin receptor protein, and it was positively correlate with the serum ferritin, serum iron and transferrin saturation. There is very poor correlation between the red hemoglobin and severity of anemia and grading of CKD from the Cockcroft-Gault formula. The cutoff value for the red hemoglobin with serum transferrin protein is more than 1.76 milligram per liter was 23.5 picogram, sensitivity of 86.8% and specificity of 79.8%. The cutoff value for red hemoglobin with serum transferrin protein of more than 0.76 milligram per liter was 26.2 picogram, that is sensitivity of 86.9% and specificity of 84.7%. Here we are seeing the ROC curve depicting the red hemoglobin and transferrin saturation protein. Then if the patient of anemia with CKD patient will go for biochemical and clinical evidence of the inflammation, then CBC with red hemoglobin level. If less than 23.5 picogram, then this is iron deficiency anemia. If 23.5 to 26.2 picogram, then anemia of chronic disease with iron deficiency anemia. If more than 26.2 picogram, then that is anemia of chronic disease. To conclude our study, we found the CKD patient with pure iron deficiency and with pure anemia of chronic disease, and with anemia of chronic disease and iron deficiency combined. Group can be distinguished by the using the cutoff value of red hemoglobin, serum ferritin and soluble transferrin receptor protein with high sensitivity and specificity. Approaching the red hemoglobin would be the cost effective in our country with financial constant basis. Thank you.
Thank you, Dr. Archana. That was a very interesting presentation. So red hemoglobin, the cutoff which you found was as per your study. Does it match with the other studies?
Yes, ma'am. Actually, we are comparing with the transferrin receptor protein, which is previously we are considering. By comparing this, we are taking less than 23 and more than 26, and in between we are the combined group. We are taking, that is the this value.
So what do you understand primarily by red hemoglobin? What does it mean? The reticulocyte hemoglobin, what does it mean? And is it a part of the routine CBC that we do?
Ma'am, reticulocyte hemoglobin content will look for the iron. If we are in CKD patient, if we are giving any iron injection or anything which we are giving, then we can check from the red hemoglobin within 2 to 3 days. We can see the iron content in the blood. But if we are going normally in CBC, it will reflect after 2 to 3 weeks. But in after giving the iron transfusion, within 2 to 3 days, we can look for the iron content in the blood.
So you'll advise this red hemoglobin in all the CKD patient, whether
Yes,
that you should advise this.
Cost effective, ma'am. We can
As a
do
marker
CKD
for
patient.
evaluation of anemia.
Yes, ma'am. The evaluation anemia, so that we can normally we can differentiate from the anemia of chronic disease and iron deficiency anemia. So we are not.
So what you'll advise to your pathologist, what you'll write in a prescription.
Ma'am, CBC with red hemoglobin.
Yeah, sorry.
Complete blood count CBC with red hemoglobin.
With red hemoglobin. The cost would be?
300, ma'am.
Okay. Thank you. We'd be calling upon Anna Medibula. Oh. Yeah, please.
Good afternoon, everyone. I'm Anandal Vamsi Krishna. Today I'm going to present is it time for evaluation of iron deficiency in all patients with heart failure. My guides are Dr. Chandanda sir, Dr. Soumya Ranjan sir, and head of the department, Dr. Samir Sahul sir. Introduction. Heart failure actually is a chronic inflammatory state. It causes absolute and functional iron deficiency. Heart failure is a chronic inflammatory state. It causes a functional iron deficiency due to increased expression of hepcidin and increased expression of hepcidin that suppresses the ferroportin, causing functional iron deficiency anemia. Also, there is an absolute iron deficiency anemia due to cardiac agyxia or some GI blood loss due to use of antiplatelets. Actually, iron is an important part of hemoglobin, myoglobin, and some other important part of enzymes like catalase, aconitase, and ferrocolitase. These enzymes play an important role in the citric acid cycle and also the cellular level, cellular respiration of the mitochondrial respiration. So, if iron is getting depleted, means all these enzymes get depleted, and there is more increased chance of cardiovascular incidence. And iron deficiency occurs in the stages of 3 stages: pre-latent, latent, and anemic stages. In first stage, that iron gets depleted, but hemoglobin is normal. In the third stage, the iron is reduced and hemoglobin is also low. So, if you see in a heart failure patient, if you see iron profile in the first stage only, if we can see that iron will be low, but hemoglobin is normal. So at this point, if you give a transfusion of iron, there will be reduced hospitalization, and there will be chance of reduced hospitalization. My study size is about 100 individuals were selected. It's a cross-sectional study. Patients, OPD patients and IP patients, basing upon the NT-proBNP and echo, heart failure is confirmed. And in that patient, blood picture is done, whether to see anemia is there or not. If patients are non-anemic, that patients are selected, and then they are sent, and then iron profile is done among these patients. Inclusion criteria: patient with symptoms of heart failure by 2D echo and showing decrease in preserved ejection fraction with raised NT-proBNP levels, and patients with heart failure having hemoglobin levels. That is, these are non-anemic patients. That is 13 in males and 12 in females. Exclusion criteria: heart failure patients with chronic kidney disease and heart failure patients with recent history of blood transfusions and pregnant females with heart failure. Results: about 100 patients were studied, out of which with heart failure with non-anemic patients are studied, out of which 53% are males and 47% are females, and iron deficiency is occurring in 60% of patients. Among that 60 patients, 32 patients are having absolute iron deficiency anemia and 28 patients are having functional iron deficiency anemia. This is the ejection fraction less than 40% and 40 to 50%. Conclusion: discussion, even if the patient hemoglobin is normal, with heart failure, if you see the iron profile, there is a chance of having low serum iron level. At this point of time, if you give your iron infusion, there is betterment in the patient's life, or like improved oxygen consumption or 6-minute walk test like this. So my conclusion is I try to emphasize that to study iron profile in non-anemic patients with heart failure when even hemoglobin is normal.
Yeah, what would you advise? You said non-anemic patients of heart failure should be evaluated for iron deficiency. As a therapeutic measures, what you mentioned, has there any studies with infusion, iron infusion or oral supplementation?
Actually, there are studies, ma'am. Before studies are giving iron infusion in anemic patients with heart failure. That improved the 6-minute walk test and further things, ma'am. But normally,
study you haven't.
No, this is a cross-sectional study. I want to actually. We will do iron profile only in when low hemoglobin patients, that is anemic patients. But when a patient is having heart failure, even when the hemoglobin is normal, if you study the iron profile, there is a chance of low ferritin, means depletion of iron, ma'am. At this point only, if you give iron in infusion, there is next anemia won't occur, and anemia if it occurs, it exacerbates the heart failure.
But usually in these coronary patients and patients with heart failure having baseline lot of other problems in the heart, the ferritin is usually elevated as a marker of inflammatory. So it would be difficult to identify this group of patients who have a reduced ferritin. That would
patients, that's what, ma'am. It is called functional iron deficiency, where normally if absolute iron deficiency is ferritin less than 100 nanograms per ml. But functional iron deficiency, we will take a cutoff value of 300 because ferritin will be mildly elevated due to other conditions. So we will take a cutoff of 100 to 300. Absolute is less than 100, functional is 100 to 300, I mean less than 300. And at that point of time, if we calculate the serum transferrin saturation, like serum iron by TIBC into 100, we can get a transferrin saturation around less than 20%, and you can label it as a functional iron deficiency.
But then that would not be a very severe iron deficiency because hemoglobin has still not gone down. So would you like to give correct it by intravenous or just oral?
No. Oral. Actually, there are studies. Oral iron is not that effective as intravenous iron, ma'am. But at this point, if you
but it should be required also. No, efficacy is one thing. Other thing is it should be required. It should be an indication to give an intravenous therapy. No.
Yes, ma'am. If the patient is having functional iron deficiency, at this point only, if you give replace iron.
By how replace how?
Intravenous iron, ma'am. Intravenous iron, already studies are there in anemic patients with heart failure. Anemic patients with heart failure.
How much you would like to replace?
1 gram over 3 grams, ma'am. 1 gram per week.
1 gram.
1000 mg.
See, I just want to ask one thing. What is the recommendation for IV iron therapy in any patient? In which set of patients you recommend IV iron therapy?
Sir, iron deficiency, patient having iron deficiency, then we will recommend severe.
All iron deficiency?
Severe iron deficiency.
No.
Even in severe, there is.
See, one of the indication is that anybody who is intolerant to oral iron therapy, that becomes an indication for IV iron therapy. There is no straight away indication for the oral iron therapy as far as I know, but if there is any other indication for the IV iron directly without replacing, unless until the patient is having CKD, you are giving erythropoietin.
And 1 gram would over how many sittings? You cannot give 1 gram with that.
1000 mg per sitting. That like
1000 mg per sitting.
1 gram.
Okay, fine, Dr. Anima. Thank you. Do we have the next speaker, Tamineni Roja? Dr. Tamineni Roja.
became a global burden, and it is diabetic peripheral neuropathy is a significant complication of diabetes mellitus patients. And now the study being the relationship between vitamin D and the progression of diabetic peripheral neuropathy. Aims and objectives. The study aim is to find the relationship between serum vitamin D levels with peripheral neuropathy in type 2 diabetes mellitus patient. Objectives: to estimate the levels of vitamin D in patients with type 2 diabetes mellitus, and to assess the level of diabetic peripheral neuropathy in type 2 diabetes mellitus patients, and to compare the levels of vitamin D in type 2 diabetes with and without neuropathy. Study design: it is a case control study. The sample size being 132, out of which 66 were taken as cases and 66 were taken as controls. And the assessment of diabetic peripheral neuropathy was done by neurodisability score and nerve conduction studies and vibratory perception threshold. Allocation into groups: the subjects with diabetic neuropathy of any grade and severity were taken as cases, and the subjects with diabetic and no neuropathy were taken as control groups. And matching of age and gender was done for both the groups. And here you can see that study subjects, there is a slight female preponderance, with most of the study subjects being in the age group 41 to 60 years. And it is glycemic control. Good glycemic control is noted in these study subjects, with poor control is noted only in few subjects. And duration of diabetes being, most of the study subjects are having 5 to 10 years of duration. And diabetic peripheral neuropathy in case groups, only few subjects are having severe neuropathy, and most of them are having mild neuropathy. Here, glycemic control, there is a good glycemic control in diabetic patients with no neuropathy, and there is poor control compared to without neuropathy patients in neuropathy. And vitamin D levels are significantly lower in cases when compared to control groups. And the vitamin D levels are significantly lower in diabetic neuropathy patients with severe intensity when compared to no neuropathy, mild and moderate intensity neuropathy. Discussion: age and gender distribution were matched, so that there was no significant difference between the groups, and the vitamin D levels were significantly lower in subjects with diabetic peripheral neuropathy, and then poor glycemic control was noted in subjects with diabetic neuropathy. And there are studies done with lower levels of vitamin D noted in diabetic peripheral neuropathy patients in compared to diabetic with no neuropathy patients. And recommendations: the present study with previous clinical studies demonstrated that vitamin D deficiency is an independent risk factor for peripheral neuropathy in diabetics, and the vitamin D level can be used as a surrogate marker to detect diabetic peripheral neuropathy. The limitations for this study is, as it is being a retrospective study, so we can't establish cause-effect relationship between vitamin D deficiency and diabetic peripheral neuropathy. If it had been a prospective study, we could have established it. These are my references.
Diabetes itself has it shown, the studies have shown to be associated with vitamin deficiency. How do you correlate this deficiency, which is already there, with the peripheral neuropathy?
Already, vitamin D deficiency can also cause neuropathic symptoms, and diabetic patients also prone for neuropathy. If we evaluate for vitamin D levels, and if they are significantly lower, if we supplement vitamin D, so that we can decrease the burden on.
So one line message out of your study? You recommend vitamin D assessment level in all patients of diabetic peripheral neuropathy?
Yes, ma'am.
Thank you.
Next presenter, please, Dr. Uppu Pooja.
Good morning. Myself, Dr. Uppu Pooja, presenting a paper on study of acute undifferentiated febrile illness spectrum in a tertiary hospital in eastern India. My guide, Professor Dr. Subhash Chandra Das sir, head of the department, Dr. Samir Sahu sir. Introduction: infectious diseases are leading cause of morbidity and mortality in tropical countries. In resource-limited settings, fever may be treated empirically or self-treated due to lack of access to diagnostic tests. Fever is one of the common presenting symptoms in clinical practice. Thus, knowledge of local prevalence of infections is critical in order to target clinical workup and treatment. Classically, fever of unknown origin was defined by Petersdorf and Bisons as a temperature above 38.3 degrees Celsius or 101 degrees Fahrenheit on several occasions over a period of more than 3 weeks, for which no diagnosis has been reached despite 1 week of inpatient investigation. The term acute undifferentiated febrile illness connotes fever of less than 14 days duration without any evidence of organ or systemic specific etiology. Aim: the study aims to determine the clinical profile, etiology, and outcome in patients presenting with acute undifferentiated febrile illness. Objectives: to study the etiology and clinical profile in patients presenting with acute undifferentiated fever, to analyze in-hospital mortality and duration of hospital stay in patients with acute undifferentiated febrile illness. Study design: prospective observational study, study site IMS and Some Hospital, Bhubaneswar, study duration 1st November to 31st October, study population all patients with fever of duration less than 14 days without an apparent focus of infection after an initial evaluation of medical history and physical examination. Sample size calculated to be 184 patients with confidence level of 95% with margin of error 5%, assuming prevalence of common infectious diseases of 34%, rounded off to 200. Inclusion criteria: patients aged above 18 years, patients presenting with acute undifferentiated febrile illness, presenting with fever of less than 2 weeks duration, and no apparent focus found after initial evaluation. Exclusion criteria: with multi-organ involvement, immunological diseases, malignancies. Gender distribution in my study: male patients are 61%, female patients are 39%. Age distribution: 18 to 40 age group 47%, 41 to 60 age group 33%, more than 60 20%. In my study diagnosis, most common is dengue, followed by scrub typhus, chikungunya, malaria, leptospirosis, and some cases are undiagnosed, which is referred as pyrexia of unknown origin. Presenting symptoms in study subjects: fever is the most common presenting symptom, followed by fatigue, myalgia, cold, and rash. Presenting signs in study subjects: hepatosplenomegaly is the most common presenting sign, followed by hypoxia, petechiae, shock, and neck rigidity. Outcomes in my study subjects: most death is seen in dengue patients, followed by malaria and enteric fever. My present study showing most common prevalence in Eastern India: dengue, followed by scrub typhus, malaria, chikungunya, and enteric fever. Other journals referred: Abhilash et al., which is conducted in South India, showed scrub typhus is most common, followed by dengue, malaria, enteric fever. Jung et al., which is performed in non-endemic area of scrub typhus, enteric fever, malaria, tuberculosis. Crispal in South India, scrub typhus, malaria, enteric fever, and dengue. Conclusion: men compromised of majority of study subjects. Most of the subjects were aged 18 to 40 years. Dengue was the most common diagnosis, followed by scrub typhus and malaria. Leptospirosis was the least common. Diagnosis could not be established in 1% of the cases. The total mortality was 6%, seen mostly in dengue cases and malaria cases. Thank you. These are my references.
So your definition was any fever of less than 14 years where no focus was found. But your results were including dengue, scrub typhus, so everything is comes positive. Then how can you include it?
On the day of presentation, there is no focus to specific etiology. In hospital study, after 14 days or within the 14 days, patient will come to diagnosis as dengue or malaria.
Is it not included that after investigations being done for around 3 days, if there is still undiagnosed, then it comes under the category? Because on the day of patient when comes to you any fever, that means you are including all fevers, because when the patient gets admitted he will not have any test done. So how would you know what is the cause? You have to get the test done. Okay, fine. Okay, thank you, Dr. Uppu.
Next speaker, please, Dr. Neerukonda Shriteja. And Dr. Vishnu Shivam, you also be ready. You will present after this.
Multisystem inflammatory syndrome in adults. I'm from postgraduate from Department of General Medicine, Kasturba Medical College, Manipal of Academy of Higher Education in Mangalore. I'll be presenting it under Dr. Basav Prabhu. Coming to the introduction, multisystem inflammatory syndrome is a rare but severe complication of SARS-CoV-2 that can occur around 2 to 12 weeks after the initial infection. It was characterized by in children initially but later reported in adults. It was first identified in children in UK hospitals manifesting as a Kawasaki-like illness with a rapid rise of cases and expanding knowledge of the disease. Similar illness was observed in young adults, contradicting the belief that this was restricted to children and gained the term multisystem inflammatory syndrome in adults. But CDC suggests treatment with steroids, IVIG, but there were no specific guidelines for whom to start these. Coming to the definition and diagnostic criteria of multisystem inflammatory syndrome, which includes patient aged more than 21 years, hospitalized for more than 24 hours, or with an illness resulting in death, who meets the following clinical and laboratory criteria. The patient should not have more likely alternative diagnosis for further illness like bacterial sepsis, exacerbation of the chronic medical conditions. Clinical criteria include subjective fever or documented fever for more than or equal to 38 degrees centigrade for more than 24 hours prior to hospitalization or within the first 3 days of hospitalization, and at least 3 of the following clinical criteria occurring prior to the hospitalization or within first 3 days of hospitalization, and at least one must be a primary clinical criteria. Primary clinical criteria include severe cardiac illness, include myocarditis, pericarditis, coronary artery dilatation or aneurysm, or new onset right or left ventricular dysfunction with LVEF less than 50%, second or third degree AV block or ventricular tachycardia. Cardiac arrest alone does not meet this criteria. Rash and non-purulent conjunctivitis are also included. Secondary clinical criteria include new onset neurological signs and symptoms, which include encephalopathy in a patient without prior cognitive impairment, seizures, meningeal signs or peripheral neuropathy, shock or hypotension not attributable to medical therapy, abdominal pain, vomiting or diarrhea, thrombocytopenia less than 1.5 lakh platelet count. Laboratory evidence include evidence of SARS-CoV infection or a past infection. CRP, ferritin, IL-6, ESR or ProCal should be elevated. Coming to my study details, 4 patients tested positive for SARS-CoV-2 at admission, while 4 patients had previously tested positive for SARS-CoV-2 PCR or NAT 18 to 50 days before admission. All the patients had significantly elevated SARS-CoV-2 immunoglobulins at admission. Ferritin was elevated in all of our patients, ranging from 206 to 2368. ESR is elevated in all my patients from 17 to 87. These are the normal references. CRP is elevated in 11 of my patients and LDH in 6. D-dimer is elevated in all of my patients, whereas platelet count was reduced in 8 of my patients. I included 12 patients in my study till December 2021 when I got the ethics clearance. Coming to my case details, here are the case details. Case 1 is a 32-year-old female who presented with fever, abdominal pain for 14 days and hypotension on admission. 2D echo, CT abdomen were normal. We didn't find any other cause of hypotension on admission. Patient was started on only methylpred and discharged on 5th day of admission. Coming to the case 2, it's a 55-year-old female presented with fever and hypotension. Ferritin was 1336. ECG showed atrial fibrillation on day 3 of admission. 2D echo was normal. 2D echo was showing mild TR, pulmonary artery hypertension. We got a CTPA done, which was normal. Hypotension and atrial fibrillation are the findings in these patients. We treated this patient with methylprednisolone, inotropes, amiodarone and anticoagulation. Coming to the case 3, patient presented with headache, aphasia, altered sensorium, unresponsiveness for 1 day. Thrombocytopenia on labs and ferritin is 2368. Direct hyperbilirubinemia was present. ECG was normal, 2D echo was normal. We got an MRI brain which contrast, which showed a bilateral coronary radius central semioval and splenium of the corpus callosum, flare hyperintensities and diffusion restriction. We diagnosed the metabolic encephalopathy. Patient was treated with only methylpred, inotropes and anticonvulsants. Patient got discharged in a stable state. Case 4, patient presented with fever, sore throat and for 3 days duration and hypotension on admission. Ferritin was elevated 2345 and with a direct hypobilirubinemia. Patient was found to have atrial fibrillation on admission. ECG showed 2D echo, dilated LA, RA with thin rim of pericardial effusion. Patient was treated with inotropes, methylpred and amiodarone, and patient got discharged. Coming to case 5, it's a 31-year-old female who presented with maculopapular rash, altered sensorium, hepatosplenomegaly, found to have ferritin of 1900 with a SDOT of 7074 and SGPT of 5380. Ultrasound showed hepatosplenomegaly and severe hepatitis, and patient was treated with methylprednisolone and discharged. All these are pulse therapy of steroids. Case 6, it's a 52-year-old female, generalized weakness, weight loss and hypotension on presentation. Ferritin was 1282. Echo showed mild MR, AML tip prolapse with a mild PAH. Patient was treated with methylpred and discharged. Coming to the case 7, 21-year-old male presented with fever and breathlessness, thrombocytopenia on admission, ferritin 1682, direct hyperbilirubinemia, ECG was normal. 2D echo showed a new onset severe LV dysfunction. CT showed a 15/25. Patient developed a bilateral facial nerve palsy, truncal and neck muscle weakness with severe myocarditis with significant LV dysfunction on 4th day of admission. We treated this patient with pulse therapy of methylpred, IVIG, 100 grams over 2 days, and tocilizumab and noradrenaline and inotropes. Patient got discharged. Later, post follow-up, after 2 weeks, patient came with in a regular state of health. Case 8 is an 18-year-old male who presented with generalized rash, diarrhea, and ferritin was 810, urea was 93 and creat was 3.18. ECG was normal, 2D echo was mid and inferior wall more echogenic, ultrasound showing hepatomegaly. AK was there
Dr. Shriteja, if you can go to your discussion and the conclusion slides, because what is the takeaway? Go to your discussion because you are running out of time, already 6 minutes.
Sir, just 2 minutes, sir, have a good case next. We'll go to the case 9 directly, which is a 29-year-old female presented with breathlessness, jaundice, and involuntary movements involving eyes and difficulty in walking. Ferritin was 365, borderline LVH, dilated LA, MRA brain normal. This was a obsoclonic myoclonus movements on examination. Patient was treated with methylpred and noradrenaline and IVIG on discharge. Other patients, these are the obsoclonus myoclonus movements of when the patient presented. On admission, this was on admission. This was 1.5 months after the, This was 1.5 months after the follow-up. Patient improved significantly. Should I play it?
Yeah, it's already playing. Please conclude.
Coming to the pathogenesis.
No, you'll have to conclude, please.
Okay. My limitations are ANA and ARIA and other investigations required for the CTD are not done on our study. I conclude higher degree of suspicion after extensive investigations with the blood cultures, PCRs and spot tests. We have ruled out other causes of hypertension. Then we came to a diagnosis of multisystem inflammatory syndrome in adults. On-time diagnosis and appropriate treatment with pulse therapy of steroids and IVIG in a patient with a myocarditis and a CNS manifestations made us reach these diagnoses, and the patient improved significantly.
Did you look in for scrub typhus in this patient of obsoclonus myoclonus?
Yeah,
because we see scrub encephalitis coming with classical and responding very well to methylprednisolone.
Yes, ma'am. Actually, in KMC Mangalore, we have multiple scrubs coming there. So we ruled out all the things.
So it was negative?
Rickets. Everything is negative, ma'am.
Was the patient treated with doxycycline or azithromycin?
No, ma'am.
Okay. So what is the underlining factor which we should know for this multi-inflammatory disorder, MISA, that you are indicating? What are the 3 points that should be there which would make us think that this could be it?
Antibody titer, immune dysregulation, and young age.
Which antibody titer?
And SARS-CoV, IG.
SARS-CoV positive, so that's okay. SARS-CoV positive, not antibody. Okay.
SARS-CoV antibody was positive in all the patients. Most of the patients had a significantly elevated titer, ma'am. And none of them...
SARS-CoV positive, you are correlating with that. And?
Elevated inflammatory markers, CRP, ferritin, LDH, or D-dimer is also elevated because of the underlying prothrombotic state. Then
Were the patients given anticoagulants?
few of them received, ma'am. Who developed atrial fibrillation had received anticoagulation. Other than that, none of my patients received anticoagulation.
Okay, thank you. Thank you, Dr. Shritaja. So we have one more person remaining, Dr. Vishnu Shivam.
A systematic review and a meta-analysis on the role of salt taste receptors and its genomics in salt taste sensitivity and preference. So as we all know, salt intake plays an important role in the development and management of hypertension. So this regulation of salt intake is partially due to the genetic variation in salt taste receptor genes, which is related to homeostatic sodium regulation and hedonic responses to salt taste. There are two channels identified as potential salt receptor channels. They are epithelial sodium channel, ENaC channel, and TRPV1 channels. Any mutation or polymorphism in these genes will result in higher salt taste threshold, which leads to lower salt sensitivity, which leads to higher salt preference. This explains the individual variation in the salt perception and the intake. So our main objective is to identify the relationship between single nucleotide polymorphism of salt taste receptor genes, that is ENaC and TRPV1, in the salt taste threshold and preference. A systematic search and PubMed database was carried out using MESHTEM's article, which assessed the direct relationship between this panel of SNPs in salt taste receptor genes and psychophysical measures of salt taste modality outcome were included. The review was carried under the guidelines of PRISMA and registered in Prospero. There are 81 records identified through Midland database sets, 3 identified through citation matching. Finally, 3 studies were included. The exclusion criteria are shown here. 30 duplicates were removed and 51 were removed, excluded with reasons such as 2 not in English language, 8 were reviews, 40 not relevant to our study, 1 doesn't have sufficient data. So these are the characteristics of 3 studies included in our systematic review. So as it comprises of 427 sample size. Out of these SNPs, there is an association of 9 SNPs related with the taste modality outcome. So the studies were quality assessed by the Newcastle Ottawa School, and they were considered high quality if they have a total score of more than 7. So this is the forest plot comparison of association of salt taste receptor genes and salt taste outcome. A non-significant low heterogeneity of high-score value 37% is associated with the meta-analysis outcome, and these SNPs have a relative risk of 0.28. That is 28% individuals having these SNPs will have impaired salt taste sensitivity. That means low sensitivity, which leads to higher salt intake, which is significant. P-value is less than 0.05. So the studies revealed that single nucleotide polymorphisms in the salt taste receptor gene TRPV1 is significantly associated with the salt taste threshold and preference. And these SNPs are shown here, these reference IDs, which increases the risk of salt taste threshold and lowers salt taste sensitivity by 28%, which obviously leads to 28% increased risk of salt intake. SNPs in ENaC channel modify suprathreshold sensitivity, but there is no significant relationship between this SNP and salt taste threshold. So in conclusion, this study provides a new insight on the role of polymorphisms of salt taste receptor genes and their effects on salt taste threshold. So currently, current knowledge about the risk of hypertension doesn't include these polymorphisms. So further research will help in understanding the potential role of these polymorphisms as a biomarker and development of targeted dietary therapies for hypertension. This study does have some limitations. The number of studies available were limited. Despite the limitations, this represents a first systematic effort into the role of single nucleotide polymorphisms influencing salt threshold and preference. These are my references. Thank you. Thank you for giving.
Very absolute. So we had a very good time, and a very nice, novel, informative. Many of the sessions were very good. So congratulations to all of you. Thank you.
much. A very, in fact, good afternoon to one and all. With such a nice brainstorming papers, we are now with our very important session, a session which is focused on next generation health, and that is adolescent nutrition. And for that, I would like to invite our chairpersons for the session. The first one is Dr. Manoj Kumar Shrestha sir. He is the leading diabetologist of the country. Give a round of applause for him. And we are with our next chairperson who is just coming into the hall, and we'll wait for him. Meanwhile, I'll ask Dr. Manoj Shrestha sir to please come up and chair the session. The next chairperson is Dr. Anuj Maheshwari sir, and we'll definitely going to come up with him in a while. Meanwhile, I would like to ask our chairperson to invite our speakers for the session. So we are with our next chairperson even, and he is the governor of ACP India chapter. So please give a round of applause to our chairpersons. So the session is for you.
Moderator Amit Gupta. CV of Ma'am Nambiar, please.
Where is Professor Nambiar? Is she here? Yes, please. So, next session is on the adolescent nutrition. Professor Nambiar, Vanisha Nambiar, she is a well-known nutritionist and professor of nutrition science at Sayaji Rao University at Vadodara. Am I right? So, she will be speaking on adolescent nutrition. Adolescent nutrition is a thing which is very much required in not only in our country but in every country, and very little is being done, because many of the times the specialty merges here, like pediatrics and medicine. General medicine, people thinks that this is a business of pediatrician, and pediatrician thinks that this is a business of the general medicine or physician. So many of the time this remains a neglected issue of the adolescent nutrition, and we are really thinking in this direction. ACP has started thinking in this direction to make things more useful and make things more to be, we can say that it should be deliverable on the forum of ACP India chapter. If we can do something, for adolescent nutrition nowadays, because of the advancement of the technology, nowadays because of thinking of our adolescents is changing, and now they are currently growing very fast as compared to our times. And for all these reasons, nutrition is taking the backside, and this is causing and compromising their health in future life. And probably this may impact in coming days by reducing the life expectancy in the next generation also. They may become more prone to have number of diseases in their life in future, because their nutrition is not being well taken care. In our times, our parents were very much cautious and considerate for our own nutrition. Nowadays also we are considerate and cautious about our kids' nutrition, but our kids are not really that much. Even in MBBS, I was discussing with Professor Narsingh Verma once upon a time, even in MBBS, we don't teach our future doctors how to handle the nutrition issues. Only a small chapter remains in community medicine books. Apart from that, there is nothing, no training regarding the education of nutrition is there. And they themselves do not follow the nutrition guidelines and nutrition ethics in their own life. I'm talking about our own kids, those who are doing the MBBS, those who are in their medical school days, even those who are even in residency period. They don't follow the nutritional ethics, what should they eat, when should they eat, what is the right time to eat, what is the thing which is injurious for their health. Many of the students starts taking tobacco products when they enter in medical college or engineering college, just to get up throughout the night, just to prepare for the examination. They start sacrificing their sleeps, they start changing their life. There is no point of the exercise, and there is a lot of things there which can compromise and jeopardize their health. I'm talking so long because some technical issue is there, that's why. So, I think what is there, why is not resolving? So this is really causing a harm to our future generation when we jeopardize the issues related to health. So this has came in our mind when we were planning a meeting of ISMN at Udaipur, and Dr. Verma requested me to put some ACP symposia there also. I thought nothing could be better than this topic for providing the support of the ACP and ACP to be supported by the ISMN. So we took the first part of this in Udaipur ISMN meeting, and second part of that event is being done here. That is of the next, you can say the next part of that discussion. Before going for that discussion, we shall be having a talk on adolescent nutrition by Dr. Vanisha Nambiar, in which she will be telling us that what should be done for the adolescent nutrition, what is ideal for the adolescent nutrition, what is required for the adolescent nutrition. After that, I will request that Smita will tell us what we have discussed in our last meeting and what are the points which are remained to be addressed in our last meeting, and those points will be started being discussed here. So this is the agenda of the next 1 hour and 1 hour 20 minutes. So we are looking forward. I hope that technical mishap is resolved. Till then, Dr. Manoj can speak something.
Well, I think the technical glitches have been resolved, and Ma'am Nambiar is there with us to take over this session, and she's an expert in nutrition, and especially I've heard her speak on this very topic of adolescent nutrition at the Udaipur conference of ICMN, and I was really impressed by the way she took over this particular topic. And I hope that today afternoon again she'll probably will be able to express the basic needs that is required of as far as adolescent nutrition are concerned, especially the perspective of our country, and let us see what are the solutions that she has to offer to these problems. Ma'am Nambiar, please.
Hello. Thank you so much, sir. Respected chairpersons, Dr. Anuj Maheshwari, sir, and Professor Srivastav, sir. Thank you so much for giving me this opportunity. Extremely sorry for the technical glitch. Today's topic given to me by ACP India chapter is adolescent nutrition in India, how it is and how it should be. And I bring to you greetings from one of the finest university in Western India, the Maharaja Sayajirao University of Baroda, Gujarat. This is the overview of my presentation. It will talk about the adolescent nutrition scenario, what are the nutrition issues and concerns, what are the Government of India initiatives, and then what can be done. And I'm going to give you the example of one of the projects that we did on school health with support from Diabetes Foundation of India. So, you know that adolescence is a phase of life between childhood and adulthood. And adolescents represent over 16% of the world's population and play a central role in achieving our targets of SDGs by 2030. And therefore, we are it's our duty to focus on this age group because had 1.3 billion adolescents in the world today, and more than ever before, they are making up to 16% of the world's population. These are millennials, they are post-millennials, and they cannot be treated the way we have been treated, or the way we have been brought up. As parents of this age group, you need to be very careful. And India has around 253 million adolescents in the age group of 10 to 19. So what are we actually trying to see? Why are we focusing on this age group? It's because rapid changes are observed in every front, whether it is physiological, whether it is cognitive, whether it is psychosocial, during this period, and which is the second period of growth spurt. And in many ways, these adolescents' development drives the changes in the disease burden between childhood and adulthood. We now have researches which have shown that there is an early onset of diseases, the Barker's hypothesis. Fetal origins of health and disease is very well known. But if you have not taken care of that period, this is another period from 9 to 19 wherein your focus should be there in order to prevent the diseases in later period of life, especially the non-communicable diseases. And now we're going to talk about the nutrition issues and concerns. We know that there is a problem of dual burden of malnutrition in this age group. We have now over 10% of the adolescents who are overweight and obese, and undernutrition has always been a problem. The other issues is anemia. Alcohol, tobacco, drug abuse has also started in this age group. Besides this, very, very poorly reported are the mental disorders, concerns due to injuries and violence among this age group. And then there is unintended pregnancy, there is unsafe sex, leading to STD, HIV and AIDS. We are very happy that as an economy, India is thriving. However, rapid urbanization and urban growth have created vast inequities in this public health sector, and it is paradoxical that there is both undernutrition as well as overnutrition in this country called India. So where is the nutrition which is affected? Well, nutrition influences the growth and development throughout the infancy that we know, but also throughout the childhood, and the transition from childhood to adulthood is the period adolescence, which we really need to be focusing on. So industrialization, urbanization, all has led to faulty dietary habits. Lifestyle pattern has differentiated, and of course the physical activity pattern has been disturbed. We are talking about 30 minutes moderate to physical activity every day. But does it actually happen? Overcrowded cities means small schools. Small schools means no playground, no PT period, no free period. It's just studies, and after school there is a huge burden of doing tuition classes, which is again back to another small crampy room. So where actually is the time for an adolescent? You see 10, 12 standard students, the maximum time spent is in tuition classes. So where is the actual time to grow, to enjoy, to relax? And that is also leading to mental health problems directly that is related to nutrition transition. Now adolescents, therefore, there are a lot of neurodevelopment changes in adolescents, and that is leading to how they actually perceive the risk. Even if you tell them that Maggie is junk, their perception is very different. How they act on communication and risky behaviors, they believe totally by the media, by their peer pressures, and it is very, very difficult to tell them this is right, that is wrong. And here I would like to tell you about the principles of Sigmund Freud, who talks about id, ego and superego. The superego actually is formed and nourished and cherished and very, very strongly implemented in the minds of the adolescents, okay? So they influence their mind, and once they have the mind of their own, it is very difficult for them to change, especially related to the food choices. Now these are the modifiable risk factors which this august audience knows about it. that the busy schedule, increased affordability, availability, media, promotion, peer influence, all these actually influence what the adolescents eat, their type of meal pattern, whether they're eating, and the adolescents generally do not prefer to go out with their family, especially the elder adolescents. They have their own nutshell, they have their own peer pressure, okay? And then there is stress, sedentary lifestyle, reduced outdoor physical activity, about which I have already discussed. So the entire life spectrum and the dietary pattern spectrum is altered during this period of adolescence. And they are influenced by peer more than their parents. There is such perceived social norms that can create a lot of peer pressure, especially related to smoking, to tobacco, to other issues which are very, very common in urban as well as in rural India. And the social media is another havoc which has a direct influence on these adolescents. Nutritionally, another important part is the skeletal growth, and that requires two big nutrients, which is calcium, phosphorus, and a good quality protein. Now we have the India starch studies, which we all quote during our diabetes symposium, that India eats only starch and there is hardly any protein. So growing adolescents, which needs 1 gram of protein per kg body weight, is not able to get that. This is a period of growth spurt, and therefore our studies have also shown there are more stunted children, especially the COVID batch. The growth spurt is reduced, they are stunted, and thanks to the low intake of protein, which is all due to sedentary lifestyle and media influence in this age group. So global scenario of urban nutrition, well known to everyone, so I'm just skipping. We are all talking about overweight and obesity, and we have discussed about these important factors which happen in adolescence, which is stress, the hormonal changes, the growth spurt, puberty also is a very important factor which leads to mood swings. And the nutritional status of an adolescent has a profound impact on the immediate and the future health. And therefore, the end line is you need to have a sustainable, healthy diets. But how do you give that? A sustainable, healthy diet. And if not, there are metabolic aberrations, and the Asian Indians, obviously with low birth weight babies and a poor fetal nutrition, are having insulin sensitivity, they are having increased plasma, and they are at risk for diabetes, which is well known to this group of physicians. So to summarize the overview of issues and concern, the macro as well as micronutrient deficiencies are there in this age group. There are physiological issues, there are psychological changes, and there are eating disturbances. But what needs to be done? We need to break the chain. We need to see that there is an entire life cycle approach which has to be taken care of. There is intrauterine period wherein Barker's hypothesis of fetal origins of health and disease has many, many theories that you need to feed your mothers well in order to ensure that the NCDs can be prevented when he is an adult. But when you look up, even if you don't look up Barker's hypothesis, you look up Indian customs of Garbha Sanskar, you know, God Bharai, 7th month, a mother being sent to, a pregnant woman sent to her mother's house so that she takes rest in the last 3 months of pregnancy. All this it was a part of Indian culture, which in the era of modernization has gone, okay? That last 3 months are the period of rapid growth, and if you take care of the mother, the intrauterine growth can be even prevented. The growth retardation can be prevented. Then we talk, and that will not lead to low birth weight babies, and that will probably not, you know, a good Garbha Sanskar definitely means good gyan of nutrition in the mothers, and that will also lead to prevention of non-communicable disease in the early, later life of life. So another important part in India is the gender inequity and gender disparities. Females being fed at the end of the family meals, females being given less, all the boys getting the best good quality food, and so on and so forth. So we need to do that during the Garbha Sanskar, that yes, in the family it is boy and the girl who are equal. So investing in adolescence brings triple dividends. Number one, better health, for adolescent now means their future is better, the life ahead is better, and also their children are better. So now let's look at the Government of India overviews. We have the National Health Mission, and under that National Health Mission, there is the RMNHCA, where the plus A is the adolescent health. It talks about so many strategies, and among this, the government, which had actually added this A following the call to action, that A, that is adolescent, is important. And that is a strategy which prevents various interventions across the thematic areas, and it links both maternal as well as child health, because earlier adolescent education leads to a better pregnancy, healthier mother, healthy child. Okay? There are different key features of this health systems under the RMNHCA, and one of them is the Rashtriya Kishore Swasthya Karyakram, the RKSK, and under this we have the adolescent friendly health clinics. Now, the huge RMNHCA interventions are 5 into 5 matrices, and of that, the adolescent health is focusing on pregnancy, especially teenage pregnancy, contraceptive prevention, and also they introduce community-based services through the peer educator. One of the RMHCA objective is to strengthen the ARSH clinics and the rollout the National Iron Plus Initiative program, and also promote menstrual hygiene. Because reproductive health, many adolescents do not use sanitary napkins even today in India, and poor reproductive health leads to fungal infections, and that leads to anemia. So even if you give them iron, that adolescent is not going to be healthy. The another one, which is the Rashtriya Bal Swasthya Karyakram, where now many Ayush doctors are being engaged and involved by the government, is also a program which has started by the Government of India. I'm not even discussing about the success of the program because this is not the forum for this, but deficiencies like iron, anemia, vitamin A, D, SAM, goiter, all these two programs, under these two programs, they are supposed to be screening, they are supposed to be treating in school as well as out of school adolescents. And so the priority interventions under the government programs are iron folic acid supplementation, facility-based adolescent reproductive and sexual health services through the adolescent health clinics, and information and counseling of the adolescent sexual reproductive health and other issues, menstrual hygiene and preventive health checkups. But in summary, the execution of the programs have several bottlenecks, and they are limited availability of skilled human resource, low coverage of services, inadequate supportive supervision of the frontline service providers, low quality training, and very poor motivation of the program executors of these two. So what can be done? I'm going to give you a success story which we just completed. This is a work which we did in school, and this work was basically, there was a need to address the complex interplay through comprehensive approach. And how was that approach done? So we had this, I'm sure, yeah, I'm very happy that Dr. N.S. Verma has joined, because he spoke about communication. He said that all the issues in the world are due to poor communication. And this is a model called socio-ecology model, which is a very, very important model when we talk about SBCC, that is social and behavior change communication. So any issues in life, this model works. And we use this model for improving health and nutrition for the adolescents in school, okay? And there are 3 levels, micro, meso, and macro level in this model. So the objectives of this study was to develop a SEM using integration of nutrition knowledge in a school setting, and to execute the SEM in EXO, that is family and community, meso, that is school, and micro, that is individual level for children, for preventing of lifestyle disorders, and to assess the impact of and sustainability of this SEM for prevention in a school setting. So this is the experimental design. We had around 6,472 children, and we had 10 schools, and these are all affluent English medium schools of Vadodara city, and it was a 2-year interactive program wherein use of print, electronic and media was done. So who were the micro level? There were school students. Meso level, there were the staff of the schools, principals, and the exo level were the parents. Now interventions and assessments were done through PowerPoint presentation, handy booklets, and various competitions and activities which were embedded inside the school curriculum. So we did not do anything extra. Within the school hours, using the school teachers, we actually formulated this program, and post-assessments after 2 years, we had food feedback, we had spot observations, and we had key informant interviews. So we had development of SEM, we had execution of SEM, and then we had evaluation of SEM. And during the process of development, implementation and evaluation, all the 3 levels had to be overlaid in order to address this complex integrity. During the development, there was intrapersonal, interpersonal, organization and parent and committee level interventions. And micro level, there were presentation where 6,500 children from 10 schools were trained. Meso level, the school principals and teachers, we had meetings to ensure that this actually goes inside the school curriculum. All schools in their science teachers class had to do in-depth teaching of nutrition to the children. It is there in the syllabus, but it has to be done in a particular manner so that the child understands and then remembers them. That was done. And in the exo level, for the parents and the community, lot of presentations, meeting, discussions, recipe competition, and NHE material, that is nutrition, health, education material was given and shared. Street rallies were also done. So the electronic, print, medias were done, there was skit, exemptor, all these competitions were done inside the school, by the school children, handled by the school teachers. Whether it's science exhibition, health walk, group discussion, debates, drawing, essay, chart, poster making competition. And these are the glimpses of various competitions and health camp that were done in the school. And these are the highlights of the evaluation of the STEM. 22 different types of activities were conducted at micro level. 100% cooperation from school principals and teachers were done at the meso level. And at the exo level, we had many presentations. So overall, a positive feedback. So to conclude, the SEM model is a very interesting, sustainable behavior change communication model. Even if I and my research team are not there, the school teachers have now inculcated and embedded this entire concept in their school curriculum. So it's a very sustainable model. Also, it can be replicated throughout the government as well as non-government schools of the entire country, wherein our adolescents form a major chunk. And obviously we know that the healthy eating program, if made mandatory by all schools, can contribute to today's children, healthy adults across the country. So prevention at the school age can reverse the trend of that lifestyle changes, and prevention programs have to be made culturally sensitive. What works in Andhra Pradesh, what works in Visakhapatnam will not work in Bengal. What works in Bengal will not work in Gujarat. So it has to be very culturally sensitive program, but the SEM model works. And initiative, this comprehensive school-based program and lifestyle interventions can, we're all talking about behavior change communication, and that works. So where are we? We have so many government programs that I mentioned under the Sarva Siksha Abhiyan, the RBSK, the FHC, the RKSK, but still, when we look at the latest NFHS guidelines, we still have huge issues as far as nutrition is concerned. So this model, the coordinated health approach, is the way forward. So from comprehensive, you have to have a coordinated health approach, which includes health education, which includes health services and nutrition services and health environment. And there are many such examples of the United States where the coordinated school health approach have been given. And these includes 8 components: nutrition, health, psychology, healthy school environment, health promotion for the staff, family, community involvement, and health education, which actually works. So these are the various programs which have been successful school programs in the United States, and I can give you names of many others as part of a review, and we're bringing out a paper on this also. And most of these interventions have been conducted with children, and they're focusing on classroom health curriculum, food service program, family and community components. So it is important that we have a coordinated school health approach, and that is what will be the way forward. So thank you so much for your patient hearing, and once again thank you Professor Anuj Maheshwari, Professor Srivastava and Professor Narsingh Verma sir for giving me this opportunity to share my views on this ACP platform. So, thank you so much.
Thank you for giving this exciting ideas in your study, and you are very correct that nothing can happen if we do not start in time. So everything can be done, but before adolescent if we start, then only adolescent nutrition will be effective. Thank you.
Any question? Any question? Yes. Mike.
And overnutrition is a very important problem of school going children, and we are not focusing on that. Number one, our school cafeteria have food which is really not needed to the school children. We must have healthy food cafeteria in our schools. This must be advocated by ACP to Government of India, number one.
Yes, sir.
And number two, the most important point is good parenthood, which is lacking. As you mentioned, coaching, school, bhagam bhag. Agar parenthood अच्छी है, तो we can deal all these problems. In earlier days, there were food habits. सर्दियाँ आएंगी तो बाजरे की रोटी, ज्वार की रोटी मिलेगी. गर्मियों में मठा मिलेगा, सत्तू मिलेगा. We all are forgetting this thing. We must advocate them. Thank you.
Sir, thank you so much. We did the school canteen assessment also. This is a very huge project. I just give some brief, only the SEM model A part in here. But we did we call it food service assessment program. We used the 3 methods for assessment, and we did the categorization of school through all the 8 components of the school health program. And we have given suggestions, and all the schools have stopped mothers from giving anything junk. The school canteen provides healthy foods now, and also anyone who brings tiffin is checked, and we have a do's and don'ts that can be brought to the school by the child. So that has been done.
Thank you, madam. An excellent deliberation. One humble submission. We could think of making physical activity one compulsory in schools right from KG or class 1. That would not only improve our Olympic medal tally in the long run, but also help us to prevent all the non-communicable diseases, blood pressure, hypertension, all those, if physical activity could be made compulsory from junior classes.
So we did that also a part of this project. We had a school health club formation, and in that we had 30 minutes of yoga, 30 minutes of moderate and physical activity, 1 hour before the actual school started, and many school children participated in that. We have the whole data. I think that paper's published also, body composition and the entire biophysical parameter including blood pressure, and we had a difference in the fat composition after the intervention was over. So that, of course, as I said, but many schools do not have a playground, because whatever is a playground are now converted into constructions. They want more classrooms, so that gives more revenue to the school. So that is being, the government norms of having a particular open space is easily been broken by a lot of private schools also.
Very wonderful talk, madam. You appear to have worked in the urban area only. But the actual problem in India is of rural, undernutrition amongst the school-going children. And as you are aware, there are a lot of schemes from the government side also, like midday meal school program and all. So we need to go into the nutritional aspect, macro and micronutrition aspect of those kind of schemes, whether they are really successful or there is some hanky-panky going on, or sadi with dal, sada hua atta, all those things we keep hearing in the news and all. So it's not the any implementation of any scheme. You have to monitor the scheme and quality of the dietary ingredients which the children are getting, and actually is it reaching to the children or not? Because still in India we have 2/3 of the population which is suffering from anemia. Yes. So this is a very severe problem, not only one aspect anemia, but overall the undernutrition is very prevalent among the adolescent school going children, madam.
Thank you, sir. So I did not bring it here because I just wanted to show a model of how we can go forward. I am one of the board members for the government of Gujarat, and I have done 20 projects on the midday meal. I'm basically a public health nutritionist who love to work in the field. So under my observations, we have data of 8 districts of Gujarat, all children's midday meal data. Okay, but I know I've just given what are the issues and concern in that undernutrition is one fact, and I wanted to show what is the way forward. We all talk, there is a problem. So midday meal is a government's program. During COVID also they were given ration. So on paper it's a wonderful program. Execution monitoring, yes, there are loopholes. We have trained all the IS officers, district collectors, MDM deputy directors, everything we have trained. After that 3 months there is a transfer. And the next person who comes on that MDM seat has no idea about MDM. He is waiting for his other transfer. So there are a lot of realities. We have data, we have videos, we have shown the midday meal ration being sold in the as a shop in his own. So his wife is the supposed supervisor of that MDM, and the person, he's a sarpanch of the village, and he's having a shop where all the ration is sold. So when we went for an audit, so I'm an auditor of the government. So when we went for the audit, he said, koi ration nahi hai in the school premises, nothing. Then I said, where do you store? I said, idhar koi store room nahi hai. Then we said, okay, wherever the store room, wo to andar hai, gaon ke andar. Madam, bahut dur hai, aap chal nahi paoge. I said, mera mein problem nahi hai. Bolte 3 kilometer. I said, main chalungi. So I went with the team and I saw the same MDM ration, the same labeled oil tins, the same namak, everything is sold, sir. So how do you do this? So it comes from within. There is so much of corruption in this country, and there is so much of lalach, people to grow more and more. If I have a Maruti, I want a Ferrari, and if I have a Ferrari, I want a BMW. Then what? There is no end to lalach. Schemes are very good, but then there is a good point also. We have schools where the supervisors are perfect. Everything is done. 3 shifts, everything is cooked and served well. And then now, because of that, we have now centralized kitchen. Akshay Patra has now been started in many places of Gujarat, where all the kitchen cooking is done in the central kitchen and distribution is done. But even then, on paper, they will write 30 children, and on that day only 10 children will come. The other food is packed and taken home. Now, nothing can happen to these kind of things. So it comes from within. So somebody has to awaken the conscience of people that this is my duty. Let me do my duty properly. Unless that comes, India will not progress. So in the race of westernization, we are losing our own culture. We are losing our own ethics. We are losing our truthfulness. And the consciousness once lost, it is difficult to revive.
Thank you, ma'am. Thank you for giving such a brilliant, informative lecture. Ma'am, during my own study, and that too in urban government setup school, I could see that we talk about malnutrition so much, but still students are getting enrolled for that food only. So if we are not making that healthy, we are not working on it, those students still have that charm of having that midday meal. And apart from this, what you shared, this was my own experience. But my question is, ma'am, from hunters and gatherers, we became the farmers. We have moved from there to this place where we are eating food which is still we consider is not healthy. And now we are moving, a paradigm shift is taking towards the junk or whatsoever. In our language we call it junk, but it is not exactly the junk. It is the new transformed way of taking food by the adolescent. Whether it is a school going person of a private school or a government school, they all are eating the food which is now locally available, call it noodles, call it burger, call it bantikki, whatsoever. So this paradigm shift is taking place. From hunters and gatherers, farmers we accepted it. Now we are going for this paradigm shift. So what as a nutritionist you will say, should we eradicate this habit or should we try to improvise so that we can go forward with these things into the system?
So ma'am, when I was talking about issues and concern, I spoke about perception. I spoke about how peers actually influence, how social media and media influence the mindset of an adolescent. So if Amitabh Bachchan says, I cannot live without Maggie, and he is the role icon of the whole country, then everybody follows him. So it is false advertisement that we need to stop, number one. And second, if the child insists that I want to have Maggie, please give him. Never say no. And then have a healthy meal option with the family. We are in a fast life. We are not even sitting and eating. If a family of 4 members, everybody eats at their own time. How many of you sit and eat together and enjoy on the dining table? It is on the dining table that all the habits occur. It is on the dining table that all the group discussions and everything happens. So if Amitabh Bachchan talks about social marketing, and if you've seen KBC's episode of his birthday, his wife also does not cut cake on his birthday. His wife cuts the Mama milk cake and no candle is blown. So what they do is for money. What they practice is a different ethic. Okay? So if somebody is marketing something on TV, you can be what we call in our terms of public health nutrition, social marketing. So as a mother, do social marketing, engage grandparents and grandmothers and give them good habits on the dining table, and that works.
Thank you, madam. The discussion is very nice. It can go on, and very valuable suggestions given by you, but the time does not permit us to keep it further. Thank you very much. All the interest shown by the persons who have asked the questions, that is very nice.
So,
Thank you, ma'am, for such a thought-provoking session, and I really want you to join this group's discussion session, ma'am. Please, I want Poonam ma'am also to join us for this group discussion. And
please come.
Dr. Vanisha, you please join us on the dais. And Poonam, you also came this side. Yeah, you come this side, Poonam will come this side, whatever is like.
so, in this group discussion, we are basically focusing the roundtable meet which we conducted in Udaipur in 19th August by ISMN, that is World Congress on Clinical Nutrition and Food and Nutrition, that is ISMN, that is International Society of Medical Food and Nutrition. And this was been a very informative roundtable meet where we have a lot of illustrious experts who are giving their suggestions and recommendations to improve the adolescent nutrition. And in them, we have the whole panel of illustrious people who are Dr. Shelly Awasthi, Dr. Manisha Nambia ma'am, Dr. Ajay Tiwari sir, Dr. Kamlakar Tripathi sir, then Anuj Maheshwari sir was also there, Dr. Shipra Bharadwaj, Dr. Shritish Bharadwaj, Dr. Manoj Kumar Srivastav, Dr. N.S. Verma sir, and they all have just discussed how to improve the adolescent nutrition, and I'm going to give you a summary of that roundtable meet on adolescent nutrition. So we all know that the youth population is supposed to be the largest among the human history, and India is supposed to be having largest adolescent population in the world. And you can see this picture that youth population is just nearly equal to the total population of almost 18 Western Asian countries in 2011. So you can see that how much big population we have to cater and make it healthy for the nation. And the teenagers, you all know that they are now growing up in a rapid changing world because of lots of many things, that is urbanization, globalization, digital media, and more widely available education. And with this, we have a lot of opportunities being generated for the coming generation, and with that we are coming with, there are a lot of health hazards also associated with it. With such a threat, we are threatening their well-being, nutrition and mental health. And you all know, everyone in this August gathering knows about the physiological changes which occur in adolescence. The changes can be a little bit different for different genders, but there are also a lot of transition changes in the body composition, and just because of that we have a very high requirement of nutrition. And because of the nutrition requirement being increased, there is seen that NFHS 4 even said that almost 50% of the teenagers are either wasted, stunted, overweight or obese, and it's very much shocking that almost 80% are lacking in one or more micronutrients, including any of them like iron, folic acid, zinc, vitamin D, vitamin B12 and so on. And so adolescents are supposed to be the most important window period where we can work on to make it healthy. As N.S. Verma sir also said that we shouldn't be looking from the time the child is started with the adolescence, we should be starting from the very early age even. And just because of that, we have our new RDAs 2020, which is highlighting all the nutrients to be taken in consideration according to the current scenario. We have the RDAs, we have the EAR, so that we can get more specific nutrients, and this slide is going to tell you that this new RDA has also been focusing that the adult men and women need little bit less of calories, but the adolescents have to increase their nutrients, especially the calories requirement, so that they can meet their development. So this is with our experts suggestions about the dietary implications, how to implement, how to give the nutrient calories or nutrients to the adolescents. For that, they have suggested that the food should be coming from each and every categories, either energy giving foods, growth promoting foods, protecting foods, and when we see individually what are the energy giving foods, they are various cereals, and the cereals should be at least 8 to 15 servings of at least one serving or of 30 grams. Fats and oils should be at least 7 to 10 servings in a day, and there should be a mix of desi ghee, buttermilk and palm oil, because all the oils have their different benefits, so they were strongly suggesting for the mixing of oils, and the sugars around 2 to 4 servings of 5 grams each. When we talking about the growth promoting foods, the pulses to be at least 2 to 3 servings of 30 grams each, and if the adolescent is going for the non-vegetarian, they should be getting 1 serving of pulses be replaced by 1 serving of eggs, meat, fish, chicken, almost 50 grams each. And the milk and milk products should be at least 5 servings of 100 ml, so that they can get a lot of proteins and good carbs even. The protective foods never been missed, because fruits and vegetables are the most important part, so that they can get their immune system or more stronger. And the fruits that has to be taken at least 2 servings of 80 grams, and prefer more of fruit juices, whole fruits rather than fruit juices. When we talk about the vegetables, they are asking for green leafy vegetable to at least 1 serving, 1 serving of any other vegetables, and 1 serving of all the tubers to be in their diet, in the main diet. Apart from that, 30 grams of nuts, that means just a handful of nuts, are important to get their nutrients, and the fibers, at least 15 to 25 grams coming from the fruits and vegetables or whole grain wheat breads. Water has to be at least 2 liters per day, but if they are going for any of the physical activities, their water intake will be definitely increased. So this can be summarized by this NIN recommended thali, which is my plate for the day. That the plate says that half of the plate should be coming from the fat, from the fruits and vegetables, and rest to be from the proteins and the whole cereals. Now these are the suggestions which we give to the adolescent, and they should be eating this way, but they are always coming out with lots and lots of challenges which we already been discussing few minutes before, and these challenges can be because of the inadequate intake, poor absorption, increased requirements and loss of nutrients, poor utilization of nutrients, infection, poverty, and also practicing food taboos even. So just because of these things, we are turning out to having a lot of, and most of the adolescent population with eating disorders. And you can see this graph which is saying that India is having almost most of the population having a lot of dietary and abnormal eating habits. So these are the eating disorders we all know: anorexia nervosa, bulimia, binging eating, and these are the disorders which I'll not go into. But we should be specific. We should be seeing that all the disorders are very much gender specific. You can see most of the eating disorders are being seen in females rather than the males. And this is the most important, this is the biggest culprit for all the adolescent health, that is night eating syndromes. It can be just because of so much of stress, so much of education burden, and the adolescents has to have a very good score of grades. So just because of that, we are having night eating syndromes. So the experts have came up with this suggestion how to cope up with this night eating syndrome, and for that they are suggesting that they should be planning your meals. The planning should be done because having at least they should be having proper 3 major meals with 2 or 3 healthy snacking, so that they are not eating junk or unhealthy food at night. They should be identifying their triggers. They should be having a food and mood diary, which will help them to see the triggers which affects their eating habits. For example, like if they are having proteins at night and fats at night, they are less prone to get more of hunger or hunger pangs at the night time. They should be always, this is the very important part which I think so one of our delegate also talked about, the parenting part, and this is the most important parents should be looking for, that they should be stocking on the healthy snacks. Readily accessible healthy snacks in the refrigerator will definitely restrict the urge to snack at germs. So a good sleep, definitely it's a part of it to restrict the NES. Brushing. If you insist adolescent to brush their teeth after the last meal, they are less prone to get urging for the junks. And the de-stress activities can help out for the NES symptoms to cope up. So apart from there are various other treatments which I'll not go into it. There are various health professionals which work on the NES adolescents, and they can help to treat them with the medications or with the cognitive behavioral therapy. So another very important point which was being discussed in the roundtable meet was that people doesn't know what are the programs are there, in the government programs are there which are running for the adolescent health. So we should be also making them aware about all these programs, and I think so these programs were also being discussed by ma'am also. They are Rashtriya Kishore Swasthya Karyakram and Poshan Swasthya Poshan Swasthya, which actually emphasize on the which is the modified version of basically national scheme for midday meals in schools, this is also providing the meals. Apart from that, they are providing the education, also nutrition education also. So this is the part which we were discussing a few minutes before. That is the school canteen. Now, school canteen has to be very much giving a healthy recipes, healthy choices for the adolescents, so that they can get a healthy food from at the school canteen only. And the school canteens are being seen that they are getting more of trans fat, unhealthy foods rather than a healthy one. So what exactly is happening? We are having a lack of school food preparations. Though government is working on it also, there are various health programs, that is school health and wellness program, which is launched in February 2020, and this is actually a government and this has been implemented on the government or employment related schools. In this program, what exactly is happening? Every school must designate 2 teachers, preferably a male and a female, as a health and wellness ambassador, who will receive training to communicate with students for an hour each week about the health promotion and illness, and they have to give different awareness programs are there, so that they can get educated very well. Apart from that, there is a Food Safety and Standard Regulation 2020, and this is a very important regulation which is not being aware. We don't be aware about this program, and this is saying that foods which are referred to as a food product high in saturated fat or trans fat or added sugar or sodium cannot be sold to the children in school, and apart from that, they cannot be sold at least 50 meters apart from the premises from all the directions. So it is a very important part, and if any of the unhealthy foods is being sold in the school canteen, you can complain against them also. These are the regulations. What are the suggestions our experts have given? These are the things which the canteen menu should include. And special thanks to Vanisha ma'am, which she very nicely added all the recipes which gives different nutrients in just one recipe. And these are the few recipes which you can ask the school canteen to add in the menu card. Should I start? Should I? So these are the suggestions for the whole week, and now the session is open for everyone to discuss how we can improve this suggestion and come out with the formulating of any of the recommendations.
Ask questions, invite questions. 7 minutes.
I really want to invite questions from the gathering, please.
Or you can ask.
Okay. There are a lot of physicians and clinicians over here. I really want to ask how many people are getting different common complaints from the adolescent patients regarding the health or the nutrition part. Are you getting any complaints regarding the so what are the, I really want to ask
very nice discussion going on about nutrition, and I would like to ask you, what we are going to do that we cannot delete junk food from the diet of adolescent young people, and parents they cannot say no to them for junk food. So what can be done to have good nutrition out of this junk food?
As far as I could understood, your question is like you want to know that how can we improvise on the junk food?
Yep.
Because they're eating it, right?
Yes.
So
We can't
for the junk food, first of all, we should need to have a conceptual clarity which says that junk is what? Junk is one which should not be eaten at all. So the food which children or adolescents are eating right now cannot be categorically said as a junk. We just need to make the unhealthy food has to be made healthy.
Yep.
So first of all, we should define, this definition should be changed for the adolescent that they are not eating junk, they are eating unhealthy, which we have to make healthy. And now for making that unhealthy food healthy, what we can do, we can make it a nutri-dense kind of recipes for them. Suppose if they want to eat their noodles, there is no harm in saying that you don't, you eat. So what we can do, add lots of veggies, try to incorporate the cast iron utensils, because contaminated iron or whatsoever other, instead of using, you know, that vinegar or the soya sauce or the other preservatives, we can always ask to add sirkas, which had been a traditional homemade practices of we Indians. So we can go ahead with that, including lots of vegetables to it. That can make the recipe more healthy. And other thing, like with the noodles, we can come up with a veg roll kind of thing that wrap in a roti and give it. So this unhealthy eating practice needs to be changed into healthy rather than calling it a junk food. Cold drink is a junk food, I agree. Chips is a junk food, I agree. But eating noodles or eating aloo ki tikki or eating chole bhature is not junk, it is unhealthy, which we have to make healthy.
Yes, that's what I want to say, that we should make some policy and some programs in schools, in canteens, so that we can add, because they are tasty foods.
Yes.
You know,
Yes, because in canteens,
Yeah.
samosa is one thing which can be economically purchased by all. But making that samosa filled instead of aloo with chana dal or filled with little bit of paneer might increase its nutritive value. Yes, sir.
So that's very interesting. I want to know, is there any standard definition for the junk food?
Standard definition for junk food. Yeah, anything which is not going to give you any micro or macronutrient except calories can be called as junk food. Right? Otherwise, if any food is giving you a little bit of micronutrients also, the method of cooking is wrong. Making puri is not wrong, but the method is wrong because we are deep frying it, we are adding maida, that makes it unhealthy. But puri is not a junk food. We have to make it healthy by adding vegetables and lot many other things to make it healthy.
I just want to give one more definition for junk foods. All the foods which are very high in fat, sugar and salt. If they are high in all the three nutrients and they are getting a lot of high calories, they are supposed to be a junk foods. So it is not only burgers and pizza or chow mein only the junk foods.
Is there any
Your
cutoff, like for the high in fat, is there any cutoff value for the fat? What should be labeled as high?
whatever the meal you are getting, at least 60% should be coming from your carbs and 20% from fat and 20% from the proteins. This is supposed to be a complete meal. And if that if the fat percentage is more than 20%, definitely it's going to be high. Okay, and last, I think so we have a very less time, so I just want to know a last takeaway message from each and every panelist, please.
Okay. So, I'll suggest that whenever we come across as clinician any patient who is malnourished, especially an adolescent, what is important is not just the correction of the malnourishment, but also to identify the cause for that malnourishment. Especially if you find in a particular family all the other members are healthy and one particular child or adolescent is not really picking up his growth, what is the problem? Then you need to identify that problem, correct that problem, because this is what the clinician's job is. It's not just supplementing them with nutrition. Identify why is it that the rest of the family members are thriving and growing and why this particular child is not doing that. Supplementation with the food, of course, is also part of the treatment. Identifying the cause. Malabsorption is a very important cause, and there are certain diseases which we need to look at. Especially in the Indian situation, always look for worm infestation, because worm infestation is something that is very, very common, and very vague symptoms are there, so you may not be able to identify. Similarly, celiac disease, again, not so common, but we do find that a lot of patients are now being identified because the physicians are now getting more aware about this condition. And what we typically thought of celiac disease is patients having multiple stools and diarrhea and frothy stools and all that. That is a very late stage of celiac disease. The earliest sign could be just an anemia. So anemia could be a signal that this patient might be suffering from celiac disease, and you investigate him for that and you identify the thing. Similarly, in our situation, a lot of infections need to be taken care of. Tuberculosis, of course, is very important. We need to rule out tuberculosis because that is again a disease which can really cause a lot of malnutrition, a lot of weight loss and other things. So my take home message is that whenever we come across a malnourished child or an adolescent, treating the malnutrition is a very important part. An equally important part is to identify why this child is really malnourished. And so if there are any causes that need to be corrected as well.
My one more suggestion, while we are looking for the overall nutritional requirements of the adolescent, we should also take into consideration the drug abuse part even, because that is also one thing which leads to lack of appetite. So we need to consider that also in the holistic treatment or the holistic increment of the nutritional status.
I think now it is time to close this session because 1 p.m. it is there and we have to be ready for official initiation of the conference. In this conference we have kept the free paper sessions before the start of the conference. We have selected few very good papers, very good research for the podium presentation. That will be a kind of the showcase kind of the presentation that will be tomorrow from first half in this hall only. So all of you, those who are very much interested in the research, those who are looking for the youngsters, how they are doing, they can come here. The quality research what the youngsters are doing, they can come here in the first half. Today we have had a very good session of the free paper session. After that we had this adolescent nutrition symposia that has also been very much fruitful. And after this we shall be coming out with a white paper of ISMN combined with the ACP for this adolescent nutrition. So this is a very good constructive things what we could do before the start of the conference. Now the officially conference is going to start. Our scientific chair Dr. Narsingh Verma shall be starting with the opening remarks. He is giving the opening remarks there, but we can see it here also. So wait for 1 or 2 minutes, it will be started immediately, and after that we shall be having our regular sessions as mentioned in the scientific program, the PC Roy Hall and William OSLER Hall. Okay. Thank you very much.
Thank you so much. significance as regards to us, the metabolic physicians. So I'll be discussing that, and meanwhile the slides are being put in. So. As a metabolic physician, we are always overlooking NAFLD, and I think NAFLD is the point, that is what is the basic crux of why we are having so many problems. So if you don't encompass that in what you are looking as a diabetologist or as a metabolic physician, that will be a big issue. And I think now newer guidelines will be incorporating looking for NAFLD proactively by the diabetologist and the metabolic physicians. So this is something which is very close to my heart, because I have already presented many papers on NAFLD at national and international forums, and we did a study at our center, and what we found that around 27% of the patients had advanced fibrosis. So the incidence is very high. The only point is that we are not picking it up. So we need to have better systems. We ought to rely on the serological markers that we have. We should be very cautious when we are seeing these patients, because we have to be careful that if a patient of diabetes is presenting with raised serum markers, AST and ALT values, at least that patient, or a patient who is overtly obese or having a higher BMI or bigger waist circumference, that patient should always be investigated for liver fibrosis. And you know that at every stage, it is reversible. Only when you move ahead from NASH onwards, then it is irreversible. So till the stage of NASH, we can always intervene. And what I am telling you, that the best modality of treatment that we have available is the lifestyle management. So reducing the weight is the best medicine that we have as regards to the management of MFLD. Now I would not like to call it NAFLD because it's MFLD. So whenever you have a metabolic liver disease, you ought to think about this. So finally they have come. Thank you very much. So it was all, as Murthy sir told me, that I had to speak extempore, and I think I have proved that I can do a bit of it even without the slides. So not moving. Okay. So I started with that NAFLD is the lost child, because non-alcoholic fatty liver disease is currently defined as the accumulation of excess fat in the liver in the absence of secondary causes or other liver disease etiologies. So NAFLD or MAFLD is a diagnosis of exclusion. It is the most common cause of liver disease worldwide and is closely linked to type 2 diabetes and obesity. So we have to see it in continuum. We don't have to isolate. So primarily the problem is that basically it is the purview of a diabetologist or a metabolic physician rather than a gastrophysician. So that delineation is important, and lot of crosstalk is needed between the diabetologist and the gastroenterologist as regards to this thing. And NAFLD is a broad spectrum of disease states, and most people with NAFLD have simple cirrhosis with low risk of progression and low risk of liver-related mortality or morbidity. And approximately 10 to 20% of patients can develop the progressive inflammatory form, that is the NASH, non-alcoholic steatohepatitis. And NASH is characterized by lobular inflammation and hepatocyte ballooning. And I think this is the most important thing, because these changes can be picked by biopsy only. So the quest is for the right marker or the right thing, how we can pick up those patients who are shifting to NASH. So that is the $100 question, $1 million question, that how do we identify without performing a biopsy as regards to this. And despite this large disease burden, most people living with NAFLD are undiagnosed. because they are going to the wrong people. The right people would be a metabolic physician, and the disease course prediction is imprecise, and there are no treatments licensed for this condition. So still, lifestyle management is the most important treatment for NAFLD. Still not changing. Okay. So basically, I'll be discussing this in these headings, that is the epidemiology, whether it is NAFLD or MFLD, what is the pathophysiology, and very important, this PPR gamma, PPR receptors are the most important thing when we are talking about NAFLD. Then what are the medications available with us? I have been asked to talk about low dose pioglitazone, so I will be covering that, how we have to do that. So this is how I will structure my talk. So, as regards to the prevalence, globally 1 out of 4 adults have excess fat in liver without any secondary causes. And India, up to 1 out of 3 adults have excess fat in liver without any secondary causes. That the incidence is now around 32%, and it is growing at faster pace. We are having a boom of obesity, 56% patients coming every 10 years. So numbers are being added, and this is what we did at our center, screening for NAFLD in people with type 2 diabetes. So this was a cross-section study, it was printed, and we did the fibroscans to assess the degree advent of fibrosis, and we found that the incidence of advanced fibrosis was of 27.2%, and the patients with and the incidence was 4.9 with a fibroscan scores of more than 11.4. So that is very, very high, and we have to understand that yes, we need to rise up to this. So this was basically an eye-opener for me also, because as a practicing diabetologist, I felt that yes, now it is the time that we should think about NAFLD also. So NAFLD is basically diagnosis of exclusion. So we have to exclude alcoholic hepatitis, drug-induced hepatitis, viral hepatitis, autoimmune hepatitis, and metabolic Wilson and hemochromatosis. So is NAFLD now MFLD? Patients may have more than one etiology affecting the liver at the same time, but the current definition of NAFLD requires that the other causes of disease are excluded. So now the consensus is coming that no, we should think it as a metabolic disease. The increasingly described synergistic effect of multiple etiologies on disease progression is not acknowledged, and recognizing this close association between metabolic risk, this international consensus has evolved, and what they have found that now we will label it like this: the presence of hepatic steatosis plus one of the following, that is overweight or obese, type 2 diabetes mellitus, or evidence of 2 or more features of metabolic dysfunction. So this will be the definition of MFLD now on, and while this reflects the real world burden by selecting the patients with metabolic factors. So this is very important, and metabolic associated fatty liver disease acknowledges the potential for more than one etiology of liver disease, but may also select patients with metabolic factors that increase the risk of liver progression. So we have to think now as a broader picture: the cardiovascular risk, the metabolic profile, the fat in the liver. So all these things are to be added up when we are discussing about this. So coming to the pathophysiology, metabolic inflexibility contributes to dysregulated glucose and lipid metabolism in NAFLD. So overload of high fat and sugar, peripheral mobilization of free fatty acids into the liver, and the ineffective or dysregulated PPR alpha and PPR related uptake, that leads to lipotoxic upload and increased deposition of fat in the liver. So NAFLD and insulin resistance may lead to systematic inflammation. So we have a continuum all across the spectrum, and systematic lipotoxic stress contributes to a cluster of metabolic abnormalities. Inadequate metabolic substrate disposal, that is both the glucose and free fatty acids, that contributes to the excess fat in the liver. And this is now what should be the thing: liver, pancreas, and cardiovascular disease. So they are all intertwined. They are not separate modalities. We have to think they are all one. So this was what we presented at US Endo, the correlation of advanced fibrosis and coronary artery disease risk scores in people with type 2 diabetes. This was the poster there, and there we found that NAFLD, advanced fibrosis, was associated with increased risk of coronary artery disease. Then obesity and insulin resistance are pathogenic drivers. Central obesity, insulin resistance, that leads to NAFLD. So again, we tried to look into this, and we had another paper in 88-2022, and what was the correlation of TG-SDL ratio and liver fibrosis in people with diabetes. TG-SDL ratio is a very sensitive marker of insulin resistance, and this was presented in ADA 2022. So all factors, we know that genes are contributing to the formation, to the progression of NASH, but the environmental factors are also very important. That is the sedentary lifestyle, the modern eating habits, snacking, fast food, saturated fats, trans fats, processed meat. So all are contributing to it. So this is the continuum, how it goes. Multiple things can happen. The steatosis increases, cytokines are coming in, and that is, and at the stage of NASH, the reversibility factor is lost. So now coming to what can be done to target this. So if you are having a targets related to insulin resistance or lipid metabolism, then we have PPR gamma, that is a pioglitazone, GLP-1, liraglutide, semaglutide, and number of drugs are being tried to be developed. And the targets related to lipotoxicity and oxidative stress, again we have got newer drugs with dual PPAR agonist, that is L-fibrinol, and a large number of drugs, and alpha and gamma, that is the saroglitazar, which is available in India and is cleared by DGCI for use in NAFLD. Then targets related to inflammation and immune activation, then a lot of drugs are being developed in that field also, targets related to cell death, apoptosis and necrosis, and then targets related to fibrogenesis and collagen turnover. So these are the factors which contribute to the progression: advanced age, sex, race, hypertension, central obesity, dyslipidemia, AST-LT ratio more than 1, low platelets, and persistently elevated ALT levels. So they are all associated with the poorer outcomes as regards to the progression of the NASH. So a few words about the nuclear hormone receptors. Then only we can understand how pioglitazone acts. So this is a family of nuclear hormone receptors, that is the thyroid hormone receptor, THR, steroid hormone receptors, vitamin D3 receptors, retinoic acid receptors, and the last one is the peroxyso-proliferated activated receptor. So this is of interest for us, that is the PPAR receptors. So if it is effective, the signaling is effective, then we have increased fatty acid oxidation and the energy burning and reduced fat storage. But if this is improper, that is the PPAR alpha sensing is not working properly, then we have decreased fatty acid oxidation, lipotoxicity. So basically, the entire thing rests on the PPAR receptors. So these are the different receptors. PPAR alpha, they are responsible for lipid catabolism and homeostasis, control of inflammatory process and vascular integrity. So, and they increase the fatty acid oxidation at the level of liver. Then PPAR beta and delta responsible for insulin sensitivity and glucose homeostasis and vascular integrity, and PPAR gamma for glucose homeostasis and liver storage. So these are the various drugs which have been developed. PPAR alpha, we have fenofibrate, clofibrate, gemfibrozil. For PPAR beta and alpha, we have this new drug GW501-516, and for PPAR gamma, we know all about the pioglitazone, rosiglitazone, proglitazone, and so many drugs. Then coming to the medications that we have, and I've already told you that LSM is the best drug as regards to the management of NAFLD, and any weight reduction to the tune of 3 to 5% improves steatosis, and 7 to 10% to improve most histopathology, including fibrosis. And as regards to pharmacological treatment, early stage NASH at high risk of disease progression, age more than 50 years. So we need to treat, we don't need to treat all the patients. Those patients who are at high risk of progression to NASH are to be considered, and patients with age more than 50 years, metabolic syndrome, diabetes mellitus, and increased ALT, these are indications for the treatment, early treatment, active NASH with high necrotizing inflammatory activities, and progressive NASH, that is bridging fibrosis and cirrhosis. So this is, I have included this slide just because that evaluation and management of NAFLD in patients with type 2 diabetes, this is a call of action to all my metabolic physicians and diabetologists present. So this is very important that we must address and we must start identifying these patients because this is of great importance. So this is the entire schema, how it all happens at the level of the molecular level, and now we have incorporated the drugs where they are acting. PPR gamma agonism, pioglitazone is living at the insulin resistance, decreasing the insulin resistance in the adipose tissue. GLP agonists, they are reducing weight and improving insulin sensitivity. Then L-fibranor, PPR alpha agonism, improve insulin sensitivity, increasing lipid oxidation. SGLT2 inhibitors lowers plasma glucose by increasing renal glucose excretion. GLP-RN analogs, DPE4 inhibitors, and metformin to some extent are useful as regards to this. So these are the guidelines, what they have said as regards to metformin, vitamin E, PPRA gamma agonists. So drugs approved by regulatory agencies for NASH in certain countries like India, we have saroglitazar. Drugs recommended by scientific societies, AASLD, EASL and INASL are vitamin E and pioglitazone, and drugs available, but data available, but they are not cleared by the regulatory authorities. They are the anti-diabetic drugs, metformin, liraglutide, SGLT2 inhibitors, probiotics, and this new one that is an anti-fibrosis drug, that is the obeticholic acid. So saroglitazar we have heard a lot. So it's a dual PPR gamma agonist, that is alpha and gamma agonist. So it decreases hepatic steatosis, inflammation. Animal data is there, real life data is there, phase 2 data is there, histological data is there. First drug approved by any regulatory authority. Tried and tested in diabetic dyslipidemia, no major side effects. Cost, data not peer reviewed, published as full paper. So there are constraints as regards to this. Then obeticholic acid, bile acid active receptors, farcinoid X receptor, and it controls the bile acid formation. This was used, but a US FDA warning has come as regards to its use because of the increased incidence of pruritus and increased LDL levels. But this is a good drug in F3 and F4 stages of NAFLD. Then coming to the pioglitazone, it improves insulin transduction system, improves glucose transports, improves mitochondrial function, reduces free fatty acids, thereby reducing lipotoxicity. So enough number of indications for pioglitazone. I think we all are aware about this. Then coming to the topic, that is the pioglitazone and adipose T, insulin sensitizer pioglitazone remodels adipose tissue phospholipids in humans, increase subcutaneous adipose tissue mass by approximately 3.5%, at the same time reducing the visceral fat mass. Then pioglitazone for NASH and NAFLD patients with pre-diabetes or type 2 diabetes mellitus, a meta-analysis, what it pointed out that pioglitazone can significantly improve the histological performance of the liver and insulin sensitivity. Additionally, it can significantly reduce fasting blood glucose, glycosylated hemoglobin, plasma SGLT, and other liver biological factors. So this all started with this particular study, and this was the PI1 trial. This was done by Dev Sanyal and the group. So they compared 3 groups. One was with pioglitazone, one with vitamin E, and one with the placebo. So they found that there was a significant reduction in both alanine aminotransferase levels with pioglitazone and vitamin E, but after 96 weeks when it was stopped, so again they came back to the same levels. So it was as regards to both AST, ALT, insulin resistance and weight. So these drugs are to be taken for longer durations of time. Then another interesting study, long-term pioglitazone treatment for patients with non-alcoholic steatohepatitis in patients with pre-diabetes or type 2 diabetes mellitus. So another study, this was done by Kenneth Kusi, and it was presented in the ACP only, that is the Annals of Internal Medicine. And what they found that the intervention was all patients were prescribed a hypocaloric diet, around 500 kilocalorie deficit, and then randomly assigned to pioglitazone 45 milligram per day or placebo for 18 months, and followed by 18 months open label phase with pioglitazone treatment. So the primary outcome was a reduction in at least 2 points in non-alcoholic fatty liver disease activity score in 2 histological categories. The results were among patients randomly assigned to pioglitazone, 58% achieved the primary outcome, 51% had resolution of NASH, and pioglitazone treatment also was associated with improved in histological scores and improved adipose tissue hepatic and muscle insulin sensitivity. And the overall rate of adverse events did not differ between the two groups. Then another trial, randomized placebo-controlled trial of pioglitazone in non-diabetic patients with non-alcoholic steatohepatitis. So again, this is in non-diabetic patients. So there also they found that there was a significant reduction in the steatosis scores, liver injury score, lobular inflammation score, and portal inflammation score when they compared pioglitazone with placebo in non-diabetic patients. Then coming to low-dose pioglitazone. So first we should understand what is the concept of a low-dose pioglitazone. So there are nth number of studies. So this is a study. The effect of low dose 7.5 milligram per day, standard 15 milligram per day, and high 30 milligram dose pioglitazone therapy on glycemic control and weight gain in recently diagnosed type 2 diabetes patients. And this study was done in India, and it was published in JAPI. And the chart reviews were performed on recently diagnosed less than 24 months type 2 diabetes patients receiving therapy including pioglitazone, and patients were excluded if they had heart disease or liver dysfunction. So the results were at the end of 6 months, there was a significant weight gain in all groups from baseline, and the weight gain was greatest in group C, that was 2.72, intermediate in 1.62, and the least in the group A. The difference was statistically significant between group A and C and group and B and C, but not between group A and B. But there was no difference between HbA1c lowering in the three groups. And this was the most important thing. And from there, the concept of low dose of pioglitazone started coming up. So this was further seen in other studies at different parts of the world. That is, Asu et al. Did the study. The same results were seen with a low dose of pioglitazone of 7.5 milligram. So the lowering of HbA1c without having the deleterious effects, that is the weight gain and the fluid retention, was not seen in these studies. Another study by Madima et al., and this was from Arnoff group, and they also found that all treatment groups, including the 7.5 milligram per day, had significant HbA1c reduction compared to placebo. However, the study showed a significant inverse correlation between HbA1c reduction and weight gain. So then coming to the pioglitazone, even at low dose improved NAFLD in type 2 diabetes. So this is the low dose of pioglitazone in type 2 diabetes. So this was a very interesting trial, and this was a subgroup analysis of TOSCA IT trial. So this was basically for seeing the cardiovascular effects with sulfonylureas vis-a-vis pioglitazone. So they did a subgroup study, and the objective was to evaluate the effects of 1 year treatment with pioglitazone or sulfonylureas or on indirect indices of NAFLD in people with type 2 diabetes. And the outcome was 1 year treatment with pioglitazone, even at low dose, significantly improved liver steatosis and inflammation, systematic and adipose tissue insulin resistance in patients with type 2 diabetes. And the beneficial effects of pioglitazone on NAFLD were independent of blood glucose control. So here we have the comparisons, pioglitazone versus sulfonylureas as regards to AST, ALT levels, GGT levels, liver fat equation, hepatic steatosis index, and the index of NASH. And HOMA-IR and ADIPO-IR and VAI, visceral adiposity index, were also seen in these studies. So the interesting part of the study was that they compared the three doses, that is the 15 milligram, 30 milligram, and 45 milligram, and they found that all of the three doses performed equally well when it came to the regression of the fat in the liver. Then concluding my talk, so pathogenesis of liver fibrosis has not been fully illustrated. So multiple factors are coming into play, and the repeated heating of the liver, that is the point which is causing the progression from a simple steatosis to steatohepatitis. And pioglitazone, even at low dose, is effective in improving indirect indices of liver steatosis and inflammation and systemic and adipose tissue insulin. The beneficial effects of pioglitazone on NAFLD were independent of blood glucose control, and an average dose of pioglitazone of 26 milligram per day for 1 year induced a significant reduction of indices of liver cirrhosis, liver enzymes, and hepatic inflammation. And these effects came together with improved glucose control, a less atherogenic lipid profile, and relevantly without a significant increase in body weight. So pioglitazone dose is as effective, the lowest pioglitazone dose is as effective as the highest on the whole metabolic profile of patients with type 2 diabetes, and the dose-dependent studies on effects of pioglitazone on blood glucose control show that even at low dose of pioglitazone holds its beneficial effects with a reassuring safety profile, and the liver cirrhosis and inflammation were independent of the blood glucose control. And the pioglitazone is essentially mediated by the reduction of insulin resistance, particularly in the adipose tissue. And pioglitazone, unlike sulfonylurea, is able to counteract not only the deleterious effects of lipotoxicity, but also glucotoxicity. And anti-inflammatory and antioxidative properties of pioglitazone at the hepatic level, but also to its regulatory action on hepatic lipid metabolism. So these could be the contributory factors that are acting independently of the glucose control when we are talking about NAFLD. So thank you very much.
Any questions from audience?
My question is very simple, very clinical. Is this weight gain with the higher dosages, is this also by research methodology, is this also increasing liver fibrosis?
No,
is there any relation between weight gain and liver fibrosis?
Okay. So the point was that, so this was, I had already highlighted in my conclusions also, that this weight gain is independent to the liver cirrhosis. And what pioglitazone is causing, it is increasing the weight at the subcutaneous fat, not the visceral fat. And that is not being contributed to the NAFLD.
Thank you, thank you.
Any other questions? Well, I would like to ask some questions, Dr. Pyariji. One thing was that there was concern about the increased incidence of malignancy with pioglitazones.
Yeah.
Whether it is there with low dose as well or not, I don't know.
So, sir, I think this is the reason why this low dose of pioglitazone started being explored. So, because there was a diabetes registry, the French diabetes registry, which first pointed out that there could be an increased incidence of malignancy, bladder malignancy associated with pioglitazone. So I think that is the reason why this all studies with the low doses of pioglitazone, because no drug is acting at the level of insulin resistance at the level of adipose tissue. So this is something which is very wonderful drug in our armamentarium, and which should be incorporated more and more in our set of patients. So that could be a reason, but I think the long-term studies and the meta-analysis have disproved this thing, that it causes an increased incidence of or is signaling for bladder cancer.
Thank you, Dr. Ajay. It was a very nice, excellent presentation, I think. And subject is also right subject, I think. So my one question was is there any beneficial effect of pioglitazone over the metformin?
Okay. So I think if we combine these two drugs, so we will be having the best results as regards to the insulin resistance, because one is acting at the liver, at the peripheral tissue, another is acting at the adipose tissue. So if you are combining these two drugs, and there are studies with metformin which have shown that it decreases the incidence of liver cancer. So that is basically it is acting indirectly to stop the progression of liver cancer. So combining these two important agents will be, I think, a better answer, rather giving a verdict as regards to either the two. I think the both should be combined.
Okay, I want to add one advantage, the pioglitazone over the metformin. It is the kidney nephroprotective also, I think. Number one. Number two, the PPAR, alpha, gamma and alpha, all and beta also, tumor necrosis factor. These all are acting through the insulin mediators. Or that is the natural things which we are concerned about. But metformin and other one are the glucose metabolism. They inhibit the GI absorption and also inhibit the outcome of the glucose from the liver cells. But in the alpha, through the alpha, the pioglitazone, it also, in addition, the fatty acid metabolism also. Yeah. So it is. So it was excellent presentation. Thank you very much.
Thank you, sir. Thank you. Yes, I already pointed a study by that Cruci et al., which was presented in Annals of Internal Medicine. So they did a study in non-diabetics, then there is another randomized control in pre-diabetics and diabetics also. So if you have a case of NAFLD, it will be effective all across the spectrum, because the action of...
No, my question is not in NAFLD, non-NAFLD pre-diabetes.
Non-FLD,
मतलब उसको he or she has got is in the range of pre-diabetes, but no NAFLD.
Obviously it will work.
And I think it can be used as a diabetes prevention program along with the
yes,
metformin.
There are studies with diabetazone also.
Thank you.
Is it lean diabetic or?
Sir, what I wanted to know, if a
lean.
patient has got his blood he's pre-diabetic, but there is no NAFLD.
Okay. Thank you very much. Next.
Thank you, Dr. Ajay Tiwari. And I invited second speaker, Dr. Vipul Chopra. He delivered interesting talk.
Dr. Vipul Chopra is diabetologist, cardiometabolic physician, and he is the chairman and co-founder of Reproductive Institute of Medical Sciences. He is district coordinator, Ahmedabad RSDI. He is the faculty of National and Regional Education for HCPS. He is the principal investigator of various trials and the author of National Index publications and chapters. He has been awarded many times from many authorities like USP, Diabetic Award from Times Group, Bharat Chiksha Puruskar from Government of India, Best Institute for Management of Diabetes by Times Group, and Early Career Physician Award from American College of Physicians. Welcome, Dr. Vipul Chopra.
Thank you so much, sir, for kind words of introduction. And last year on the same ACP meeting, I received that Early Career Physician Award by our Governor, Dr. Anuj Maheshwari, sir. And then we were discussing about that COVID, that the world was shaken by the COVID, and still the sir was thinking that how we can collect the data, analyze the data, and use that data to make something that is useful for not only for the COVID, but for the post-COVID and also for the future for any viral infection. So today, I will talk about COVID Diabetic Registry. That is a study of factor determining the severity of patients of diabetes who develop COVID-19. So it is an original paper now accepted at Diabetic and Metabolic Syndrome Clinical Research and Reviews. And of course we can see that Dr. Anuj Maheshwari sir and Dr. Dhruvi Asnani and myself are a part of that. Initially we plan that we could plan a registry, but in a country like India where registry is very difficult to take, and we plan that we can have a multi-centric study, and our primary objective was to estimate the prevalence of newly detected diabetes in a patient who suffer from or recover from the COVID, and secondary objective was to compare the newly detected diabetes with already diagnosed diabetic patient as well as non-diabetic patient in terms of the glycemic status before and after COVID, as well as along with the disease severity. Initially when COVID arrived, we considered that CT score was the only factor to determine the severity, but then we find out that there are many other factors that affect the severity of the diabetes. So for the methodology, we started to collect data of all the patients who are more than 18 years of age or older, and they were RT-PCR positive, because at that time RT-PCR was considered as a gold standard for the diagnosis of COVID, and exclusion criteria were any patient who were more than 18 years of age, and duration of data was 6 months, June 2021 to November 2021. It was a multi-centric study. We consider almost the pan-India, and we can see that our institute was also part of that. So how the study was executed? Initially, we took our 2,263 patients from the multiple centers, and then we found that 51 patients were less than 18 years of age, so we excluded them. Then we analyzed the data and we see that there were 226 patients whose data was incomplete in terms of the comorbidities. So we exclude that data, and finally those patients who don't have the data of blood glucose from beginning of the study and at the end of the study, that data also was excluded, and finally 1,630 patients were analyzed. The study group definition. We started the study and we planned many things, but there was a hurdle that how to define that sample size and study, and at that point of time we took a help of Mediva, and they helped us very well. So these three definitions are very important for this study. Who had diabetes before having COVID, and obviously they were remain diabetic after the COVID. The second group was non-diabetic, and the third group was a newly detected diabetes. The newly detected diabetes they were not diabetic when we started the study, and they were first time detected hyperglycemia because of many reasons. Case record form was like this. We took our demographic data, the study of COVID infections, and medical history of the patient were taken. For diabetic point of view, we took blood glucose level, HbA1c, medication used for the management of hyperglycemia, and current use of medication was also considered. For COVID related history, we took symptoms, vaccination status, need of hospitalization, date of diagnosis, management of COVID, and details about the steroid. Because in India we found that we use almost all type of the steroids when we are treating diabetic patients and COVID patients. So we considered the name, strength and duration, and we took them to the prednisolone equivalent so that we can uniformize the data. And for laboratory measurement, we took our C-reactive protein, D-dimer, interleukin 6, neutrophil, lymphocyte, and SGPT, SGOT, and of course the HRCT score of the patient. This was our data collection sheet, and again the Mediva helped us very well. And again at this point of time, when we have to decide what should be the sample size, what should be the statistical tool for analysis, and how the significance of data is at that point of time, again Mediva help us with their expert statisticians team, and we took that 5% of the population would be a significant level, and that for that the number was 1,184, and we crossed that number in our study. The steroid usage and data dosage information, the use of corticosteroid, as I already mentioned that we use almost all the steroid during the COVID, whether it was hydrocortisone, prednisolone, methylprednisolone, deflazacort, dexamethasone, as well as betamethasone. But we divided them according to the usage of steroid as term of prednisolone equivalent. Those patients where steroid was not used, they called as a non-steroid user. When we use a 50 milligram or lesser dose, then we call them a low steroid users, and when we use 50 milligram or more, then we call as a higher use of steroids. Our study group, again, we already know that there are already established diabetes patients, there are patients who do not have diabetes, and there was a third study group, which was our main interest group, that newly detected diabetes, but they can be divided into these categories, that either they were already diabetes, but they were not diagnosed with diabetes. There may be a COVID-induced diabetes. In ADA 2022, we found the paper that the COVID virus directly invades the islet of Langerhans and reduces the beta cell production of insulin. So it can be a COVID-induced diabetes, it can be a steroid-induced diabetes, or it could be a stress-induced diabetes. That was our main purpose of study. So what were the results? In the terms of demographic and comorbidity, we can find that more patient or more aged patients were already having diabetes. 52% of the average age of a patient who already had diabetes, while 45 and 50 years of the age was in non-diabetes as well as newly detected diabetes. And on the other side, we can say that in non-diabetic patient, 60% patients do not have any major comorbidities, and 34% of the patients who had a newly detected diabetes do not have any other comorbidities. While in diabetic known patients, there is a comorbidities and measures are hypertension, dyslipidemia, obesity and hypothyroidism. Talking in terms of symptoms, we can see that diabetic, who had already had diabetic, were more symptomatic as compared to the non-diabetic, as well as patients who newly detected as with diabetes, but the number was not statistically significant. Now again, this chart is very important. It shows that blue is a already diabetic population, green is a newly detected diabetes, and orange are the population who were non-diabetic. In terms of RBS, at the admission, the non-diabetic has a higher RBS. In terms of HbA1c also, the already non-diabetic has a higher HbA1c. But talking about the HRCT severity, the patient who first time detected diabetic during the study were have more HRCT value. Now comparison study for other surrogate marker, we can say that patient who were newly detected with diabetes has a more percentage of hospitalization, more percentage of stay to hospitalization, as well as their oxygen requirement and steroid requirements were higher as compared to the other population. So question that arise after the study, that even the known case of diabetes were not having more complication. They were, of course, they were more symptomatic, but their hospitalization, their oxygen requirement and the steroid requirement was not more. While the newly detected diabetes has a more requirement, what are the factors that can contribute? The possible factors are age, gender, comorbidities, steroids, number of vaccination dosage, and the brand of the vaccine available. So on further exploration, we find that diabetic patients were more symptomatic, but they developed less complication, and newly detected diabetes who were less symptomatic but developed more complication. So to conclude, we can say that for non-diabetic group, they were having lesser severity on the HRCT, their age was higher, still they develop a less complication. While the newly detected diabetic patient, they have a higher HRCT value at the diagnosis and they develop more complication. So what is the message here? The message here is that we are living in a country, in India, where we have a very large population who are undiagnosed with diabetes. We have too much population with pre-diabetes, and those, if they were not screened properly and treated properly, if any pandemic like this occurs again, and then we have more population at risk. And our limitation of this study was, it was a lockdown era, so we use EHR and telephonic consultation of the patient or further data collection. And it was unclear that pre-existing diabetic became apparent because of the COVID admission, or they develop stress-induced hyperglycemia or steroid-induced hyperglycemia. And the scope of further research, of course, this study enlightened very much scope for many studies, whether this newly detected diabetic were reverted to the normal diabetic or not, how their clinician approach them, and whether lifestyle intervention and other medicine can reverse or prevent these comorbidities. My acknowledgement for ACP India chapter for supporting this study, as well as Mediva for providing all the electronic and statistical background. With that, I would like to thank you, my colleague and my partner, Dr. Dhruvi, and this is our institute. Thank you so much.
Any questions from audience? I would like to ask one question, Dr. Vipulji, that how many patients who develop diabetes after COVID infection, they revert back their diabetes, whether it was transit diabetes or it was continuous?
That was a limitation of our studies. We studied that population for 6 months. After 6 months, we could not follow them. Actually, we would like to study them, whether it was a transient diabetes or it was an undiagnosed diabetes who diagnosed because of that, and because of either stress-induced or steroid-induced or diabetes was there. Again, it was our plan to continue this study in a future and make more remarks from that.
Yes. Thank you. Excellent.
Thank you very much.
Thank you, sir.
Our topic was the severity determination of COVID and diabetes, type 2 diabetes. So COVID is newer one, but diabetes is not the newer one. But I can say diabetes cannot give the chance of getting infection, but it is the severity concern. If the pre-diabetic patient is started to develop the metabolic imbalance or the resistance to something, but after you have mentioned the newly diabetes, type 2 diabetes. So it has been studied earlier also that these two problems, but it is the getting the infection, chance of infection is less. But if the infection is there in diabetic patient, the chance of complications is more. This is the one of the important severity definition. Number two is the heart disease. Even a known heart disease is there. So in diabetic patient and getting the infection of COVID, it is also a severe determinations. And last of all, you have already mentioned the comorbidities. The comorbidities with diabetes mellitus, this is also the complicatory mechanism of COVID infections. So anyway, you have described things in a very nice way with very good materials, I think. And it is being on the way, the study is being going on. So we should be careful about these comorbidities, severe determinations. We should sort out these things when COVID infection is there. Thank you very much.
Thank you, sir. I would like to make a small remark that only those patients who come to consult, those patients only were taken into the consideration into the study. And those patients who already diabetic and come for the consultation, the clinician is aware that he is diabetes. So the dose of the steroid must be very meticulously used. While for the patient who are non-diabetic or non-diabetic, at that time when too much workload was there on medical professional, there may be a higher dose of steroid may be used. So this data may still require some further filtration and further study to conclude.
Okay, that is also there. Thank you.
Thank you, sir.
Just one more question, sir. About these patients who were detected new onset diabetes. Did you label them as type 2 diabetes or type 1? Because at that particular point of time, all of them were on insulin. Hardly anyone was taking oral anti-diabetic agents. They had very high glucose, and to some extent we know that it's an acute onset diabetes. What could be the possibility that it could have been just type 1 diabetes because of COVID? Is it possible? Or did you try to identify that these patients who developed diabetes but did not had an acute pancreatic insult leading to, because we do know that a lot of viral infections can produce type 1 diabetes. This is a new disease, we do not have those data. But what are the possibility that this type of new onset diabetes happening after acute viral infection was not a type 1 diabetes?
Yes, I will answer in a two phase. First phase, in this study we consider the hyperglycemia as a marker, and we consider that hyperglycemia leads to the diabetes. So in here we do not fall into that type 1 diabetes or type 2 diabetes. Those patients who has a hyperglycemia and higher HbA1c were considered as a newly detected diabetic. And talking about type 1 diabetes, yes, of course, after the post-viral, post-COVID, also after post-vaccination also, we have seen many autoimmune conditions flaring up. Not only type 1 diabetes, of course, we have 5-6 patients who came to our center after COVID, and they have incidents that after COVID or after vaccination, they develop this after 6 to 12 weeks. So not only type 1 diabetes, autoimmune hepatitis, even GBS patient has arisen and raised after the COVID and COVID vaccination. So in this study we consider as a diabetic only, not stamp them as a type 1 or type 2. But yes, type 1 and type 2 both have raised after the COVID.
Yes, we've not included that in the study because that was not one of our major objectives, and all the investigators who were involved, so they might have done it in their centers, but we've not collected that data of say C-peptide or how much was their HOMA beta or how much was their antibody level. We've not collected that as our primary objective because that would of course shift the focus from the severity determining factors for COVID to what kind of diabetes develop. Maybe, but that is what, like sir said, that was a limitation of the study, that we could not follow them after 6 months.
Okay, thank you very much.
Thank you. Thank you.
Now I request Dr. Manoj Kumar Srivastava with your presentation on place of novel triple drug fixed dose combinations in type 2 diabetes management. Dr. Manoj Kumar Srivastava. Oh yeah, yeah. Dr. Manoj. Okay, Dr. Manoj Kumar Srivastava is the President-elect, Uttar Pradesh Diabetes Association, member governing body of the Indian Society of Hypertension, fellow Indian Society of Hypertension, Diabetes India, Indian College of Physicians, chapter IDF textbook of the medicine, and also API Medicine Update 2019, and editor RSSDI Scientific Update 2015, and organizing chair UPDACON 2022, and organizing secretary IUPDACON 2020. Please.
Thank you, Chairperson, for the kind introduction. My topic is the place of novel triple fixed drug combination of sitagliptin, dapagliflozin and metformin in the management of type 2 diabetes. So this slide has been taken from the IDF Atlas 2021, and this is looking at the prevalence of people with diabetes in various countries, the top 10 countries, and India comes second at the moment, 2021, and it has also been extrapolated to 2045, and we still are at number 2, but the number has really gone up from 74 to 124.9 million people. And this is a very recent study from the published in Public Health 2022, and it's looking at the prevalence, awareness, treatment and control of diabetes from a countrywide national non-communicable disease monitoring survey. And what does it show? It is basically looking at the distribution of fasting glucose across the urban, rural, men and women categories. And you see, as the age goes up, whether it was the urban population, or the rural population, or the men or the women, all of them showed as the age goes up, the prevalence of diabetes, that is the red box at the top of the bar, keeps on increasing. And when you look at these prevalence of diabetes as such, that is the red bar again, if you look across the spectrum of BMI, from underweight to normal BMI to overweight to obese, all of them show as the progression of BMI happens, there is a progressive increase in the prevalence of diabetes in our country. Now, this is a very alarming study. This was done some 6 to 7 years back, and it showed that only 33.1% of diabetic population was really under the control and had a target value of HbA1c less than 7. And nearly 62.5% of this population were above the target ppbg of more than 180. So this alarming slide should keep us on our toes, and we need to look at what this uncontrolled diabetes is going to do to us. Right across blindness, heart attack, brain hemorrhage, kidney problems, amputation of lower extremities, all sorts of complications we all know can happen if we are not going to control our diabetes. So there is an importance of glycemic control. All our patients needs to be well controlled, and there's a long way to go, especially looking at our Indian population. We have a lot of data which suggests that if we control the diabetes in our patient, we are going to control most of the microvascular complications. But despite that, despite this awareness among the physicians, despite this knowledge being percolated down to the patients, we are still not able to reach the target. What could be the reason, and how can we overcome these things? clinical inertia is one of the major reasons for uncontrolled glycemic control. And what is this clinical inertia? Is the failure of the healthcare providers to initiate or intensify therapy when indicated. And this could be because of so many reasons. There could be an overestimation of care. We think that patient is already taking too many medication. We don't want to add anything more. Use of soft reason to avoid intensification of therapy. And then of course there could be lack of education, training, and simply a clinical inertia on the part of the physician not to accelerate or intensify the therapy. Another important thing why we are not able to control is that we're not looking at the whole spectrum of the pathophysiology that these patients might be having. We are targeting just one of the pathophysiology. We are just leaving out the rest of them. So at the end of the day, we are probably not getting the results that we really want. If we can target most of the pathophysiological defects, probably will not just be able to control the hyperglycemia, but will also probably be able to reduce the complication that is going to happen because of that. Early use of combination therapy is being avoided by most physicians. And we already know that if you use them together, there is increased chances that a third drug may not be required for a very long time. That means this combination can give you more durability. Less chances that even if the patient doesn't come back to you, probably he'll get a control and will remain on control for a longer period of time. But if you're not looking at the durability of the combination, then these patients who are not going to come back to you will probably land up with hyperglycemia very soon. So combination therapy is the answer to if we're really interested in achieving the target. What are the advantages? There's increasing evidence and rationale that increasing the durability of the glycemic effect, potential to address the therapeutic inertia. So even you have inertia from the part of the patient, if you can give a combination therapy, probably you can to some extent overcome this inertia. Patient is already on 2 drugs, a durable combination, so patient may not require very frequent visit to the physician, and the physician doesn't require to increase the dose with every visit. Simultaneous targeting of the multiple pathophysiologic processes is also very important. If you're not going to do that, we're just going to target one particular pathophysiology and leave out the rest, probably will not be doing justice to our patient. Potential impact of medication, of course, the burden, giving multiple number of tablets, the cost of the tablet, adherence and other things are very important. And of course, the complementary clinical benefits. It is not just looking at the glucose, but probably looking at the weight, the cardiovascular risk profile in these patients. So combination therapy has now come to stay. And this is what the guidelines recommend. In 2022, the ADA guidelines for type 2 diabetes said early combination therapy can be considered in some patients at treatment initiation. Treatment initiation itself to extend the time of treatment failure. The NICE guidelines are looking at monotherapy, dual therapy, triple therapy, and they do agree that these drugs can be combined together rationally, logically to achieve a durable control of glycemia. If you look at the combination therapies, when are they being prescribed in our patients? You look at the HbA1c level. So, in East Asia, if you look at the bar diagram, you'll find that the East Asia, they start combination therapy the moment the patient's HbA1c go to 7.7. Across Europe, Latin America, and Middle East, of course, the values are much higher. In India, it is nearly 8.6 HbA1c before we start its combination therapy. We are waiting for the HbA1c to go to up 8.6, and this is where we are lagging, and this is going to result in more complication down the line. So coming back to this combination, DAPA, CETA, metformin, combination helps in controlling the ominous octet involved in pathogenesis of type 2 diabetes. So when you're using these 3 drugs together, the first part of the durability will always be there, because you're using a DPP-4 inhibitor and metformin combination, which we already know through the verified trial that this gives a good durability to the patient's treatment. And on the other hand, when you use these 3 drugs, you are basically targeting so many pathophysiological processes at one go. SGLT2 inhibitors, we all know, they are of intermediate to high efficacy. There's no incidence of hypoglycemia, so you can give them very easily. This combination will not produce any hypoglycemia. If the patient doesn't come back to you, you are not, should not be worried too much about the hypoglycemia part. patients will have a durable control, probably would not require too much of titration and continue with this triple drug combination for a longer period of time. This is very important in those group of patients who are a bit, what you call, careless about their treatment, careless about the visit to the physician. Probably they don't even get their some tested, and probably they'll never come back to the doctor for years together. So this type of a drug, which does not produce hypoglycemia, no major weight gain, lot of CV benefits are there, progression to DKD is also there. So we have already given protection for CV, protection for cardiac benefits right from the very beginning. So that even the patient who will not come back to you very soon, probably will still continue to have the benefits. The DPP-4 inhibitors, the efficacy is intermediate. There's still no hypoglycemia, no weight change. Again, a very good drug, very safe drug, can be prescribed for a long period of time. And of course, metformin, we already know, it's of high efficacy. So even if the SGLT2 inhibitors and DPP-4 may not be very strong glucose lowering agents, addition of metformin can really make this drug a very powerful anti-hyperglycemic. Then there are complementary glucose lowering activities. When you're using a DPP-4 inhibitor and SGLT2 inhibitor together in type 2 diabetes, you find that SGLT2 inhibitors produces glucosuria and cause less of glucotoxicity, and has got indirect effect on the pancreas by causing increased beta cell sensitivity and also decreases the glucagon. Increases the glucagon. While DPP-4 causes increase in secretion and lowers the glucagon. So both the benefits can be seen, and of course the incretin effect is already there with DPP-4. So this combination can reduce the chances of hypoglycemia even if it's going to happen because of this glucagon increasing effect of SGLT2 inhibitors. Additional clinical benefits have been seen when sitagliptin is added on to therapy with dapagliflozin. This was studied in published in Diabetes Care, which showed a sustained reduction in glycemic parameters, body weight, and with no risk of hypoglycemia. This is a very important part of this combination. Triple therapy is associated with significant reduction in HbA1c levels relative to dual therapy with DPP-4 inhibitor metformin and dual therapy of dapagliflozin metformin. That simply means that you're using 3 drugs together. Definitely, it is, I think, very rational that the HbA1c reduction will be more as compared to a 2-drug combination. So this was a study again published in Diabetes Care looking at dapagliflozin as an add-on therapy to sitagliptin with or without metformin. And they showed that there was definite improvement when dapagliflozin was added to sitagliptin. HbA1c went down from 0.1 to 0.6. HbA1c patients achieving an HbA1c target. The baseline was baseline more than 8%, had a further reduction of another 0.3. Fasting glucose went down by 26 milligram percent, 2 hours post glucose from 2.6 to went down 43.7, and percent of patients with decrease, those who were achieving the target of less than HbA1c from placebo sitagliptin combination was just 17.2, and it went down to 25, it went up to 25.6. So this combination is going to give you all the advantages which are not available with a dual therapy. And of course, over and above, there is additional benefit of weight loss across the broad range of treatment, whether you're using as a monotherapy, whether you're using as an add-on to metformin, add-on to sulfonylurea, add-on to DPP-4 inhibitor, add-on to insulin. Whenever you're using this drug in comparison with any of these combinations, you'll find that weight loss is much more. The red line looks at the combination and the blue line is the comparator drugs. Another advantage of this combination would be blood pressure reduction. Significant mean changes from baseline in systolic in patients with DAPA metformin relative to placebo with metformin at 24 weeks. So this drug, DAPA metformin, can also lead to a better blood pressure reduction. And another advantage is that when you use these 2 drugs together, the chances of genitourinary infection also goes down because of SGLT2 inhibitor. So in this forest plot, you see all these studies, whether from Rosenstock, Metahide, Franzo, Tenhauens, Leuven, all of them show when you are using this combination and they favor an SGLT2 inhibitor DPP-4 combination as compared to SGLT2 inhibitor, the chances of genitourinary infection goes down considerably. So there's a paradigm shift in the management of type 2 diabetes from the glucose-centric to more person-centric. We need to not just look at the glucose, but also to look at other comorbidities and risk. We know that SGLT2 inhibitor, a full success story across the whole spectrum of LVF. We have so many studies now to prove, right from those in the preclinical stage of heart failure to the clinical stage of disease to detectable cardiac involvement. All these stages have shown number of studies to prove their point that SGLT2 inhibitors definitely have an advantage over the other drugs as far as heart failure reduction and hospitalization for heart failure is concerned. Sitagliptin, of course, has also shown in the TECOS trial there is cardiovascular safety. So when you're looking at the drug combination, looking at the chances of bringing down the glucose, bringing down the risk for hospitalization for heart failure, and also for cardio safety, then we need to look at the combination bringing down the risk for chronic kidney disease. So this was a study which was published again in Diabetology 2022, and it's looking at the addition of glucose-lowering medication in people with chronic kidney disease. And what does it say? The SGLT2 inhibitors with primary evidence of reducing CKD progression. Use SGLT2 inhibitors with people with an eGFR more than 20 ml. Now the limit has gone down to 20 ml per minute. So now we have a large number of patients who can really be given the advantage of SGLT2 inhibitors, even those who are in a pretty late stage of chronic kidney disease. And once initiated, should be continued until there is a dialysis or transplantation. So you can, if you have been started, don't stop it. GLP-1RA can also be given if case the SGLT2 inhibitors are not tolerated or contraindicated. So in conclusion and recommendation, in people with CKD, SGLT2 inhibitors and GLP-1RA reduce the risk of MACE dependent of eGFR. They reduce the risk of heart failure and kidney outcomes. And in people with CKD and even with the eGFR of up to 20 ml and SGLT2 inhibitor with proven benefit, important thing is to remember is the proven benefit. We have very recently just 2 medicines in the SGLT2 inhibitor group. That was the DAPA and the canagliflozin, which were considered to be renal beneficial drugs, but now empagliflozin with the EMPA kidney study has already been published, and so it has also shown the similar type of results. So all 3 medicines now show proven benefit as far as the renal reductions are concerned. And if such treatment is not contraindicated, not tolerated or contraindicated, only then you need to put a patient on GLP-1. So SGLT2 inhibitors have now come to stay, a very important group of drugs in all patients of chronic kidney disease and type 2 diabetes, but also in patients who do not have diabetes, but have chronic kidney disease. So overall, summarizing the talk, a triple drug fixed dose combination of metformin, sitagliptin and DAPA, that is metformin with a DPP-4 inhibitor and an SGLT2 inhibitor. First of all, it improves the compliance that we were talking of, reduces the clinical inertia that we were talking of, increase the durability of the treatment that we were considering, address most of the pathophysiological defects of the ominous octet, achieve weight reduction, provide cardiorenal benefits, including reduction in hospitalization for heart failure, and also minimize the adverse effect of individual therapy like genitourinary infection. So it provides therapy which optimizes the quality of the life of a person living with diabetes. Thank you for your patient listening.
Thank you, Dr. Manoj Kumar. It was a very nice presentation. Especially, I am delighted to hear in India, in the world, 86% is on the work is going on the fixed dose triple therapy. And I want to add one thing because the things is like that. The triple therapy is the oral therapy, but people are not in significant number. They are afraid of taking the insulin also. So this also I can add one point in favor of you, this trial. Anyway, You are very learned enough, experienced on this issue. So very nice presentations. And I want from the dais, from the audience, any question or any suggestion, please.
Sir, the idea of this triple therapy is very excellent, and but the thing is in my mind is because India is a tropical country, and we are looking lot of cases of hyponatremia nowadays. The only concern is that we must, this is good combination, but we also make other physicians aware of the possible hyponatremia that can occur with such combinations. So this may be the first line of treatment in many of the cases because of devoid of hypoglycemia, significant hypoglycemia, better results, and but hyponatremia is important concern, sir. Thank you.
I think what you have said is very relevant. We need to be careful about the side effect profile of any drug when we are prescribing that drug. And with SGLT2 inhibitors, of course, dehydration needs to be taken care of, especially in conditions like ours, where there's a lot of heat, lot of humidity, lot of sweating is going on. So we need to be careful, especially in patients who are elderly, who are more prone to the complications of dehydration and electrolyte imbalance. We need to be careful about that. And that stands true for so many other drugs as well. But I think this is what the clinicians are meant to be. They are sitting behind the table, and it is our job to identify who are the patient at risk. It is not a blanket treatment to be given to all patients, but this is a good option. 3 drugs in one single tablet, bringing down the the cost of the drugs given separately, with again, as I said, a possibility that patient might not turn up for a long period of time. We don't have hypoglycemia and other things. Of course, the side effect profile should always be kept in mind. And I think we as clinicians, as healthcare providers, it is our job to see whether this drug or this combination of drug is really meant for the patient across the table.
Thank you, sir. Very nice presentation.
Thank you.
Thank you, speakers, and thank you, chairpersons. And I will request the speakers and chairpersons to collect their memento or a gift from the ACP India chapter from the Mediquip stall in the exhibition area. And the gift is one nebulizer for the speakers and one neck pillow for your air travel with the Mediquip. So you can get it and collect it from that stall whenever you visit the exhibition area. So we move on to the next session. And for this, I would like to invite Dr. Anuj Maheshwari, sir, and Dr. Sabiha Ansari to chair this very important session. Dr. Anuj Maheshwari, sir, as you all know, is the governor of the American College of Physicians India chapter. And Dr. Sabiha Ansari is Senior Medical Officer, Provincial Medical Services, UP, and the member of the Lucknow Heart and Healthcare Foundation. So I request them to take over this session.
I think Dr. Sabiha is not there. So
yes.
Okay, I will request Dr. Amos Sachan to join me here. So it's okay. So next session is very important session, which is on COVID dilemma, and speaker is again a very important person, who is the governor of American College of Physicians Bangladesh chapter, Dr. Khan Abul Kalam Azad. His very famous name and very well reputed and very honored name for the Indians, Khan Abul Kalam Azad, who has fought our freedom struggle. And now we shall be listening Dr. Khan Abul Kalam Azad in a different way, in a scientific deliberation. And it's very much important for us just presented our own work on the COVID and diabetes, and Dr. Khan Abul Kalam Azad shall be telling his experiences of COVID in Bangladesh, obviously. And we know that Bangladesh has handled the COVID problem very nicely as compared to the other countries. So we shall really be looking forward to listen his ideas as well as his experiences. How did he do and how did he come out of that dilemma? Over to Dr. Khan Abul Kalam Azad. Dr. Azad is working as a professor and head in Department of the Medicine, Dhaka Medical College. He is Dean Faculty of the Postgraduate Medical Science Research University of Dhaka. He is Principal of the Dhaka Medical College, Bangladesh. He is a Professor and Head Department of Medicine. I think it is repeating. So, over to Dr. Khan Abdul Kalam Azad.
Ginger is here, right? Okay. Ginger here forward. Very great. Okay. Where's my lecture? Good afternoon, ladies and gentlemen. Your Excellency, Mr. Governor, and thank you for the invitation you made to me and to my team. And also, I'm seeing that a huge number of participation, and I'm very much delighted to listen to important papers since morning. Thank you very much for organizing, and also I'm having the opportunity, and I'm really fortunate to talk to many specialists who are not known in India, but globally they are very renowned persons. Thank you very much. Today, I'm going to give thanks to SCP again because of your leadership and also the previous governor, Mr. Muruganathan. Both you are doing very excellent job, and you have gone to the 7th international conference, so that's a great achievement. I congratulate you for this achievement. Thank you very much, Your Excellency. And today I chose one lecture because this COVID has created so many opportunities to learn, to disseminate, and also to pave the way for future research. But we have seen that this produced an unprecedented challenge, that how to deal with COVID and what to be done, how to prevent COVID. Not only that, it had a very extensive impact in the community, not only the health problem, but we had so many dilemmas still is working with us. And one of them which was being discussed, that the new onset diabetes mellitus in the people. And also we found that GBS patients and so many other cardiac complications, the cerebral complications. So those are the things which are being coming day by day. Those are the health problems. But whether only the health problem is there, or we have to deal with so many other dilemmas. So today I will try to focus on some of the dilemmas, and I will go quickly on those issues which are not related to the health, but I will just focus on the health problems. So before I go to say something to my tribute to the great heroes, the doctors who sacrificed their life while dealing with the COVID patient in Bangladesh. And also, I do recognize the heroic activity of the doctors of India, and also in this part, because we have got many similarities in the health structure. So these are some of the photographs of some of doctors who worked, and also I pay my regards to the nurses, other healthcare workers who really fought against COVID. And so we all know that it started from Wuhan, the capital of Hubei, and it is a beautiful city, but the thing is that the virus initiated its journey from this city of Wuhan. And then in Bangladesh, we came to know about COVID on March 8th. The first case declared on March 8th, and within 10 days, we had a sudden demise of a person. That was the first declaration of a death. So we were not prepared that death will be there so early. So we understood that we had less preparation, that we could not fight against COVID at the time. And that created a sort of your government activity. And on 26 March, the first lockdown was imposed in Bangladesh. And then, we will discuss a few of the dilemmas. We know that you are all aware of the dilemmas, but I will be discussing some of the dilemmas, the health dilemma. So very unique moment it has been created by this COVID-19, and we are going through this situation. And then we know that this health dilemma, among the health dilemma, there is long COVID-19. That is we have seen that after acute COVID, the long COVID can be there, where maybe the symptoms can persist for about 12 weeks. But on occasion, after 12 weeks, we have found that the patient can have some of the manifestations of COVID. So the post-COVID syndrome is there. And we have to remember that it can mimic many of the viral disorders, but we have to exclude those disorders to make a diagnosis of post-COVID syndrome. So this is a dilemma that COVID, the viral infection, whatever the viral infection is, where it can affect, but it goes away. The effects go away. But the thing is that COVID has produced some of the long effects in the human body. So we are finding that some of the devastating activities are still there, and we can find that those symptoms are persisting in many patients. So prevalence, it has been seen that 1 in 10 people who were tested positive, they are having COVID symptoms after 12 weeks. And 30% of the people can return to the usual activities. But the thing is that we have to remember 30% of the COVID-19 patients still have got persistent symptoms after 9 months. So I have taken the study report when it was taken, but still we can find that the newer reports can focus on the duration in the coming months. And long COVID symptoms, these are the symptoms we all know, that the patient can have unusual fatigue and other respiratory symptoms, but every system of the body can be affected by long COVID. But the 3 most common symptoms, the brain fog, fatigue, and extreme tiredness after mental or physical work, those 3 were found to be the commonest. And it is a Bangladeshi report, Professor Mujibur Rahman and others, that is post-COVID syndrome and symptomatic COVID-19 patients. It was a prospective study, and here we have found that 46% patient develops post-COVID symptoms, and the most important 70% patients, they had post-viral fatigue. So they proposed some of the important factors which produce this post-COVID fatigability in many of the patients. So here we can find that pathogenesis can have so many probabilities, but the thing is that organ damage and microclots, those are the 3 important issues what we have to consider in the future also. And at this time, no laboratory test we can definitely distinguish, and as I mentioned, that you have to exclude the other possibilities to make an established diagnosis of post-COVID syndrome. So we do not require any test, but we can go for the organ-related testing in some patients. And very importantly, everybody says that what type of treatment can be given to the patients having long COVID syndrome. But till today, we know that so we don't exactly have any particular type of treatment, but we need some form of your multidisciplinary management, which are now being handled by the pulmonary, cardiovascular, neuropsychiatry, primary care physicians, renal, and hematological. All these types of multidisciplinary management can produce some benefit to the patients. So here we have got a vaccine. We are very much fortunate, and so everybody says whether vaccination can prevent the disease, but we know that 85% of the people can prevent the infection by after primary dose series, and about 50% of the people can have less manifestation in long COVID syndrome. So here we can find if we take 2 doses, we can have less risk of long COVID syndrome. And also we have come to know that very important finding, I have gone through this one, During the second wave, India had so many cases of mucormycosis. So this mucormycosis has several etiological aspects to remember. The most important was the hygienic factor that is important, and in India, mucormycosis was prevalent earlier along with your candida infection and aspergillosis. But because of this COVID and hygienic issues, and we have found the rhinocerebral type of your mucormycosis became prevalent, and still it is persisting. So that is one important issue. And another issue, Mr. Chairman, sir, I will say that our experience says that we know that whenever a service holder or a student becomes sick, he gets a sick leave. But after post-COVID dilemma, we have seen many of them, they do not want to be sick, they don't get the sick leave. And so it is a dilemma, how sick is too sick, that can be answered by deep personal reflection and self-understanding. And another issue is that ethical dilemma. We had so many difficulties during that one that the patient came. So huge number of patients, they appeared in the emergency department. But exactly whether we did rightly to the patient, that is also ethical. And in the future, for other patients, what ethical aspects will be covered by the hospital authorities and by the doctors, nurses, that is another dilemma. So another, we had a huge challenge with vaccination, and after vaccination started in June 2021, we had less than 4%, but after 1 year after, in June 2022, we had more than 70% coverage of the primary series, and about 35% got the booster dose. So we like to give thanks to Indian government for both the issues, because the first gift was to the army and also 1.2 million doses of AstraZeneca at the time, other than the usual commercial vaccination program. So I want to show this picture because, you know, Mr. Chairman, sir, in our country, a very strong extended immunization program is going on, and the vaccination in the rural areas also, they carry this vaccination box for the regular immunization. But here, we applied these people to carry on the immunization. So shortly, we could involve these people to make vaccination a successful program in Bangladesh. So we have so many challenges, you know about that, I'm not going to repeat this one, but whether after vaccination, any long-term side effects will be there, that will be a dilemma, Mr. Chairman, sir. Whether any other effective vaccination is possible, that will be our question. And so, academic dilemma, we all face like this one. We saw that the students, they could not go to the colleges, the schools, the young children, the toddlers, they were affected because they had to stay in the house, and online education system was given in medical college, and you all are experienced about the medical colleges, and we could not teach the students about the clinical classes. So with the patients, they were in the house, they were sitting online, and only the theoretical part of all the subjects were taught to the students. But it was a real problem, and that reflection we saw in our professional examination. When they were in front of the patients, they could not answer properly on many occasions. And we have seen that we took the initiative to, during lockdown also, we started our post-graduation and graduation classes, and so the students could appear online, and we had to continue, and later also the primary education was involved. And so state-run, this television was teaching the students that the students were learning at home. And also the medical education, the online classes, we had the classes and we taught the students, and all these teachers were teaching their students. And also we found that change in the research, and very importantly, Mr. Chairman, sir, 87,000 scientific papers at the very beginning. We did a very few months, and 47% of them were contributed by the Chinese researchers. But after April 2020, the number of publications were decreasing by the Chinese authority. And also we have found that the United States contributed 23% of the worldwide coronavirus-related publication. And journals were overwhelmed, and they used to publish up to 8 times faster, and we can see that PubMed and the Scopus all were involved to produce more and more research articles on COVID infection. Then economic issues, I'm not going into details about that. We all suffered from economic issues, and many persons became jobless. And also we found that everywhere there were the problems, and we have found the Malaysian dilemma that sustainable economy, and they think of that that is empowering the frontliners should be highlighted and prioritized. That is, health system funding is very important, what Malaysia is talking about. Global immune security, definitely after COVID it has been changed. We are now going through one country to another, and also in the different parts of the world, we can see the change scenario in the human security. And also another important issue, Mr. Chairman, is the labor dilemma, that many of the countries, even in India, many of the day laborers and their workers had been reduced, and so they became jobless. United Kingdom, similarly, United States, they had suffered from this side of your changes. And so the different countries' statistics shows that many of the countries are struggling with economy after post-COVID. And we have learned so many things to manage the patients in the hospital. And during COVID time, we had many successes in India, in Bangladesh, in South Asia in general. But the thing is that many things are needed, that whether we are completely equipped to treat any patient in future pandemic. So it has learned. We have some achievements. We increased the number of beds, we increased the number of ICU beds, and also we can see that high flow nasal cannula, ventilator, oxygen concentrator, oxygen cylinder, and also the central oxygen supply. Those are all involved in the process. But we had so many limitations, and especially in the people in India and Bangladesh, aberrant behavior. So they were taking any type of OTC drugs. So whenever they did not require any type of antibiotic, they took antibiotics rampantly, and also steroid. So there were so many sufferings from the patient side. Very importantly, we have seen when they carried the patient to the emergency, exactly what to be done. And also it was very difficult for the doctors to go near to the patient every day, every moment, and touching the patient like other patients. So the doctors also suffered a lot. Initially, we didn't have the mask, PPE, and eye shield. So later, gradually, they were educated and they could handle. And there were so many general people's attitude that they have experienced that, that initially they become, what they could do. They were, at a loss. They couldn't understand. But we found in our country, the festivals, the people did not, comply with the rules. They were going through the ferries and others. And so we had so many challenges. So especially in Bengali, we call Jivon versus Jivika. That is life versus livelihoods. And we asked the people, why you are outside? Why you are not remaining in the house during lockdown? Says that, okay, I may die, but I can feel the cry of my children. So I have to go to earn some money. So I'm going outside. So that was their answer at the time. And also we found mental health and personal health. This stress is very important, and we have found the brain fog and depression and all type of psychiatric abnormalities, and the suicidal activity also increased during COVID time. That is a problem. And the divorce rate in Bangladesh is keeping rise, and here you can see that 35 couples sought divorce every day in the capital city, one every 41 minutes. It's a matter in post-COVID era. What are the reasons? The psychosocial aspects should be addressed as a dilemma. And also we have said the social dilemma was there. We had abandoned many of the social activities, and also we understand that after 2 years, a little bit of tourism is going on, and after stopping tourism, many of the countries, many of the areas, they suffered really financial loss. That is very important. So we are going to near normal. So ladies and gentlemen, Mr. Chairman, sir, I know that is a very huge discussion. It needs long hours to be discussed, and we have faced some features, and I have discussed those, but in the future also we need some more discussion. So ladies and gentlemen, my deep regards to Professor Anuj Maheshwari, Honorable Governor SCP India, Professor Kaji Tariqul Islam, the founder Governor SCP Bangladesh chapter, Professor H.M. Nazmul Hasan, immediate past governor, my registered Dr. Narsaba Noor, and SCP Bangladesh chapter, and all COVID frontline fighter. With these few words, I like to conclude. Ladies and gentlemen, thank you very much. Sign.
Thank you, Dr. Abdul Kalam. You have really nicely presented the whole corona syndrome, the post-COVID factors which are affecting the humanity. One thing I would like to mention here, that COVID has proven that there is no boundaries in the country. It has spread like anything everywhere. Wherever the humanity was there, the COVID has gone. So we should take lesson from the COVID, that there should be a brotherhood all over the world. And it has really given this thing particularly to India, that we have supplied vaccines to all over the world. Whosoever is in need, we have supplied it. And secondly, the most important thing which I want to know, have you done any study regarding the post-COVID traumatic, psychological trauma? What has happened really to the people? We have seen this politically that they have suffered everything, whatever you have described. Any statistical data? Because personally I feel the psychological trauma was the greatest during the COVID and post-COVID.
Yes, thank you very much. We initiated with a study in Dhaka Medical College at the time to study the people, especially the healthcare providers, the doctors, nurses and workers, what type of psychological disturbances they were having when they go to the ward to treat the patients having COVID. So that is one aspect. And also we found that psychological stress and trauma in doctors, it was enormous, and in the family also we found. And I found that after third attack of COVID, a doctor, he really became abnormal. He had some features of delirium, and he was doing a very abnormal behavior. A doctor, he came to me to discuss the future. So that was one. And also now ongoing, some of the study reports are there, that what type of psychological aspects the people consider after post-COVID, especially the people when they go for oxygen or they go to the ICU bed. And we have seen that, I did not bring the report here, but we have seen that almost every patient, after being intubated or staying in the ICU for more than 3 days, had, the nightmares and anxiety. And all the time they were restless and they could do not a very good work. So that I have seen, that we have experienced. The study is still going on. So I do believe that it has, you just raised an important issue, the psychological trauma, post-traumatic stress disorder and other related things. Thank you very much, sir.
Any other question from the house? Thank you, Dr. Khan. Thank you very much.
Thank you, Dr. Khan, for the fantastic talk, and we really enjoyed your talk. Had a great time. So now I shall invite the next speaker of the session, Dr. Amit Gupta. Amit Gupta shall be speaking on Is Diabetes and Inflammatory Disease Biomarkers Tells the Story. Amit Gupta, as you can see, is a busy profile and busy CV slide of Dr. Amit Gupta. But what I know him, he is a ACP Council member of India chapter. He is a very good friend of mine. He is my colleague in the RSSDI National Executive. and he has done a lot of work in the diabetes, in the field of diabetes, in very less time, and he's very young but has gone. He has been the board of the ADA also, so he has won the Padmakar Tripathi Award in the Young Scientist Award of the Uttar Pradesh Diabetes Association, and I think that was the beginning of the story, right?
Yes.
So over to Amit without wasting much time.
Thank you, sir, and thank you for the kind introduction and giving me this opportunity. So, a topic for given to me today is diabetes and inflammatory disorder. Biomarkers tell the story, and continuing with what Dr. Kalam has just said, we were talking about COVID-19. So, COVID-19, we all know that led to a state of chronic inflammation also, that is what is long COVID. And we have seen a surge in patients with type 2 diabetes following COVID infections, and those who have had pre-diabetes, they were having, actually converted into type 2 diabetes. So COVID again has established that chronic inflammation can can trigger a milieu where inflammation can lead to hyperglycemia, and it can lead to worsening of the hyperglycemia as well as the new onset diabetes. So does the biomarkers, they tell us anything? So if you look at the various, if you look at this circle, you will find that the diabetes has inflammation can lead to type 2 diabetes, and I will be brief in telling what is happening. So there are many various studies and which have shown that, and they have provided the first possible evidence that what can be the association between inflammation and the diabetes. Over a century ago, the administration of high doses of sodium salicylate led to decreased glycosuria in people with a suspected or definite diagnosis of the diabetes. So this was the first instance where it appeared that the anti-inflammatory action can prevent diabetes. So later studies on the role of inflammation in diabetes revealed that this hypoglycemic action was related to the inhibition of the serine kinase IKK beta, which correlates with the post-receptor action of the insulin. So this is as long as 100 years ago. A landmark study of the to correlate inflammation with diabetes was conducted in animal models, and it revealed that the role of tumor necrosis factor alpha in obesity, and particularly in insulin resistance and as well as the diabetes. Another epidemiological association of the inflammation with obesity and type 2 diabetes were made when circulating concentration of the markers and mediators of inflammation and acute phase reactants like fibrinogen, C-reactive protein, IL-6, plasminogen activator, and sialic acid in the white cells have been shown to be elevated in these conditions. So this was the historical perspective which has initiated the talk that can inflammation lead to diabetes. And if you look at this slide, this actually sums up a lot of things. Now we know that there are various inflammatory markers in the form of TNF-alpha, interleukin-1 beta, platelet activating factor, TGF-beta, protein kinase C, arachidonic acid. So activation, ultimately all this leads to the activation of the endosomal NADPH oxidase, and leading to the generation of the reactive oxygen species and activation of the NFK beta pathway. So this leads to the inflammation, and this inflammation itself is responsible for the metabolic syndrome, atherosclerosis, as well as the diabetes. So again, I have just shown the milieu of the inflammation, but if you look at the top, you will find that the genetic predisposition, somebody may be more predisposed genetically to the inflammation, while the age is also a contributing factor, and the environment can also trigger. For example, COVID-19 is something which you can say came to people from the environment itself, leading to changes in the adipose tissue as well as the immune system, generation of all the inflammatory markers, milieu, leading to changes in the metabolism, and ultimately causing hyperglycemia, dyslipidemia, obesity, hypertension, and various cardiometabolic disorders. So, and result is cardiovascular disease also. This is very interesting that it is not just the type 2 diabetes where inflammation plays an important role. It is also the type 1 diabetes where the T cells, through the inflammatory pathways, they can actually lead to beta cell destruction mediated by the autoimmune beta cell destruction. And why it is important to understand this slide today is that because just today, a few hours before, the FDA has approved teplizumab as one of the anti-inflammatory, anti-immune therapy, you can say, which can delay the onset of type 1 diabetes by a couple of years. So this is latest. And how does this work? This is a humanized monoclonal antibody, binds to the T cell co-receptor CD3, acts as partial agonist, It is administered as a 30-minute IV infusion over a 12-day or 14-day outpatient treatment, and supporting clinical data has been there. That's why it has been approved by the FDA. And you can see here that this is the T lymphocyte, which is playing an actually very, very important role in autoimmune beta cell destruction. So this is the latest, and this has been announced on November 17th itself, that the US FDA has approved the anti-CD3 monoclonal antibody, that is teplizumab, to delay the onset of the clinical type 1 diabetes in people aged 8 years and older who are at high risk for developing the condition. So even type 1 diabetes is now having a role where the modulation of the immune system to change the inflammation can delay the onset of the type 1 diabetes by a couple of years. If you look at the various things in the type 2 diabetes, I will just run through these slides because it will sound like a repetition, because the mechanism of action is more or the same. There is a high metabolic load, excess calorie intake, changes in the adipocytes, adipocyte hypertrophy, hyperplasia as well as dysfunction, and here the immune cells are recruited again, leading to adipocyte inflammation and the insulin resistance. On the other side, increase in free fatty acids, reduced adiponectin level, increased leptin level, high demand for insulin, places the beta cells under the stress, and this stress leads, and again the cytokine production and the immune cell recruitment, islet cell inflammation happens, dysfunction happens, leading to the insulin insufficiency. So a cascade of insulin resistance as well as the insulin insufficiency is happening, leading to the development of the type 2 diabetes. So this is again the same thing. You can see the liver as well as the tissue as well as the pancreas all are getting inflamed and contributing to the development of the diabetes. This is a very busy slide, but I will not go into detail of this. Again, you can see both hyperglycemia as well as the hyperlipidemia through various mechanisms can lead to the various complications like nephropathy, retinopathy as well as the neuropathy, which we see in our patients with type 2 diabetes. Also, it is important to understand that the environmental factor as well as the genetic factors may also be contributing to chronic low-grade inflammation, which can ultimately lead to this various complications associated with type 2 diabetes. These are certain publications and the evidences which are being published, and one of the very good article is in 2011, that is in the Nature Reviews Immunology, that is type 2 diabetes as an inflammatory disease, followed by Trends in Immunology, and then JAMA, as well as the one paper in the Cell Research, which talks about the role of the inflammation in the development of the diabetes. These are various biochemical markers. I will skip these slides. We know that WBC count, the serum cytokine markers like IL-6, TNF-alpha, IL-10, acute phase reactants like high sensitive CRP, serum amyloid A protein, fibrinogen, immune cell markers like CD8 plus T cells and CD4 T cells, and CD19 B cells. These are various studies and evidence that has linked inflammatory markers to the development of diabetes. For example, Pradhan et al., almost 188 cases, length of follow 4 years, and CRP and IL-6. They studied, another group studied CRP and fibrinogen, another studied white cell count, CRP and adiponectin. And most of these studies, they found that the elevated level of the CRP as well as the WBC can incite inflammation and lead to dysglycemia. Also, high sensitive CRP, we all know that it is again considered as a severe risk marker in diabetes, and we have seen that even in patients post-COVID, elevated CRP level are being considered as one of the markers of the inflammation and increasing the risk of cardiovascular diseases. What is more important and what I want to show you is that there are various kind of drugs which are available, and we know that virus like COVID-19, obesity, hyperglycemia, changes in inflammation, diabetes, but metformin, DPP-4 inhibitors, GLP-1 analogs, SGLT2 inhibitors, anti-IL-1 therapy. So is there something which can target the inflammation? So we know that one of the molecule which we are using in India is hydroxychloroquine. It is approved in India and approved by DGCI for use in patients with type 2 diabetes, though with certain riders, and it can be used to reduce the inflammation. This is the ACE guidelines in 2017, and this, in one of the table they have mentioned that inflammatory markers like CRP and lipoprotein and PLA2 as a non-traditional risk factors for the development of the type 2 diabetes. So This is the different markers. CRP, we know that it is derived from the IL-6 dependent hepatic biosynthesis, primary marker of the acute phase response. It is associated with type 2 diabetes and insulin resistance. IL-6, WBC again. So IL-6 exhibit immunoregulatory actions and are involved in glucose homeostasis and metabolism through action on pancreatic beta cells, adipocytes, hepatocytes, and the skeletal muscles. And WBC is a marker of immunity and inflammation, we all know. So WBC count has been predictive of worsening insulin action, secretory function in type 2 diabetes, coronary heart disease. Many a times patient comes to us with a report and we find that TLC is elevated and we don't see any obvious reason. So sometimes it is the inflammation which is there, maybe contributing to the inflammatory milieu. I will not go into the details of the fibrinogen, PAI, IL-18 and the IL-IRA. But it is important to understand that targets are important because a lot is happening in the research, and you can see one of the drug is anakinra, which is IL-1 receptor blockade, and there are various studies which have been done, and it has been found that it can because of this its anti-inflammatory action, it can help in management of the glycemia. Also, there are drugs which are targeted the IL-1 beta antagonism like givokizumab. Also IL-1 beta antagonism through the canakinumab. So these are various antibodies mediated drugs which are targeting the therapy for the inflammation in diabetes. Another thing is that we also have IKK beta NF kappa beta inhibition through the salsalate, and these drugs have been shown to be effective in reducing HbA1c, fasting plasma glucose, triglyceride, as well as the adiponectin. TNF antagonism has also been studied, and so it has been found that TNF antagonism has no effect on insulin sensitivity. Another study, no effect on insulin sensitivity, but it reduces the CRP, improves the insulin secretion, and no effect on the insulin sensitivity. So these are the different mechanisms which are being now targeted by the researchers and the investigators to develop newer armamentarium for the management of the diabetes. So I would like to conclude by saying that inflammation may play a very, very crucial role in the pathophysiology of type 2 diabetes, also to some extent in the pathophysiology of type 1 diabetes. Furthermore, atherosclerosis, which is accelerated and more pronounced in patients with metabolic syndrome and type 2 diabetes and responsible for a high morbidity rate in population, is also characterized by increased silent inflammation, especially in the arterial wall. Patients with elevated HSCRP levels are at higher risk to develop type 2 diabetes and CVD. And if inflammation plays a crucial role in the cardiometabolic diseases, so developing successful targets which can actually target these inflammatory markers and reduce the inflammation can help with the management of the glycemia. I would like to invite you today night for this webinar, which will be happening 1 p.m. ET time. So if you get some time, then please join us for this webinar, which is organized by the ADA. I will be moderating this webinar with the blessings of Anuj sir. Thank you very much. So inflammation is a secret killer. Thank you very much for the patience listening.
Thank you, Dr. Amit Gupta. You have really given a good insight about this inflammatory markers in the diabetes. I have got one question. What is the clinical implication of these inflammatory markers in diagnosis and the treatment management of the diabetes? In what way they can be helpful? Because we don't do all this regularly.
Yes, sir. So, sir, we have shown certain slides. We are targeting these inflammatory markers, and there are therapies which are being developed to target these inflammatory markers and the inflammation as such. So, if we are able to target the inflammation, then recently we know that one of the drug has been approved and is used in India. It is imiglin. So it is targeting the mitochondria and modulating the metabolism. So now we are moving towards the precision medicine and more targeted therapies. So I think if we target the inflammation, we may be developing multiple things. Just like we have, there is a recent, I told that FDA has approved one of the molecule, which is again the immunomodulator and targeting the immune system to delay the onset of type 1 diabetes. So if it can be done for type 1 diabetes, I think model suggests that it can very well be done for type 2 diabetes also.
Are we using it?
Sir, it is not available. It has been recently approved. It is not available in India. I think it will come to India also, and we will start using it whenever it is available.
Thank you very much. Is there any question from the house?
Thank you, sir. I was also the moderator of this session, so I will conclude this session. Thank you, Anu sir, and thank you, sir, for this wonderful moderation. And now I will hand over the session to Dr. Divya Saxena, who will be taking us to the next round of session in this ACP India chapter IM meeting. Thank you.
Good evening to all of you. So moving towards the next very interesting session, I would invite the chairpersons for this session, Dr. Arun Kedia and Dr. S.S. Deria, to please come over the dais and invite the speakers for these two sessions. Over to chairpersons.
So, good afternoon. And for the next session, we have 3 topics, and all 3 topics are very different. So for the first session, I invite Professor Qazi Tarikul Islam. We all are concerned with the aging population. Our OPDs consist of a large number of patients who are now from the geriatric age. So we have certain concerns. What is our role? How do we provide them a good care? So for that, I invite Professor Qazi to give his deliberation. Over to you, sir.
Thank you. It's a great pleasure. I think everybody is trying to sleep because this is sleeping time. But my topic is completely different. Not that much academic, but very much interesting, very much relevant to your life, because all of we are getting older. So my talk is on aging population. Why? This is a great concern of this century, and throughout the globe, the concern is increasing, and the number of the elder population is also increasing, and we have to take care of them. Who doesn't know this man? You know, this gentleman, how nice he was in his middle age, and at the late life, what he is. These are elderly people, no doubt, but they are ruling nation. They are the leaders of different countries of the world, and they are the heroes, celebrities. They are making us laughter, giving joy, many things to us. Still, after the age of 65, what you call elderly age. Religious leaders also. But the journey of the life is completely different. Why? You can see it starts with a green leaf, but ends with a very brown and puckered leaf. So this is the journey of life. It is just like this. Some people, they think that aging is a disease. No, this is not a disease. This is a natural, Mr. Chair, this is a natural process of the physiology which we have to test at any person who has got money and who has got no money, no matters. You have to test the age of your life. It starts and ends in the grave or whatever may be. What is the global position, Honorable Chair? The global position, you can see the geriatric demography going so faster. In 1900, it was less than 1%, which has turned into 92 years after 6.2%, and projected in 2050 almost 20%. So every 5 people, you will get 1 person who is having geriatric age or 65 years and older. You can see by 2025, 2030, 35, 40, where the more darker area, United States, China, but India is below this higher age group projected value. But still, we should not keep ourselves quiet. We should be very enthusiastic from now, because what is going on, that we should address those people to take care. The two issues are very important. One is the frailty rates, it is decreasing, and the life expectancy is increasing. So these two are very, very important. And you can see that developing countries like Bangladesh and India have been included among the 20 countries of the world who will experience high number of aged population. These two low middle income countries are included in those. And if you see this slide, the 65 years old age group is crossing by 2020, and the 5 years, that means we are not taking 2 children, 1 children, even 0 or minus population is going on. Despite all this, our number of population is not decreasing. The life expectancy, you can see, the life expectancy has increased globally. If you check the arrow area, 71 to 75, the female are long liver, the male are dying early, but still almost the world population are same except the African region. This slide is very important for one reason. If you see, I think there is no light over here. You can see that the pyramid, with the 50 years, it has been changed to some other shape, but in projected 2050, this will be a tunnel shape on the top. That means the elderly age group will be more. Oh, thank you very much. The elderly age group will be more. So this change of 100-year century, this is giving us a big issue. Next. Yes, I have seen this, shown this to you, that these are the population of the world. When I am talking before you, just 2 days back, on 15th of November, the world population become 8 billion. I repeat, 8 billion. So it is projected that by 2100, the population will be 10.4 billion. And majority of the population will be elderly. So we are concerned with the elderly population. And you see that China, India, and Bangladesh, they are among these large population countries. So let us see, I'm talking in India, let us see what is happening in India. You can see that, let us come to this point over here. Elderly population in India was 8.6% in 2011, which is 10.1% in 2021, just the last year, and the projected is 13.1%. This is going on, the elderly population, and this is the figure. This is the picture that India is experiencing, huge number. What about the Bangladesh? Yes, Bangladesh, the same picture. You can see there is a very tummy-like figure over here, and by 2050, it will be like this. I told you before, so I'm not repeating, that Bangladesh is one of the 20 countries, those who will represent 44% of the world population. As you know, India has got 1.4 billion, China has got 1.4 billion. So the world's almost 44% population, including India, Bangladesh, China, Indonesia, and many other big countries, it is 44% they will represent. That means the Asia. Let us see the China. China from 1950 to this date, 2020, you can see where they are. Where they are. just more than double, 17.4. This is the elderly population. In United States, they are almost flat. They had the elderly population before because they had the ability to rear up to take care those population. If we compare the India and China, just see there here, 2019 to 2022, the population increase is 0 in China, but still it is very high. Also in India, almost it is 0.6, but still it is the higher population number and is very high. If you compare Bangladesh and USA, because USA's population is just double of Bangladesh, but still you can see that we have 1.08%, 22, but they are having the decrease in number, but they cannot control because of the old people are still surviving than the expected age. Between China and India, I think the Chinese, their number is much higher. Old people has been classified again into 3 sub-classification. One is young old. I think all of in this room, those who are in elderly, including myself, young old. Middle old, 75 to 84, and more old is 85 plus. So 85 plus people are, you can see the demography of geriatric population in different countries are different. You can see this, they are the first world and they are the third world countries. Still at this age they are working and they are making leisure and enjoying their time. Still, this is India's picture, Bangladesh picture. These people at their old age, still they are working. These are the issues and these are the concern. The issues facing by the elderly are loneliness, insecurity, poverty, discrimination, abuse and health issues. I will not go into the detail, just few words. Loneliness leads to depression. So many things there are, and you can pass your time with books if you are educated. Insecurity from the family. This is very common in our this subcontinent, and they can't earn money, so they don't have, as because they cannot earn, they don't have any money. Discrimination in case of job. When an elderly person apply for job, obviously the younger is encouraged, not the elder one. So social and job discrimination is very important issue. Abuse in the family, it is common. We do not know, but it's a very important issue one should address. And the health issue, you know, these are the most important. Hypertension, diabetes, CVD, ischemic heart disease, these are the issues. Geriatric patients are coming to you. You like it or you don't like it, no matter. So they are coming. So we have some responsibility. What to do? Our responsibility to care this, and we need to protect the elderly population because they have immense experience. They provide a vital generational link and support stability to the family and society. But are we doing this? This is a very important question for today. Contributing towards bringing the better human being and responsible citizen, the elderly people are very much needed, so we should take care of them. So family has got the first responsibility. What the family is doing, this is the picture not available nowadays. In one family, this is a joint family. Now this is the nuclear family. We too have to, nothing more than that. And cornerstone in all human society, again in the United States or in any Western country, they are thinking again they are going for planning for. Again, that joint family is better than the nuclear family. Our joint family, they take care of their, even you can see that they are enjoying the touch of the children or whatever may be. So this gives a family bondage, and we can take care of the seniors. According to the rituals of different religion, they are taking care of their elderly. So elders have their own expectation, and they think that now I am old, but I was boss once upon a time. So they have their own issues. So they think that nowadays families are fragmented, but definitely the fewer young family members will be available in the family. That is why we are very much concerned about the elder. Elder also, they want some adjustment with the new culture. And ego problem, that is another issue. Some elder people, they think that I am the eldest person, so what I will say, that is the final. So it is not true. And also sometimes very difficult to accept the decision of their son. Obviously, this is the point that the elder have their own issues. What the society is doing for the elderly? Society is behaving something like ageism, racism. They are not entertaining the elders. And the middle, you can see, they are saying you are old, you might have some disease, disability. So sometimes they are also very much scared. They feel I am useless, powerless. After some days I am going to death. So the right of the elderly are many. I will not go too much, but don't think that the elders means they don't have anything. They have the right to be treated as a person, to have a good future, have fun, be romantic, and also be respected and prioritized. Society has got a responsibility towards the elder. Definitely, they should take care of the daycare center, medical aid and economy, welfare scheme, which is not available too much in our region and in our country like Bangladesh and India. What is happening? We are glorifying the youth. So, modern digitalized lifestyle has resulted in the diminished social standing of the elderly. So what to do? If we want to give some respect and also to use the elderly, don't say you are useless, ineffective. In that case, we can use their experience. This is a big question, how to overcome this situation. What the government is doing. Say, for example, in developed and developing country, you can divide into two. In developed country, there is social security for the elderly. They get some money from the government and the rest of the life, as well as the gratuity from the job and everything. They can pass a very nice time. I have shown you the picture. But what is happening in our country, like developing country like India and Bangladesh? The government officials, they can get some gratuity money from the job. But what about the rural people? They are not getting anything. Very little number and very few amount of money is being allocated, as in our Bengali language it is called Boyoshko Bhata, means your elder age some money, which is so negligible, this is of no use. So there is a big difference between the developing and developed country. So we have to overcome that. Last but not the least, the role of physician. When they are coming with ill health, what you are doing for the elderly? Are you taking proper care, proper history, and soft spoken to the elderly? Very patiently, you are listening to the elderly person? Yes, this is needed. They are expecting that when I am in hospital, I must be properly addressed, and you should be very careful about the nosocomial infection. So the time to act is now. Mr. Chair, in every level, national, political, cultural, sports, economy, arts, teaching, science, we see that I have shown you the picture before. The elderly are conquering the nation. Also, they are the celebrities in cinema, in arts, and everywhere. So we have to respect them. So our take-home message is, young generation should remember that they will older someday in the same way. Aged population are the backbone of the nation. Aging is not a disease. We should respect the senior citizen in terms of experience, knowledge, and attitude and skill. Elderly people are part and parcel of the society. Elder people have the same right as others. Elder people should adjust, accept, and adapt with the change culture and modern digitalized life. We are proud to take the responsibility of the big burden of the huge number of elderly population. And with this, I conclude here, Mr. Chair. You see, these are the new leaves, these are the old leaves, but this looks very beautiful that the elderly and the younger are living together. Thank you very much, ladies and gentlemen.
Thank you so much, sir. It was an excellent deliberation, and this is the time to act for the elderly people, because in India, its elderly population is around 10.1% in 2021. And this is a whole responsibility, not only the government, but the whole societies, and being a physician. So we should also take care of the giants of geriatrics. As you know, the giants of geriatrics is the main problem with the elderly people.
Yes.
Yeah. In India, earlier it was the 65-year age, now they have increased it. And in India, the government is also providing the geriatric population special care.
Should be.
Yeah, they have started the post-graduation in geriatric medicine also. So I think it's a...
The floor is open. So if not, thank you, sir.
Okay, thank you very
sir.
much.
So,
Thank you.
So after listening to the problems of the aging population, we have another interesting lecture, that is adult attention deficit hyperactivity disorder. So for that, I invite Dr.
discussed much among psychiatrists ourselves. In fact, we do not have a chapter of adult ADHD. So I was very surprised that I got to speak on this chapter. So first of all, I'll say that usually ADHD has been known as a disease of childhood. But now we know that there is a spillover in adults also, and there were certain cohort studies which have been done in England, in Brazil, which actually showed that adult ADHD can arise de novo without any symptoms being present in childhood. So if you look at this chart, most of the cases are spillover from the childhood. There can be adult onset ADHD where we do not have any symptoms in childhood, and there can be a true adult onset ADHD where due to neurodegenerative conditions, symptoms of impulsivity, hyperactivity can arise de novo. What we know is that if you can look at this chart, that ADHD is most prevalent between 6 to 12 years of age, and after that it gradually abates as we become adults. Also, if you can see in this chart that combined and hyperactive type of ADHD predominates more in childhood, and later on as we become adults, the inattentive type and the mixed type of ADHD, combined type of ADHD is the one which becomes more prominent. Overall, the incidence decreases, but around 5% of the adult population also keep complaining of symptoms of ADHD. Excuse me. Yeah. ADHD is a problem of the prefrontal cortex. You have a typical trio of inattention, hyperactivity, and impulsivity. The symptoms arise due to inefficient information processing in the prefrontal cortex. You have the inattentive symptoms where you have problems with sustaining your attention. You have executive dysfunction, which is related to dorsolateral prefrontal cortex, and this is a new concept that is coming up. And to understand ADHD and to diagnose it, you have to understand the pathophysiology that lies behind the dorsolateral prefrontal cortex. Also, many times you have seen that family members come up and says he can give attention to things which he likes, but when I say something, he doesn't give attention. So you have to remember that there is something which is also called as selective attention, and that is again subsided by a very interesting area which is called as the dorsal anterior cingulate cortex, and that is also intimately related to especially the adult ADHD and not so much in the child ADHD, which is the major difference between child and adult ADHD. So to summarize, you have the dorsal anterior cingulate circuit, which is for selective attention, the dorsolateral prefrontal cortex, which is for sustained attention, the impulsive symptoms, which are from the orbitofrontal cortex, and the premotor motor areas where the hyperactive symptoms are present. And usually in adults, you see a mix of these symptoms, and predominantly in adults, the DACC and DLP-FC is the area which is more inefficient. As you can see, the orbitofrontal cortex is intimately related to the limbic and motor areas also. That is why ADHD has to be understood that this is a very, ADHD is a condition which has comorbid other psychiatric illnesses, a lot of them. In fact, a lot of time clinicians say ki we thought ki this was ADHD, then now the presentation is more of anxiety and depression. What you have to understand is that ADHD by nature has a lot of variance. You might have symptoms of anxiety, depression, you might have symptoms of ADHD, and in adults, they usually mix up, and for proper management, you have to look at both the symptoms and most of the times treat them simultaneously also. The executive functioning and the inefficient tuning of information processing in prefrontal cortex If you talk about, we talked about the neural circuits, the principal neurotransmitters which are involved are the norepinephrine and dopamine. There are other neurotransmitters which are also now being seen to be implemented, especially the ascending reticular activating system, and some other neurotransmitters, but principally the norepinephrine and dopamine are the circuits which are primarily responsible for the ADHD disorder. Also to understand the pathophysiology and later the management and why there are so many other comorbid symptoms, what happens is there is a tonic firing in the prefrontal cortex of both dopamine and norepinephrine. So in ADHD, once these neurotransmitters are less, we have a proliferation of the postsynaptic neurotransmitters also. And these proliferation of the postsynaptic neurotransmitters lead to problems with anxiety, with depression, with oppositional defiant disorder and other comorbid conditions that are frequently present in ADHD. For diagnosis, you have seen this criteria that we take the DSM-5. There is a difference in DSM-5 and DSM-4 which you used to have before. What DSM-5 has done is it has started recognizing adult ADHD. And now it says that for diagnosing adult ADHD, you do not need to have 6 symptoms of inattention and 6 symptoms of hyperactivity. In fact, you might be having 4 or 5 symptoms and still you can make a diagnosis of adult ADHD. Earlier, the age criteria was that there has to be some symptoms present before 12 years of age. This has also been now slightly given leverage, and now we consider adult ADHD as 17 years and older. The other criteria, which I'm not going to go into detail about, like mild types, moderate types, severe types, where all the ADHD symptoms are present. What we see mainly in adults are inattention and the combined types of ADHD. Here is the summary of the DSM-5 criteria, where these symptoms you have to keep in mind. To make it more simple, what you have to understand is people with ADHD have problems of inhibition, they have poor self-control and executive dysfunctions. The manifestations can differ. They have problems in school. Now we have problems with offices and sustained attention. Hyperactivity, simply understood, is the brake is off. You'll see patients who will keep on doing certain activities. Once they start talking about the subject, they do not know when to break. Sitting quietly in adult actually does not root out hyperactivity, because as I said, in adulthood, you develop less motor symptoms. Impulsivity, doing something without thinking. A lot of time, the family member says, "Ye kuch bhi kar dete hain." If something happens, he would be distracted, and these patients are very good beginners, but they have a lot of problems in finishing their tasks. So you can understand why even with normal IQ, with good IQ, these patients have problems in doing good jobs. So the concentration problems in ADHD seems to involve the inability to focus and to give attention appropriately. The problem is not that the patients of ADHD do not know what to do, but the timing for them is mostly wrong. In between a meeting, if some idea comes, they are unable to stop themselves, they'll blurt it out, and this is how it happens. The problem of poor self-control happens a lot of time. You can actually imagine a small child doing something and an adult doing similar things, getting fidgety, restless, would become more and more obvious, and he would be embarrassed, and the problems is happening. Executive dysfunction is you know what to do, but to effectively plan it, to do it, and when to stop when you're doing is a problem in these patients. Most of the times we understand ADHD, okay, these patients are on the go, they have motor hyperactivity, but again, why these ADHD patients have, if a diabetic patient has ADHD, you see a lot of time that they are not exercising. That's why they have like comorbid so many other conditions. They do not remember to take their pills. They are very good at doing tasks like spending time on the internet or surfing the smartphone, but telling themselves that I need to exercise every day, I need to go do 5 kilometers, or this other things I need to take, this is a problem for them, and that is why medical comorbidities are also worsened in a patient has ADHD. Also, many times this is also seen, rejection sensitivity dysphoria. It is ADHD patients have expectations from themselves and from their family. And once this is not met, they have extreme rage, and many times they are not able to control it. This comes out as violent behavior towards your colleagues, your spouse, or even towards themselves. And then these patients sometimes get confused with personality disorders also. So you have to understand that this is also seen a lot in ADHD. So poor self-management related to time planning and goal, problems with organizing yourself, poor self-discipline, poor self-motivation and activation, and all this can lead not only in problems with daily life, with comorbidities also, with medical problems also. And if you talk about domains of impairment, they have impairment in all the domains. Again, as I said, there are a lot of variance seen in ADHD. At one point of time, there will be more problems with certain areas, at other points of time, problems with other areas, and this keeps on happening. What the patients of ADHD lack is they do not have what we call it as mind's eye and mind's voice. They do not have hindsight. They tend to commit the same mistakes again and again, and they do not even have foresight. What happens is to plan effectively, because of executive dysfunction problems, they cannot see what my actions today is going to cause me doing tomorrow. Suppose I was seeing one person like selling credit cards in the airport. What will happen with an ADHD patient is, if he likes something about that credit card, he'll again take it. He'll end up getting 10 credit cards without realizing trying to save money. The opposite is happening because that impulse that's come, that is not being able to stop. So they are very, very poor planners as regard to money and management. I've already mentioned about comorbidities. In children, you have these kind of comorbidities. Slight change in picture. In adults, you have a lot of mood disorders, anxiety disorders. Nicotine addiction is a lot in ADHD, more than half the persons, because nicotine is supposedly activating and they can be actually used as self-medication. And the studies been done which have been shown that anxiety, depression, drug abuse, behavioral and personality issues, and as I mentioned, non-communicable diseases are also more common in ADHD patients because of the lack of motivation to follow through. So, and if they have non-communicable diseases like cardiovascular illnesses, diabetes, hypertension, they tend to manage it also less poorly. I've already mentioned about this circuit, how the ventromedial prefrontal cortex linked to the limbic system, which is the emotional area, and that is why you have so many comorbid other psychiatric illnesses also in ADHD. Keeping this in mind, the diagnostic criteria can be very, very much simplified. If you can just ask the patients 3 questions, one from each domain. First question could be, do you feel restless? This is like hyperactivity. With adults, usually complain of restlessness rather than frank hyperactivity of running around. Do you generally feel impulsive? Do you do the first thing that comes to your mind without thinking about the consequences? Or do you generally have problems concentrating? If the patient says yes to these, and if he says that this problem has been there from lifelong, you have to be suspicious about ADHD. If it is situational or if it has just come for some time, that could be bipolar. This is also one of the ways where how you can differentiate other comorbidities like bipolar illness, but personality disorders from ADHD. This chart has been given by Sandra Cui, who's done a lot of work in America on adult ADHD. If you now start suspecting with the clinical symptoms and these rating scales, then you have many rating scales which you can use, and these are easily available on the internet. You can use the adult self-reporting scale, the Connors adult ADHD self-report scale. Russell Barclay has written a very, very nice book on adult ADHD, which is a must read for anyone who is interested in ADHD or who or their relatives suffer from it. I have this as a PDF with myself. Anyone interested, I can provide this book to them. You can ask your psychologist. These are 2 very, very simple tests that can pick up problems with attention and selective attention. One, which is known as the Stroop task. Here, like you can see that the colors and the spellings are mismatched. You are supposed to read the colors and not what has been written. If anybody wants to attempt this test, like ADHD people have a lot of problem with this test, and this focuses on selective attention. The other test which the psychologists do is an N-back test. It is, again, what happens is you are flashed a number. You're supposed to remember this number, and then the next number is flashed, N1, and you're supposed to tell the previous number. It is easy for us, but a patient with ADSD does very, very poorly on these two tests and gives an indication for ADSD. How do you manage it? Obviously, a lot of time when you tell the patients you have ADSD, denial, as is common with psychiatric illnesses, is present, but a lot of time they have a sense of relief and joy, ki, okay, now I understand why I'm having these kind of problems. But as I said, since they are very good starters and very poor followers, so this is just the starting, and management requires a lot of psychoeducation. In fact, ADSD is one condition where a personal guide or mentor is needed. Many times when I treat the patient, I psychoeducate one family member and designate him as his mentor. And if he's okay with a counselor, it's not that counseling should be done and finished. He should be daily connecting with the psychologist. Instead that there was one Sigmund Freudian way where we used to go into past life. In ADSD management, here and now problems have to be prioritized, and there has to be frequent visits to the therapist and the psychologist also. Then obviously medications. ADSD is a very, very nice condition to treat because 70 to 80% of patients show very good results with the medications which we have with ADSD. And if medication and mentoring is done, and if the patient practices regularly, you can have very good results with ADSD. In fact, better results than have other psychiatric illnesses also. The focus should be on educating. And ADSD patients are, they want so much of information about the patients that you will be actually exhausted with this. The psychiatrist has to be supportive. I'll give you an example. Like I remember one patient, you're supposed to come to me at 12. He came at 2 o'clock when I was about to leave, and he runs and asked him what happened. He says, time pe to nikla tha. But on the way, I found that there was this guy who's selling tarot cards and he wanted to tell me why I'm having the problem, so I stopped. Acha, phir kya hua? Did it take 2 hours? No. Then I saw a friend coming. We decided we'll have tea together. So this distractibility is there. And once he comes to you, if you say, no, my time is up, I will not treat you, he has that rejection sensitivity. That's why with ADSD patients, you have to be very supportive, you have to be accommodating, and sometimes make sort of small concessions for them for having a better treatment outcome. As I've already mentioned, the treatment should be goal-oriented and solution-focused. There are many websites which provide good information about ADSD. If it becomes exhaustible, you can tell them that they can refer to the child and adult ADSD scale, the ADDA warehouse and all. These are available on the net free of cost. Lastly, I'll come to the medications. We have the stimulants and the non-stimulants. In India, we have only availability is of methylphenidate. The methylphenidate comes as an immediate release and a sustained release population. With immediate release, the problem is that it acts for only 3 to 4 hours. So you need to give the medications for 3 to 4 times. And because you're giving these medications frequently, sometimes anxiety builds up. The only thing you need to do is get a cardiovascular checkup done, because these medications may give a transient rise to blood pressure, otherwise they are very safe. Sometimes in adults, besides anxiety, psychosis is precipitated, so you have to start low, go slowly, maybe take up to a month for these medications to build up the dosage. The dosage is usually 40 to 60 or around 1 to 1.2 milligram of kg of body weight. The other treatment is the non-stimulants, and principally in it is atomoxetine. As I said, atomoxetine, what methylphenidate does is acts mainly on the dopamine pathway and secondly on the norepinephrine pathway. Here, opposite happens. This acts more on the norepinephrine pathway, but norepinephrine itself increase leads to, as I said, there was a tonic presence of dopamine and norepinephrine, and this receptor sensitivity when it goes down. So secondly, even atomoxetine helps calm down that dopamine pathway. So both of them are effective. In fact, atomoxetine can be better if the patient has secondary comorbidities like depression and anxiety. Atomoxetine, interestingly, was an antidepressant, which was not used much for that indication, but it came to be used more in ADSD. You have other agents also like bupropion tricyclics, which target both the norepinephrine and dopamine pathway. In the tricyclics, we choose agents which are mainly norepinephric for treating adult ADSD. Guanfacine again is not available. Clonidine, which acts on the alpha-2A receptors, also increases norepinephrine and helps in ADSD. In patients who cannot tolerate the other two medicines, this could also be an option. Last, to summarize, ADSD is a difficult, it's considered to be a disease of childhood, but now it's been understood that adult ADSD is a substantial condition which we are now gradually getting aware of. It is a difficult problem because there are a lot of variants and there are a lot of comorbidities. But if you treat it well, the results which we get with ADSD are excellent, in fact better than other psychiatric conditions. Thank you.
Thank you so much, sir. It was an excellent deliberation. A very simple question, sir. Being a physician, the patients comes to the physician and they think of that there is two conditions in the psychiatry. And I think you must agree with me that more than 80% psychiatric patients are being seen by the physicians. So they know the only two things. One is generalized anxiety disorder and other one is the depression. So how will you differentiate? Because as you shown in your slides that in psychodiagnosis you have to ask the three questions. So people are answering the same thing in the generalized anxiety disorder. So how will you differentiate between this adult ADHD and the generalized anxiety disorder?
As I said, generalized anxiety disorder is free-floating. All right, you're worried about certain situations. Okay, I'll not be able to do well in this. Okay, exam is coming, what will happen? Or suppose you start feeling restless because of certain situations, or you keep worrying about small things and you build it up. In ADHD, this doesn't happen. In ADHD, that inner restlessness planning, that has been there right from the beginning. It's not the things or the situations that bother you. Your executive problems in any situation is the problem. All right, so that is why. In depression, especially bipolar depression, because depression is clear-cut, you can make out sadness or mood, the patient is down. Bipolar is a differential diagnosis which is often missed, but in ADHD, as I said, have you often had this or have you had this always? Whereas bipolar, especially manic episodes, are discrete, they'll happen suddenly, there'll be a definite change in mood which will be perceived by the patient and the relatives also. Whereas ADHD is more of a continuous illness.
Thank you. Any question from the house?
Dr. Anurag, I was just looking for one slide. Is there a sex predilection for ADHD adult onset?
In childhood, we say that the sex ratio of males to female is 5 to 4 is to 1. 5 boys is to 1. This abates a bit, but even in adult ADHD, you have a ratio of 2 is to 1. Matlab more in males as compared to females, but less skewed as compared to childhood ADHD.
Thank you. Any other questions from the floor?
Yeah.
If not, we thank you.
Thank you.
And to move ahead, we invite our next speaker, Dr. Alok Modi. Dr. Alok Modi is a senior consultant physician from Mumbai. He has done his master's from Sage JS Medical College from Mumbai, and he cleared his USMLE in 1993 in the first attempt and did his critical care from US after clearing his US medical licensing exam. His topic is how to get smart in your clinic with smartphone. So that's another interesting talk, and he would probably be the right person to address this issue because probably he must have seen this much before in US then coming to India. So over to you, Dr. Alok sir.
So at the outset, I would like to thank Anuj sir, Amit sir, the organizing committee of ACP for giving me this wonderful opportunity at the seaside. It's a lovely venue and it's late in the evening. Lots of people are busy for tea and coffee. So my talk will be a little different. I'm going to be doing a talk which is going to be no PowerPoint, no classic medical talk, but I'm going to talk about something which we all use but we don't use, which is a smartphone or a phone that we all have in our pockets and which we use as a walkie-talkie just to make phone calls to friends and relatives and patients in our hospitals. We don't do anything more than that. There's a saying in computer science which says that Microsoft Excel, 80% of people use only 20% of the features. This is not called as a phone, it's called as a smartphone. And trust me, it can replace your entire hospital, it can replace your entire secretary, it can replace your entire clinic, it can replace your entire library of books and journals. You can do so much with your phone. It always amazed me that we spend 80,000 to 1.25 rupees on a phone and we just use it to talk, which you can do in a phone which costs 5,000 rupees. So what is a smartphone? We conduct workshops on this and we've been doing it for the last 5 years with Dr. Kulkarni and Apicon. It's a 1-hour workshop which I'm again taking in January. So I'm going to be very short and sweet with just few apps. I'll be a little outside the medical lingo to make life easy for all of you. So we'll start with certain important topics. As you can see, I'm handling the entire presentation from my phone, which is wirelessly connected to the laptop. I'm mirroring my phone over here and I'll be showing you the apps and there'll be no PowerPoint, I'll be doing a live demo. So let me start with the first app, which is a QX Calculate. Now this is a very wonderful app. It gives you all the calculators in the entire human body. And this is something which we use day to day in our day-to-day lives. So let me show you some few very important calculators here. EGFR is something we all use it in diabetes and many other illnesses. We commonly use multiple formulas out there. We use this Cockcroft-Gault formula. You generally make the patient spend some 250 rupees to get it done from the lab. It's difficult to get a EGFR done in your own bedside clinic. Very simple. I have a patient which is a male patient. I have his age as 47. I have his weight which is probably 74. I have a serum creatinine which is probably 1.2. This is my EGFR 79.65. Zero money, less than 5 seconds. You have your EGFR in front of you. You can choose the dosages of your various drugs, anti-diabetics, whatever you want to do. One very simple formula here. You have the MDRD EGFR formula here. You have lots of formulas in the infectious disease formulas. You have cardiology formulas over here for atrial fibrillation. You have the risk scores, you have heart failure scores, you have syncope scores. Okay, you have general medicine formulas here. You have basic calculators here, which is your BMI calculators, lean body weight calculators, weight-based medication dosing, something which we all need very regularly. So choose the patient's weight. Let's say the weight is 74. Dosages, let's say you want to give probably 4 microgram per kilogram body weight. You want to have the amount probably, let's say 40 milligram. Volume is around, let's say 100 cc. You want to give a PID dose. You want to give daily. You can choose what is the right formulation that suits you. So it's all there at your bedside, at your clinic side, very easy to use, very practical. Let's come to this infusion pump, which we need in the ICU. We calculate for dopamine, dopamine, insulin, a lot of noradrenaline, which we use. We generally tell our intensivists and our RMOs to do it, but at times we need to have access to that. So we have a 67-year-old male person over here with a dilution of 8 milligram, probably noradrenaline. And I want to give a dose of, maybe around 9 microgram per kilogram per body weight. So all I have to do is make a phone call and tell the concerned staff in charge of the ICU to keep the pump at 4.1 ml per hour. So you don't sit down with a piece of pen and paper and waste a lot of time calculating. It took me less than 2 seconds to come with the accurate dose and it's right in front of you. Okay, another practical thing, let's look at the ESC pocket guidelines over here. European Society guidelines, you have all the calculators which are required. You have all the guidelines which are required, all the messages are there, summary cards are there, all the congresses are synoptics over here. If you look at the congresses, you have their live videos, you have their PowerPoints, you have the ESC TVs over here. You can go through each one of them, build up your knowledge, read them, surf through them at your free time and get updated within no extra cost and no extra effort from your side. Look at the atrial fibrillation, Look at the pulmonary embolism guideline here. Let me go through. Let's look at the ventricular arrhythmia guidelines here. You can go through these guidelines. You can see the preamble, you can see the introduction, you can see the acute management of ventricular arrhythmias. It's all over here. All the charts are here, all the scores are here, all the guidelines and all the current flow of literature is here, which you can go through and pick up anything that you want to pick up with all the antiarrhythmics. Choose the scenario, choose the patient profile, and come to conclusions in a very accurate and a nice manner. Without going through multiple books, searching on the net, going through multiple links, downloading it, reading it. You can do it at your convenience even when you're sitting on the back seat of your car. Okay. Another very important app which is there for you, which is guideline app. This is a clinical guideline app which we use very practically, find it very relevant to day-to-day use. You get all the different kind of guidelines, as you can see, STEMI, non-ST myocardial infarctions, revascularization scores, TAP score, and these are interactive management issues. Let's look at the indications for this. You can have an interactive session, you can have a static section. You have a static section, you have the flowcharts, you have the guidelines, you can go to the links and go into the details of the guideline. If you're looking at an interactive situation, if the symptom onset is more than 12 hours, you feel there's a totally occluded infarct, are you planning to do a PCI? It's no benefit, it's a class 3 level indication. Very, very basic and very down to earth, very relevant clinically and highly evidence based. Okay, now let me walk you through some other things here. Okay. Medscape. Again, this is free. All these apps are free. I have not paid a single paisa for using any of these apps. Whereas to subscribe to various journals, to go through various literature, you have to pay a subscription. These are totally free of cost for anybody. Neither the apps cost anything, nor those subscriptions over here cost anything. This is something very useful over here. You can see all the drugs which are there. You can go through any drug in the market, go through the entire profile of the drug. You have the entire pharmacopoeia over here. You can go through the procedures that are relevant for any specialty of medicine, whether it's an ICU setting, whether it's a non-ICU setting. Go through any procedure, see the interactive videos and photos and the procedure in detail, and you can revise it whenever you want. You can go through a very beautiful thing called as interaction checkers. This is something which I find very relevant in our day-to-day practice. Let's see, we have certain drugs which we are prescribing on our patients, whether it's a diabetic patient, infectious disease patient, hypertension patient. Let's say I'm treating somebody with tuberculosis and I'm giving him isoniazid. Let me put isoniazid over here. Okay, I choose isoniazid. Let's say this gentleman has got seizures, I put him on phenytoin sodium. I choose those. I've got one interaction. I also want to treat him for tuberculosis, and I also want to treat him for a cough, so I decided to put him on the levofloxacin. I choose those. I got two interactions. What are those interactions? It's shown to you very clearly. What are the drug levels of each drug? How do you monitor? How do you manipulate? What do you do? What you should be careful about? In pregnant women and elderly people, a very useful tool for every patient prevents you from a lot of medical, legal, and potential complications issue. You don't have to sit and ask anybody. You don't have to go through any pharmacopoeias to find it out. When you're free, this gives you another beautiful thing in your free time, when you're driving your car or when you're sitting on the back seat. In this app, there's something called as podcasts. So a lot of conferences and seminars that are being held abroad, which are not available to us on a daily basis. There are a lot of discussions, clinical case scenarios, social interactions and medical science. A lot of things are available. You can just play any podcast, update your knowledge, get in touch with your colleagues outside the country and seminars which are being held in different parts of the country, and just get familiar with what is going on. So I've just touched over here. I was given 20 minutes. There's a lot of medical literature. Dynamed is another very beautiful app which is by American College of Physicians. It has practically everything. It has got podcasts, it has got calculators, it has got case scenarios, it has got clinical summaries. A lot of things can be learned. And the beauty of all this is you don't need a very higher-end broadband connection, though 5G is supposed to be walking in very soon by December. But then everything is there on a smartphone, and you don't have to have a Samsung or a HTC, or you don't have to have a OnePlus 50,000, 70,000 phone. These don't consume much of system resources. They can be taken very beautifully in a 10,000 rupees phone. So even your nursing staff and even your ground level staff can be given these things to use Your paramedical staff can be asked to go through these things, and it makes life very simple for everybody concerned. Now I'll move a little ahead from this. I will take you a little on paramedical side, but which is very relevant to our practice as a doctor, something which is called as medico-legal. Something which is on the rise, since I'm in the medical legal committee of AMC in Mumbai, and we see a lot of cases, so-called cases, which are because of various reasons, and we are all facing the brunt of the legality banging into our doors for no fault of us. For minor things, like you must be aware, so many cases have come in the National Consumer Forum in Delhi for lack of proper consent. So let's talk of a scenario where you want to put in a central line, or there was a very reputed senior intensivist from Hinduja Hospital who was recently taken to task for doing a pleural tapping in the ICU for a very fictitious and a very minor word which was omitted in the consent. And he could not prove that the consent was legalized in the eyes of the law. So there is a big need that we all face about recording our consents, whether it's a video recording or an audio recording. There's a big need that we face about our communication with our patient, which need to be taken care of and which should be acceptable by law. So have you people heard of this? When you call up Vodafone or Airtel or something, they say this conversation may be recorded for record keeping purposes and for training purposes. So you feel like you could record. The beauty here is, the non-beauty part here is, recording any conversation without the consent of the other party is illegal. Now you can't tell a patient, look boss, I'm going to do a cholecystectomy on you, and I'm going to tell you all the complications of cholecystectomy, and I'm going to record whatever you say, then you tell me whether you're ready to undergo or not. I'm sure nobody will be ready. So how do you go about it? In a legal manner, but you do it in a nice manner. So when I'm going to go ahead and do a procedure, or when I'm explaining a near-death consent, or I'm taking a consent for DNR, DNI, and I need it to be put it on paper, and I've done that, and I'll deviate from here, from today's topic, just letting you know one thing: the courts do not accept a pre-printed consent form. A very reputed urology center was in the limelight recently, I won't take any names, and they had to pay a heavy penalty for a pre-printed consent form which was signed, which the National Consumer Forum did not accept. So it is a practice in my hospital. I have a pre-written consent form. I change the name and the condition of the patient, and I change the type of consent depending on the scenario of the patient, and then I make them sign. And I always take a second consent in the native language of the patient, because there have been cases where they say, we did not understand what was written. So you make the patient sign in the native language. You don't have to know the native language. Like if I don't know Telugu, Google Translator is very much available. A beautiful app which is 95% accurate. Put up your consent on Google Translator, get it in the language of your choice, print it out, take a signature, and you're safe. Beyond that, you need an audio consent. It's there on your mobile, you don't use it. A lot of recorders are there. If yours is a Samsung phone, here is my recorder. Whatever consents I take are all recorded here. So I'm sorry. This is one second. Okay. So here it is. All my consent, all my recordings are here. They're all storable as an MP3 file. I can share them on my WhatsApp. I can share them to a Google Drive or a Microsoft Drive. I can share them wherever I want on the cloud, and I can store it, keep it in my PC for permanent reference after labeling it properly. So my consents are there and I'm secure. Now how do you go about the legality of taking to the patient's consent that I'm recording your consent? Now I'll give you an example. Suppose you lose the original agreement papers of your land or your flat, or there is a property which you had a cousin brother or somebody who could claim to a property later, but then that person is not available. What the law says is that you have to make a public announcement of what you're doing, right? Now, how do you make that public announcement? The very simple way to make a public announcement, as you must have seen in various malls and hotels, is this room is under CCTV coverage. This hotel is under electronic coverage. Put up a nice notice in a clinic room. This room is under electronic surveillance. If your patient doesn't say that is his problem, that's not your problem. But then you're legally safe, because you have told the person that I'm recording. You have not explicitly told, but you have given enough cues to the person that this is being recorded. Once you record it, you are legally safe. It has helped me, it has helped many of my colleagues, it has helped a lot of our colleagues, because once you produce a voice recording which is not manipulated with software, which the courts can make out through forensic medicine, then that consent is legally acceptable in a court of law. So this can save your skin many times. If you can do an in-camera recording, nothing like it, you need a higher-end hardware for that. Again, if you want to do a camera recording, apps are available free of cost on your mobile. You can put your mobile in your coat pocket, you can do a camera recording. Not difficult, right? I'll go beyond that, and I'll take on something which we all very commonly use in our day-to-day life, which is called WhatsApp. I'm sure none of us can survive without a WhatsApp. How does WhatsApp help in our own practice? Of course, we share photos and videos and we share a lot of patient-related information on WhatsApp. There is something called as business WhatsApp. How many of you know what is business WhatsApp and how many of you use a business WhatsApp? Is there anybody in the audience which is using business WhatsApp? So you all know what is a business WhatsApp. Business WhatsApp gives you a lot of leverage. Now my WhatsApp is a business WhatsApp. Now what is it? As you can see over here, you can see it's my hospital photo. So it gives me clear-cut advertisement, which is legally allowed because a hospital or a clinic can advertise, a doctor cannot advertise. So my center is getting advertised nicely. Moment a person sends me a WhatsApp, he gets this. Something which I do very regularly is this. The moment you send me a message, can I request Amit sir to send me a message right now? Okay, he sent me a message already, fine. So the moment you send me a message, you get this auto message. So I advertise very beautifully over here. I tell them these are my clinic numbers, this is my emergency number, this is my website number. Thank you for calling, you're welcome, and we will be happy to get back to you. It's an auto message. The moment you ping me, you get this automatically to your inbox and your WhatsApp. A very beautiful way to communicate without wasting your time and energy chit-chatting with the patient or doing it. You can modify the way you want. If you're practicing exclusive diabetology, you can modify it to suit certain emergencies in diabetes to be contacted where, what to do in certain hypoglycemic scenarios. Whichever way, there is no end to how much length of a message do you want. There's no end to how much material you want to write. It will shoot off automatically. Another thing, if you go into the settings of business WhatsApp, you get lots of tools here. These are business tools which they have written. You can put a catalog. You can write a nice catalog. You can show whatever you have, what kind of facilities you're giving, it's like a mini website. You can advertise as much as you want, and all these things will be floated to your patients, to your audience, free of cost, continuously and seamlessly. You don't really have to change your message. You can choose the quick replies, you can choose the away message, you can choose the greeting message. You can link it to Facebook and Instagram, and by putting this, you can directly get access. If you link your business WhatsApp to Facebook, whatever messages you put are pushed onto your business Facebook page whenever you want and as many times as you want. So that's the advantage of business WhatsApp. It's free of cost, it's very palatable, and it's something which works wonderfully. Even if you don't have a website, a lot of businesses are successfully running on business WhatsApp. So I'll encourage you people to consider this as an option in real life. The only hitch is, once you use your number for business WhatsApp, you cannot convert it back to personal WhatsApp. And you cannot transfer money on business WhatsApp, which you can do on a personal WhatsApp. Another thing which Meta or Facebook has recently, Facebook owns WhatsApp today, has introduced is something which is linked. Now, linked devices is something that I don't know how many of you use it. You can throw your entire WhatsApp on the computer. So if you have a laptop or your computer, you need not jump between your mobile and your laptop when you're working on your laptop. Your WhatsApp will run live on your laptop or your PC. You can type over there, you can put attachments over there, you can forward messages from there, you can reply over there. The way you work on your mobile will be workable on a laptop, and it syncs automatically. And previously they had to be on the same Wi-Fi network to run. Today that's not the case. The third advantage of a business WhatsApp, which is not there with a normal WhatsApp, is one business WhatsApp account can run on 4 laptops simultaneously. So you, your wife, and probably your colleague can do it at the same time, provided you want your wife to have access to your WhatsApp. Now that's a different scenario. So that's up to you. So that's another advantage of a business WhatsApp. Just as we have Zoom, you send a Zoom link, and you can sort of have 3 to 4 people conversing together in a room. Today you can send a WhatsApp link to 3-4 people, and you can have a same digital kind of an experience like a Google Meet or a Zoom Meet on a WhatsApp Meet, which is much more easier and down to earth and user friendly. Another app that I want to take you to, and I'll just take 2 more things and I'll stop over here. For people, amongst us, some of us are traveling very heavily, attending various conferences and going as a faculty. This is a very beautiful app that I've come across, which is not a medical app. It will be very useful to you guys. This is called Flight Radar 24. Okay? Before your plane actually lands, this app will tell you, before you get an official announcement from the airline or the service provider, this app will tell you if the plane has landed or not. So now I'm showing you the map of Mumbai. I'm showing you the map of Mumbai. This is a live thing because it pulls in from the air control. It's a legal thing. It pulls in from all the air control traffics, ATCs across the world. So right now in front of Mumbai, these are the flights which are spread over Mumbai. Let's pick up this flight. Okay, I need a good internet over here. Okay. Unfortunately, the net is slow, so I'm not getting all. These things need a huge bandwidth to get the data here. So it's showing NA versus NA because I'm not getting a good net. It tells you from where the flight is originated, where it is going, what is the current speed, what is the altitude. As you can see, it's 1390. It's showing you just 5 more minutes. It's showing you the actual altitude and the tracking sign and the angle and what is the ground speed and when it will land and what is the latitude and longitude. Believe me, the moment flight touches the ground, this is the first step to tell you before Air India or Vistara or anybody announces it to you. So very useful for your spouses, at least you can track what you're doing exactly in the air, right? Very useful for business people. A very important thing which I wanted to tell you is 2 things which is called backup. What are very important for us, SMS backup, WhatsApp backup, and our contacts backup. We need this because if you destroy your phone or you change your phone, this is the data that you can't live without. Don't depend on the SMS app which is available on your phone, which is inbuilt in any Android. Very useless app. This is a very beautiful app that I use. It's made by Microsoft. It's called SMS app by Microsoft. It classifies all your apps, SMSs into messages. It classifies all your bills which are going to come from electricity and telephone and petrol or whatever SMSs you get as reminders. All your banks SMSs that you get will be classified into finances, and you cannot enter them unless you put in your password. So they are private to you, and these are real life offers from Zomato, Swiggy and all that, and they actually work. Okay. So this is free of cost, and what is the beauty of this app is you can take a backup. You don't have to waste your time. It backs up to your Google Drive at 1 hourly interval or daily interval or whichever way you want. All your SMSs are preserved indefinitely. Just moves into your next mobile when you want. Only one thing I'll show you here is how do you back up your WhatsApp. A lot of people ask me, the moment I switch on my phone, I lose a lot of pictures and videos and messages. You don't want to lose all that. A very beautiful way to back up your WhatsApp is this. Very simple. Go into your explorer of your phone, go into your your phone operating system, go into a Android folder. Inside the Android folder, you have a media folder. Inside the media folder, you have this business WhatsApp, and I have got both. Got 2 SIM cards over here. So this is the .com.whatsapp W4B, and this is the .com.whatsapp. Just take this entire folder, push it into your PC or your memory card, put it back in the new phone, and then install WhatsApp. Everything right from 1920 or 1930, since you're running your WhatsApp, will come to your phone.
Sir, kindly conclude, sir. We are getting late.
Thank you very much. Like I said, we take workshop. It's done for 2 hours, so I just touched upon it. And thank you for giving me this opportunity. Thanks a lot to everybody.
I think listening to you was makeshift of the topic. It was like how Alok is smarter than the smartphone. So I think human brain is smarter than the smartphone. That is the first thing that you have proven. We all have smartphones with us, but we are not smart enough to use it. So any questions from the floor?
Yes, Buster. I have designed the entire software for the hospital single-handedly for my nursing home on Excel and Word, and it runs beautifully for the last 10 years. So I've saved around 2 lakhs of rupees. Yeah.
All the apps are available on the Play Store?
Yeah. So if you're going to use an Apple phone, the same developers give the same app on a iOS store. They charge you 400 to 600 rupees per app, whereas on an Android, it is 99% of the time it's free of cost, or you end up paying hardly 100 rupees or 150 rupees. But 90% of the apps on Google Play Store are free of cost.
Thank you. Thank you.
So if there are no more questions, we conclude this session, and I hand over the session to Dr. Divya Saxena.
In my hurry, I didn't do the right proprietyness. I wanted to thank at the beginning, I was stuck with my laptop. So thank you, Chairman, sirs, and the organizing committee and the dignitaries here. Thanks for giving me this opportunity. Thank you very much.
Thank you, chairpersons, and all these speakers for making this session a really interesting one and worth sitting here, leaving the beautiful surroundings of Vizag and sitting here listening to all these speakers. I would hand over the mic to the next moderators for the coming session.
very good evening to one and all gathered here. Let's move on to our next very ingenious and astonishing session. So regarding this, I would like to call upon the chairperson of this session, Dr. Jay Prakash Sir, Consultant Apollo Sugar Hyderabad, Advisor Swachh Andhra Pradesh Corporation, Government of Andhra Pradesh. I humbly invite Dr. Suresh KG Sir, Consultant Physician, Diabetologist, Manipur Hospital, Bangalore. And I request Dr. Vikas Kaushal Sir, MD Medicine, Consultant Practitioner at Kaushal Nursing Home, Punjab, to join the chairperson onto the dais. And I request to the chairperson to invite and introduce the speaker of this session. Over to chairperson.
Yeah, thank you. Good evening, dear friends. I have great pleasure to introduce my favorite physician, Dr. B.M. Makkar, very eminent popular physician and diabetologist from New Delhi, and is current president for RSSDA. And sir is very popular for organizing Cleveland Clinic's ASD workshops in the field of diabetes. Sir will speak on vitamin D supplementation and its impact on insulin resistance. Over to Dr. B.M. Makkar.
Thank you, Sai, for being a great friend, and good to be having you as chairperson. Okay, can you give me a follow-up? I'll just take a minute. I think they removed the laptop, so they are setting it up. So at the outset, I would like to thank Team ACP, especially Dr. Narsim Verma, Dr. Anuj, and Dr. Srinivas Murthy for this opportunity. And I'm really delighted to be here, first time in Visakhapatnam, and meet so many friends from all across India. On vitamin D supplementation and its impact on insulin resistance. This is a Alcom sponsored presentation, and this is my disclosure slide. So we all have been using vitamin D, and we all have studied vitamin D right from our college days, and we know that this is a fat soluble steroid hormone which mainly acts as a key regulator of calcium and phosphate metabolism, and is also involved in maintaining a balance between formation and resorption of bone tissue, helps in prevention of osteoporosis and occurrence of fractures. And now we know it has multiple roles, and it, after the discovery of vitamin D receptor, lot has been understood about vitamin D. And it is now, we also know that it is involved in regulation of genes involved in the bone modeling. Now, term vitamin D includes vitamin D2, ergocalciferol, and calciferol, which is vitamin D3, and it has two main metabolites, calcidiol and calcitriol. Vitamin D in humans comes mainly from the skin, synthesized by the effect of sunlight on ergocalciferol, and also from dietary sources where it comes as vitamin D2 and D3. And now, as I mentioned, we have discovered vitamin D receptor, and we see there are a lot of studies have shown that there is a presence of vitamin D receptor, the vitamin D hydroxylase in several tissues, suggesting vitamin D could be playing a major role in multiple metabolic processes and genetic regulation also. So this is the slide which shows the conversion from 7-dehydrocholesterol under UV light, which converts it to cholecalciferol, vitamin D3. D2 and D3 both are transported to liver by in combination with D-binding protein, where it is further hydrolyzed to 25-hydroxy vitamin D. And from there it goes to kidney, where there is one hydroxylation, making it 1,25-hydroxy vitamin D or calcitriol, which is the active form and is involved in increased calcium mobilization from bone, increased absorption of calcium in intestine, decrease in PTH, and also multiple other functions. Now, studies have shown that vitamin D may be involved in multiple non-skeletal functions, including the maintenance of normal immunity, normal functionality of the macrophages, activation of T and B lymphocytes leading to immunomodulation, by acting on the parathyroid, decreasing the PTH levels, improving the insulin resistance, by acting through kidney, suppression of renin and RAS mechanism, helping in reducing blood pressure, by action in pancreas, and also it has been shown to be, the receptors are found to be present in multiple tissues like breast, colon, and prostate. So there are now a number of studies which have shown that vitamin D deficiency may be associated with multiple diseases in multiple organs, including osteoporosis, different types of cancers, cardiovascular disease, hypertension, type 1 and type 2 diabetes, autoimmune diseases like rheumatoid arthritis and inflammatory bowel disease, depression, multiple sclerosis, and so on. Now, if we look at the vitamin D deficiency, it is widespread, widely present globally, and India also, we are not different from the global picture. We have very high prevalence, reported anywhere between 50 to 95% in Indian population, especially in young adults, pregnant, lactating women, and women over 50 years of age. This was a study from Dr. Amrish Mittal's group, published in 2010, I think, which looked at the global vitamin D status and determinants of vitamin D vitaminosis, and showed that overall prevalence in India is in the range of 10 to 20 nanograms per ml, which indicates that most of the Indian population is either deficient or insufficient in vitamin D levels. This was a study which looked at the vitamin D deficiency in healthcare professionals across different states, and again showed that more than almost 80% of healthcare professionals are also deficient in vitamin D. Now, I am basically in focused diabetes practice, and we were seeing a lot of people coming with vitamin D deficiency. So we did a small study at our center, looked at 296 people with type 2 diabetes and measured their vitamin D levels. And this study included 167 males and 127 females with diabetes, average age around 50 years. And we found that the average vitamin D level was 14.98 in the people with type 2 diabetes that we screened. And if you look at the breakup of vitamin D levels, only 8.5% had normal vitamin D levels, which is defined as vitamin D sufficient, more than 30 nanograms per ml. About 10% had 20 to 30, that means vitamin D insufficiency, and 80% were vitamin D deficient. Vitamin D role has become more clear after, seeing the, after discovery of vitamin D receptor. And now we know that vitamin D has an important role in regulation of glucose homeostasis in pancreas, in regulation of inflammation, maintaining a systemic normal inflammation, non-inflammatory state at systemic level, skeletal mobilization and metabolism. It has receptors in muscle cells, immune cells. So all these places are being looked at, important sites for vitamin D action. A strong association between vitamin D deficiency and both type 1 and type 2 diabetes, and studies have shown that supplementation with vitamin D can improve both type 1 and type 2 diabetes individuals, improve their glucose homeostasis. Vitamin D can directly enhance insulin sensitivity and it releases it from beta cells. It can increase the expression of insulin receptors in peripheral tissues, thereby improving insulin sensitivity, and also can act through the immune modulation, leading to increase or decrease in insulin resistance. So this is a slide which tries to explain the role of vitamin D deficiency. Now, how does vitamin D deficiency occur? So there are multiple environmental factors which include sedentary lifestyle, insufficient exposure to sunlight, or low dietary supplementation. But at the same time, we have epigenetic factors. There are genetic modulation or gene polymorphism affecting the vitamin D receptor genes, the D binding proteins, and the hydroxylase enzyme genes. And all these lead to development of vitamin D deficiency. Now, once there is vitamin D deficiency, it leads to impairment of beta cell function. It decreases insulin sensitivity or increases insulin resistance by decreasing the insulin receptor expression in muscle and adipose tissue, and also decreasing the expression of PPAR delta in muscles and adipose tissue, and also suppresses the adipose tissue growth and remodeling. Vitamin D also has been shown to impair mitochondrial function, thereby leading to increased oxidative stress. So all these things ultimately down the line affect beta cell function directly and indirectly by increasing the insulin resistance. Increase inflammatory process and increase immune activity leads to possibly promotes the destruction of beta cells, thereby worsening the beta cell destruction in type 1 diabetes. At the same time, it increases insulin resistance in addition to the other changes in the insulin receptor level, leading to increase in insulin resistance and beta cell dysfunction, contributing to development of type 2 diabetes. This slide further tries to explain various mechanisms involved in the type 2 diabetes, the obesity and metabolic syndrome, and also in the polycystic ovarian. So there are multiple pathways where vitamin D is acting, contributing to development of or worsening of type 2 diabetes, type 1 diabetes, metabolic syndrome, obesity, PCOD, and multiple cancers. Vitamin D deficiency may also be due to gene polymorphisms which affect the vitamin D receptor genes, the D binding protein genes, and vitamin D1 alpha hydroxylase genes, which result in increase in the peripheral insulin resistance and decrease in beta cell functioning. So if you look at the vitamin D receptor, it belongs to the nuclear family of nuclear receptor family, which is involved in DNA transcription, and studies have shown that there may be D response elements which have been identified in the promoter area of the insulin receptor gene, which are involved in the transcription control of insulin secretion. So this may be direct effect on the beta cell function. Then we know RXR or retinoid X receptors are ligand inducible transcription factors which form homo and heterodimers with other receptors, which include vitamin D receptor. And the vitamin A metabolite, which is 9-cis-retinoic acid, also acts as a ligand for RXR and is involved in the dysfunction of beta cell through vitamin D deficiency. Level of glutathione also has been implicated as one of the mechanisms. Then there are other mechanisms through which the vitamin D deficiency affects the increase in insulin resistance, and this can be due to the changes in the immunoregulatory function of vitamin D, which is compromised because of vitamin D deficiency, immunoregulatory function of vitamin D on insulin resistance, and through the effect on increase in inflammatory cytokines again worsens the insulin resistance. Then vitamin D may also be involved in improving the insulin secretion from beta cell through the calcium concentrations and calcium influx. We know that insulin secretion happens by increase in calcium influx into the beta cell, which is precursor to secretion of insulin from beta cell. And with vitamin D deficiency, this whole calcium influx may be impaired, leading to beta cell dysfunction. Vitamin D deficiency may have direct impact on beta cell function, as well as it directly increases insulin resistance through various mechanisms by decreasing the receptor expression at the peripheral tissues and decrease PPR delta expression at peripheral tissues. At the same time, it increases the pro-inflammatory state, which further worsens the insulin resistance. And there are studies which have shown that if we do vitamin D supplementation in people who have vitamin D deficiency, it improves the glucose homeostasis, and to improve the insulin resistance, the levels of vitamin D required are shown to be anything above 80, and 80 to 120 nanogram per ml levels have been shown to be beneficial. Now let us see some clinical evidence. This was a study which looked at vitamin D supplementation on oxidative DNA damage and insulin resistance in elderly individuals with metabolic disorders. So this study involved 92 vitamin D deficient individuals who were elderly were included in the study, and this was a randomized controlled trial where half the people were randomized to placebo. And further, these groups were divided into people with diabetes and people without diabetes, and all were given 2000 units of vitamin D supplementation on daily basis. Now this is the trial design, and if you see that supplementation with vitamin D was associated with significant increase in vitamin D levels both in people with diabetes or without diabetes who were given vitamin D supplementation, while the control arm, whether it was diabetes or non-diabetes, there was no increase in the vitamin D levels. Now, in supplementation with vitamin D and increase in vitamin D levels, especially in type 2 diabetes individuals, was associated with decreased oxidative damage to the DNA. And if you look at the metabolic parameters, I don't think you can see much reading, and this doesn't seem to be working. Can we have? No, this is also not there. So if you look at the fasting glucose levels, there was significant decrease in the fasting glucose levels in people having vitamin D supplementation. There was significant increase in the HDL levels, and there was significant improvement in the triglyceride to HDL ratio in people who were given vitamin D supplementation, showing significant improvement in the glycemic parameters as well as the lipid parameters. Another important thing was there was significant reduction in the HOMA-IR from 11.68 to 7.49, indicating significant improvement in the insulin resistance. Now, study concluded the supplementation with 200 units of vitamin D on daily basis decreased the level of DNA damage, especially when and the damage was better. The impact was better in people with diabetes as compared to people who didn't have diabetes. And vitamin D supplementation can reduce oxidative stress resulting from hyperglycemia, leading to increase in HDL, reduction in HOMA-IR, and improvement in the TG to HDL ratio. Another study which looked at 6-month vitamin D supplementation on insulin sensitivity and insulin secretion in a randomized controlled trial. Again, these were the people who had multiple metabolic problems, randomized double-blind placebo-controlled trial, single site, 1:1 ratio randomization, and people were given 5,000 international units of vitamin D daily for 6 months. Control group was given placebo. The primary aim was to look at the impact on insulin sensitivity measured as M value using 2-hour hyperinsulinemic euglycemic clamp, and the again, almost 48 patients in each arm, 96 patient total. And this, after 3 months, the study showed a significant improvement in the vitamin D levels, which was sustained at the 6 months. And if you look at the change, there was significant improvement in, significant improvement in the M value, which is the indicator of insulin sensitivity in people with pre-diabetes at 3 months as well as 6 months, and also in people with diabetes. And there was significant improvement in the insulin resistance. So study concluded that high-dose vitamin D supplementation for 6 months can significantly improve peripheral insulin sensitivity as assessed by hyperinsulinemic, euglycemic clamp, and beta cell function in these individuals. And these were the individuals who were at high risk of diabetes or new detected diabetes. This is a very recent study published from Dr. Anoop Mishra's group called Prevent Win Trial. This is published in Nature Scientific Reports in 2020. Looked at vitamin D supplementation in overweight and obese Asian Indian women with prediabetes and vitamin D deficiency. This was open label randomized placebo controlled trial for 78-week duration. 121 women aged 20 to 60 years with prediabetes and vitamin D deficiency who were overweight or obese were randomly allocated to the intervention and placebo arms, so almost 60 women in each arm. And at the end of, if you look at the change in the vitamin D levels, there was significant improvement in vitamin D levels over 78 weeks period. If you look at the right side at 78 weeks and you see the p-values, actually this pointer is not working. Can we have another pointer? Hello? Any other pointer you have? Anyway, so look at the p-values. So there is significant improvement in the fasting glucose. There is significant improvement in the significant improvement in the fasting glucose. 2 hours postprandial glucose. Fasting was done 10 hours, after fasting. Postprandial was after OGTT. Significant improvement in the values of vitamin D levels, and significant improvement in the subscapular skin fold thickness. And this actually is the same result shown in the graph. So significant decline in the fasting glucose levels happening post vitamin D supplementations at 78 weeks, and significant improvement in also the postprandial glucose levels. So study concluded that 78 weeks of vitamin D supplementation, vitamin D deficient Asian Indian women with overweight, obesity resulted in significant reduction in fasting glucose, 2-hour postprandial glucose, A1C levels, truncal subcutaneous fat levels, and reversal to normoglycemia. That was also higher in people with individual. So currently there is an ongoing real-world study on impact of vitamin D deficiency in insulin resistance in type 2 diabetes called Reproductive study. This study will be involving 400 patients from 40 sites and looking at the parameters of insulin resistance, vitamin D deficiency, and metabolic parameters in relation to vitamin D levels. To sum up my presentation, there is a strong relationship between vitamin D status and diabetes. A number of studies have reported improving diabetes control, improving beta cell dysfunction, decreasing insulin resistance, obesity, and metabolic syndrome with vitamin D adequacy. Evidence suggests role of vitamin D in pathogenesis of insulin resistance, including several vitamin D related gene polymorphisms and vitamin D related metabolic and immune pathways. Supplementations of vitamin D may provide a suitable option for improving insulin resistance and beta cell dysfunction and for improving glycemic parameters. So with that, I conclude my presentation. These are the various references that we have used. Thank you. I'll be happy to take any questions after this session.
Thank you, sir, for an excellent and very informative talk. take one or two questions.
Can you be loud, sir? Can you take mic? No, no. We in 78 weeks, the population involved was the obese, overweight women with D deficiency and pre-diabetes. They were not on insulin. They were not on insulin.
Sir, you have a...
Yeah. So, I am Dr. Sharat Kumar from Lucknow. I am basically endocrinologist.
Yes, sir.
So, we look at the vitamin D supplementation. It appears very exciting and very really impressive. But somehow, what do you suggest? Why it has not been so far incorporated in the basic guidelines of the...
Sir, there are so many factors for that, and I am sure you know better than I know. And I am surprised you are asking this question because you have been involved in this subject for such a long time. First thing is, till date, possibly we are not even sure what is normal about for our Indian population. We are not clear. These are the observational data that this is the, and we are using the Western cutoffs for defining sufficiency, insufficiency, and deficiency. So what is normal for Indian population, at what level we actually get into, the problems in terms of deficiency, we are not very clear. Second thing is, there is no strong data, no big trial, randomized controlled trial showing that if we do supplementation, it translates into significant clinical benefits. So there are only anecdotal data looking at all these parameters. And there are so many of them. It's not just diabetes, it is PCOD, it is cardiovascular risk, it is malignancy. Wherever you see, we are seeing vitamin D. But the problem is, can we use that data to form a guidance? I don't think we have reached that stage. So we just need more data on this.
Just as a corollary to that, a small comment that we have now started seeing a lot of patients coming with vitamin D toxicity. A lot of noise has increased in favor of vitamin D in last decade or so.
So actually you have raised a very important point. What happens is a person goes to general practitioner, gets a supplement which contains vitamin D. He is also being seen by orthopedic surgeon who is giving him injectable vitamin D, which to best of my knowledge, I have failed to understand why somebody is giving vitamin D injectable unless there is issue of compliance or patient is likely to be lost to follow. And if he is seen by third person, good number of times you ask them, vitamin D are you taking? They say, yeah, I take a sachet every week because my mother used to take. So there is so many times we are seeing vitamin D hypervitaminosis, and same we are seeing with B12 also. Everybody is giving B12. So we see commonly B12 levels in the range of 2400, 2600. But fortunately B12 doesn't cause toxicity, it does cause toxicity. So I always suggest my patients that if you have to be given vitamin D, supplementation, not the daily supplementation, a therapeutic dose, always look at vitamin D and subsequently follow up with vitamin D levels. Don't just keep on taking indefinitely.
Yeah,
I think that is important.
Yeah, thank you very much.
Thank you, sir. Thank you.
Thank you, sir. I think we'll wind up the session. We'll take a tea break now.